there was a base states were above 1 lakh. Creatinine was significantly increased. Was there at the baseline iron 1.8 increased to 1.8. There was significant increase in bilirubin. Albumin was low also. So this was a case of like cellulitis with chronic liver failure. Was treated with an upper GI bleed. Perspective. Patient was treated with meropenem, cocaine, infusion, terlipressin, black, pantoprazole, and petrol. The advice of nephrology, it was initiated and the were transfused during the dialysis. There was an improvement in his ABG pattern. Plastic surgery opinion is also practice and advised conservative. Upper GI endoscopy was done within 12 hours. It showed matter of blood in the stomach. There was total hypertension. There were no obvious in view of significant drop in hemoglobin with Malina. Upper GI endoscopy was to be repeated. Endoscopy was was there. 12 hours later was repeated. No improvement. In fact, the hemoglobin decline. Platelet also this time 4 units of dialysis, 4 units of and 4 random donor platelet. During thrombocytopathy, he was platelets. Rule out DIC. Repeat upper GI endoscopy. Fusions in gastric antrum. Colonoscopy. Sudden Malina. Just with 12 on for bowel preparation. Second day, hemoglobin marginally improved to 5.2. Platelets were get improved to 5.1. No hyponatremia. It was done daily. It was again transfused to dialysis, 2 units of FFP RDP. Angiography of abdominal aorta was done. Normal abdominal measurement was no evidence of was mild large bowel loops were dilated with mild mucosal enhancement, high density large bowel loops. All enhancement from the gastric wall, ascites, conventional angiography, significant vessel spasm with no visualization of vessels, but the visualized part was normal in force and caliber. On day 3, vasopressors were irritated, but were polymyxin was into PRRT was also in cultures were sent. There was no significant improvement in PRRT, had respiratory acidosis, lactate 2 units of PRP, and trans. Initially, we had a aim for conservative hemoglobin target with hypotension. The target was, you can see that INR has increased 1 point, settled down to 1.4. Bilirubin has also come down. Yet has also, but however, there was a progressive compared to pain. Bilirubin remains static above 7. On day 4, there was increased requirement of vasopressin. Platelets kept on increasing. Adrenaline ultimately lost this patient. This, this gives us the opportunity to take intervention. Intervention. Patient has a systemic sepsis, was not eligible for tips. As we saw that angiography and endoscopy, angiography was normal, angiography was also normal. Endoscopy there was a diffuse. Um, Such case.
Shailesh, this seems to like a diffuse mucosal bleed, probably in the stomach, and there is a strong possibility that the similar lesions may be there in the small intestine also. Considering the baseline status of the patient, like high MELD score, decompensated CLD, so this is diffuse mucosal bleed, stomach, and probably in small intestine also. When we talk of endoscopic intervention, a few important comments are there. Like, never rush for endoscopy. Endoscopy is a very important procedure. We cannot do it again and again. It's very important to stabilize the patient. What we could see in this patient, there were a lot of food material inside the stomach. It's very important to give injection erythromycin. If we give it in the dose of 1 gram, half to 1 hour before the procedure, the food migrates distally and the stomach is empty and visualized properly. A lot of time it happens that we miss ulcer or some bleeding lesion because of the presence of a lot of clots and food material also. Stabilization is very important. Endoscopic interventions in such patient, it may be in the form of argon plasma coagulation. When there is diffuse mucosal bleed, argon plasma coagulation helps. Of course, the option of endoscopic variceal band ligation, fundal variceal glue injection, and a lot of other, and sometimes a newer stent like Dennis stent is also there. When there is a patient is having refractive variceal bleed, there are covered stents, metal stents, which compresses and achieves tamponade inside the esophagus, and sometimes is life saving also. So stabilization is very important, and then we can do endoscopy. Second important thing, when the patient is actively bleeding, we may not be required to give proper colonic preparation before going for colonoscopy. So even without proper preparation, we can, because blood itself it is very strong purgative. It doesn't stay for a long time inside the colon, and even without preparation, also we can do colonoscopy in such.
Well, a couple of points I just wanted to discuss here, having gone through the case. It appears that this patient primarily becomes decompensated because of infection, and that was in the form of cellulitis, not have SB complaint, abdominal. There wasn't any significant amount of fluid. Probably this patient decompensated from which what existed in February, probably January. Infection was the primary one into tackled subsequently. There's a point which we discussed that should we be going ahead with angiography possibly such a event, especially when this patient had renal 5, 6 use, and then you're looking at contrast. perhaps it may not have given you otherwise also. If you look at the anticipated, what were you anticipating? Type of a endoscope this patient saw that had diffuse bleeding from the stomach, and perhaps he was bleeding because of coagulopathy and portal hypertension, gastropathy, both together, and low platelets contribute. Having said that, I would have not liked to do angiography in this patient because otherwise also the patient had more serious issues rather than, and one wonders as to what have happened to contrast induced concerning patient, especially when the creat level. Then comes choice of antibiotics. You were treating cellulitis. Started with marrow. Um, I don't know. I would have preferred.
Sir, his last attack on right leg, which was meropenem. Police team added meropenem.
So you were looking at a gram-negative sepsis. The subcutaneous infections, they are very commonly because of gram-positive. Klebsiella pneumoniae was there. Choice appears.
Geography, he was again.
These lactates, do they represent anything?
Usually raised in a patient of liver, but his baseline lactates were 3 and increasing. Fusion, perfusion.
Would have terlipressin added to it.
Because we see that in angiography there was a spasm in mesenteric.
Just one comment. Most of these patients of chronic liver disease have venous bleed also. One can consider portovenography in such patients. And if you can't identify the source of bleed, one can consider capsule endoscopy also in such patients. Because these patients may have ectopic varices also in duodenum or jejunum and distal small intestine also.
Thank you, sir.
You call IR, he says first do a CT angio. They will have some idea of that from which side it is bleeding, and then they will go for conventional angio. So I know creatinine was 5 in this patient, but can angiography be avoided in this patient, or you should go for it?
My point is, what were you looking for when you planned for angiography? That is the important issue. You did endoscopy in this patient. You saw that a patient was bleeding. He was bleeding because of portal hypertensive gastropathy. He had a diffuse bleed. You did find a source of bleed. You did a colonoscopy, and you saw that he was bleeding somewhere from either small intestine or probably stomach, and you already identified that. And then we are looking for angiography in the setting of a patient whose creat was 5.6. So my question is, what were you looking for in angiogram? Any answers?
Because we could reach up to duodenum in case of upper GI scopy. So we thought maybe he's having ectopic varices somewhere in small intestine, which might be bleeding, or some venous ooze, as you said. So
Definitely, it's a very difficult call whether to go ahead with angio or venography. So in the background of CLD, venography should also be done, because you may find a bunch of varix in the small intestine or bunch of collaterals which might be bleeding. If the patient is very high risk, then capsule can be considered earlier. But in the set, when you have such a massive bleed, one can go ahead with non, because capsule it takes another 24 hours for these results to come. So we can, if we want early, then definitely CT angiovenography will be helpful.
Thank you.
Thank you.
Thank you, Dr. Lute,
Yeah.
for such a wonderful case presentation.
Dipti ma'am wants to
Yeah.
ask something.
Patient did have Klebsiella grown during the last culture, but Klebsiella, also known to be carbapenes produce resistant enterobacteriaceae, could also be there. So maybe a PCT, did you do a PCT in this patient? Procal was not done, and maybe cultures, blood cultures would have helped you, that if sepsis was a cause for all this coagulopathy at this admission, and maybe a better antibiotic choice. The infection part is also, the choice of antibiotic is very important in these patients. So we see a lot of CREs, so we do a carbar and decide about the antibiotic choice also. So, since it was already a Klebsiella, so.
Just wanted to ask you whether you do push enteroscopies, because probably the major side of the bleed here probably looks like the small bowel, because in the large bowel we could just see some specks coming from here and there. Probably the small bowel is the major side of the bleed, and an enteroscopy probably, if I don't know if it's done here, but that maybe that was.
So these push enteroscopes were available routinely at most of the teaching institutes. Now it's not available routinely, push enteroscope. So now we have more of double balloon, single balloon, and spiras, which has been withdrawn recently. So it's very long procedure, very difficult to do in unstable patients. So before doing enteroscopy, we normally do capsule endoscopy to identify the lesion from where we need to go, from proximal or from rectum. So if the lesion is located proximally, we go from up, and if the lesion seems to be in the ileum, then we go from down.
So I think we close this case. Any more points of discussion? Thank you very much for a very interesting case. Deepak, congratulations to you for completing 16 years from my side, and my co-chairman, Dr. Amit. Thank you very much.
All in our practice, we are desperate to find the source, but it still eludes us. Thank you, chairpersons, for your wonderful insights. I now request the chairperson to please present a memento to Dr. Shailesh Lute. Shailesh. I now request Dr. Deepti Jaswani ma'am to please present a memento to our chairpersons. Sir. Moving on to the next session, that is physiology of coagulation, we would like to invite the chairperson, Dr. Prashant Govardhan sir, who is a physician and diabetologist in Nagpur, Dr. Dilip Shirsagar sir, who is a consultant chest and physician intensivist at Criticare Hospital, Nagpur, Dr. Bhushan Itkelwar sir, who is a critical care specialist in Itkelwar Hospital, Nagpur, Dr. Prashant Govardhan sir, Dr. Dilip Shirsagar sir, and Dr. Bhushan Itkelwar sir. In a sense, physiology is the central discipline of medical science. It is the business of the physician to restore normal functioning. Normal functioning is thus starting point in his thought and his goal in action.
It is my pleasure to introduce our next speaker, Dr. Samir Melenkeri sir, who is an expert in the intricate field of hematology, who will guide us through the complex yet fascinating physiology of coagulation. He is department head hematology and director of blood and marrow transplantation in Dinanath Mangeshkar Hospital, Pune since 2007. It will be difficult to enumerate Sir's achievement in the field of hematology. Sir has an impressive background with numerous publications and extensive contributions in clinical research. Sir.
Thank you, Dr. Jeswani, for inviting me here today. So I'm going to talk about the physiology of coagulation. Slides are not. Okay, so I'll take you back a little bit to first MBBS and then run you down to third MBBS. So hemostasis is basically defined as a mechanism of host defense that runs parallel to inflammation to protect vascular integrity after tissue injuries. Whenever there is inflammation going on in the body, you will see any inflammation. You have pneumonia, you see that the D-dimer levels are high. Why is that? Because the moment there is inflammation, there is going to be ongoing, tissue damage, capillary damage, and then the repair process, and you have thrombosis when the inflammation happens. Right? Okay, so basically, when you want to suppose there is a injury to the vessel wall, you want to patch it up. You need to have bricks and you've got to have cement. The bricks are the platelets, and the cement is the coagulation factors. So that's the thrombus here. Yeah. So this is the blood vessel wall. So here you have damaged endothelium. Can't see the point. Okay, so, sorry, this cursor is not properly. You see here that there is a damaged endothelium, right? So when you have injury to the endothelium, the tissue factor is exposed to the blood, and so the first thing that happens in okay, here's the one again. Okay, right. So the first event that happens is that the von Willebrand factor will come and layer out over here on the endothelium here, right, on the subendothelial collagen. And to the von Willebrand factor, the platelets will then come and adhere to it with their 1B9 receptor. So platelet adherence. And once the platelets are adhered, they will immediately get activated. There is flip-flop mechanism. The anionic phospholipids from within the platelets are exposed to the surface. Platelets will aggregate with each other with the 2B3A receptor, right? And then you'll have a platelet plug that forms the primary hemostasis. So you platelet plug binding to the von Willebrand factor. And then what happens after that? The tissue factor lights up the coagulation system, and then you will have the coagulation factors which come and form a cement on top of the platelets. So the platelets provide anionic phospholipids which are required for coagulation, and they will also provide a surface where the coagulation factors will interact with each other and then stabilize and form the clot. Okay, so in endothelial injury, VWF, cut to size by an enzyme called ADAMTS 13. Normally, the von Willebrand factor is present in the blood in multimers, right? This ADAMTS 13 enzyme will come and start cutting the VWF into various fragments, and then appropriate size fragment will come and bind to the subendothelial collagen. And this is what I just explained, right? Okay, then in the body, the coagulation always starts with the so-called extrinsic pathway, which I will come to again. So when the tissue factor is exposed, it binds to the factor 7, and that converts it to factor 7A. The factor 7 converts factor 10 to 10A, and the 10A converts prothrombin to thrombin. Thrombin will convert fibrinogen to fibrin, right? So that's how you form the clot. Now, if clot is already formed with just this process, why do you need the other factors, 8, 9, 11? Why do you need those factors? Okay, where is their role? You already got a clot. The problem is that with this pathway, the clot that is formed is very small and nascent. It's a small clot which can just about arrest some degree of bleeding. But to get a large amount of clot, you need all the intrinsic pathway factors. So thrombin is a potent enzyme which actually activates factor 11 to 11A, activates factor 8 to 8A, 5 to 5A, and factor 9 as well. So all these factors are actually activated by thrombin, and then you have a large amount of clot which will come and seal the bleeding areas. Now this was your extrinsic pathway, and this was your intrinsic pathway. I told you that it always starts from here. Tissue factor this way, this way, this way, and then when you have this 2A, the 2A is what goes and activates all of this. Okay. Now if you take blood and put it inside a test tube, okay, just take blood, add it into a test tube. It forms a clot, right? That's your clotting time. The clotting time is normally about 6 minutes. It's a very slow process. Now, what activates this coagulation system here? There's no tissue factor, right? You've taken it inside a test tube. What activates it? The surface of the glass acts as a contact activation, and that activates factor 12. And then this pathway gets activated and you form the clot. The clotting time is it's a very crude test. It's like a very long time, 6 minutes. You don't want 6 minutes. Supposing you have a patient who's got a little bit of a factor 8 deficiency, gentle factor 8 deficiency. You will not pick it up on the clotting time. Your clotting time is too long. So you want to shorten that clotting time to a very small, it should be a rapid clot. So what you do is you add a chemical, a reagent, which will immediately activate this coagulation system, this intrinsic pathway. And these are kaolin or micronized silica, ellagic acid. These are components which when you add to it, you'll have a rapid clotting time. And from 6 minutes, it will just come down to about 30 seconds. So that 30 seconds is, prolonged by to 34, 35, 36 seconds. There is a problem in one of the coagulation factors. It's a very sensitive test. And that test is called the activated partial thromboplastin time, right? APTT is nothing but a shortened clotting time. What is PT? PT is a representation of the extrinsic pathway. So what you do is you take the cyclated blood, you put it in the test tube, and then add a reagent which contains tissue factor to it and phospholipids to it. When you add this, immediately you're going to have this clot formed, and that's a measure of your prothrombin time. I hope this is clear. Now, in hemostasis differs slightly significantly between arteries and veins. In the arteries, it's a high pressure system. You will have orderly flow of blood in the arteries, right? So which means that the larger cells will be in the center of the artery and the smaller cells will be at the periphery of the blood vessel wall. So the RBCs or the neutrophils, they will be in the center, whereas the platelets, which are smaller, will be pushed towards the periphery of the blood vessel. Okay, so whenever you have an injury to the arterial wall, the platelets which are flowing in a fast speed and towards the periphery, they will immediately seal the bleeding areas, and so you'll have a robust platelet plug in an arterial system. So in arterial, so conversely, if you want to prevent arterial thrombosis, you need to use antiplatelet drugs predominantly, right? Whereas in the venous system, there's no orderly flow of blood. Blood is moving from below upwards. It moves up, then during diastole again it stops. There are walls which are interrupting blood flow. So the platelets are all over the place. They are not, they can't form a robust platelet plug. So if you want to prevent venous clots, you got to use anticoagulants. The coagulation system is very important in venous thrombosis, and therefore you need to use anticoagulants if you want to prevent a venous clot. Okay, so I just mentioned APTT is a shortened clotting time. There's no rule of doing a CT today, except for possibly bedside monitoring of the coagulation status in a snake bite. Otherwise, CT is not to be done. It's APTT that you always do. What is the normal APTT? Anything beyond 4 seconds above the control time that you have is considered to be an abnormal APTT. So you've got to start looking for any minor coagulation defect if the APTT is deranged. And the PT, any PT which is more than 3 seconds above the control time is considered to be abnormal. And this is the best test used for monitoring oral anticoagulation. The serum fibrinogen is another very important test, which is, the fibrinogen is the final, it's factor 1, right? It's the final step in the coagulation, this thing. So that's the normal value, and a level of more than 100 milligrams is considered hemostatic. And it's very important because cryoprespirates or fibrinogen concentrates, these are available for preventing hemostasis, and during the process of DIC, etc. When you infuse these, you can immediately seal the bleeding areas and prevent the bleeding. Now, the bleeding time is purely a marker of platelet function, right? A platelet count of below 50,000 will prolong the bleeding time, especially if it is less than 20,000. Now, regarding qualitative defects of platelets, only very severe qualitative defects of platelets will prolong the bleeding time. Okay, if it's a mild defect, such as, when you have a patient who's on antiplatelet drugs, say aspirin, clopidogrel, prasugrel, your bleeding time is not going to be abnormal, because you need to have a really bad, qualitative function or defect of platelets, like, like your Glanzmann's thrombocythemia or one of the Bernard-Soulier syndrome. Those are the ones where the bleeding time is really prolonged. Otherwise, it's nearly normal. So to summarize, to assess hemostasis, you need the platelet count, you need PT, APTT, you need serum fibrinogen. Now, I'll just mention a little bit about, I know DIC is going to be discussed, but I'm just going to mention what happens in DIC, the physiology and the pathophysiology in DIC. So DIC will happen whenever there are two mechanisms in which DIC can happen. The first is, so the tissue factor has to has to be exposed to the blood. A large amount of tissue factor, when it is exposed to the blood, it's going to light up all the coagulation factors and cause disseminated intravascular coagulation. Now, when can this happen? It can happen in two scenarios. One, whenever there is diffuse endothelial damage to the vessel walls, right? So endotoxins, enteroxemia, snake bites, mismatched blood transfusion, crush injuries, vasculitis, all these are going to disrupt blood vessels, and the tissue factor is going to come in contact with the blood. And the second mechanism is that if there is exogenous tissue factor which enters the blood. Now, how can that happen? Typically in your obstetric DICs. So placenta and amniotic fluid is rich in tissue factor. The moment that finds its way to the blood, is going to light up the coagulation system. Acute promyelocytic leukemia and certain organ malignancies, they also have content, the content in the tumors is rich in tissue factors. That also causes DIC. So it's a syndrome of uncontrolled protease activation within the circulation, where thrombin initiates the process of intravascular coagulation, and plasmin secondarily, which is activated, it breaks down the fibrin and coagulation factors and forms the fibrin degradation products. These are all the obstetric causes of DIC. So the consequences of DIC are that there is excessive activation and consumption of coagulation factors in the microvessels. There is passive activation and consumption of platelets in this process, disseminated thrombosis, depletion of coagulation factors and platelets, and ultimately bleeding. And these are the laboratory findings in DIC. You have got to look at the PT, APTT, and the serum fibrinogen. And rarely, in severe cases, you'll see microspherocytes and schistocytes in the peripheral blood. Another important thing that you need to know is about liver coagulopathy. So the liver is basically the site of production of all the coagulation factors in the body, right? And the PT often can never be fully corrected if the synthetic dysfunction exists. Now, generally, if you want to proceed with any sort of invasive procedure in a patient who's got chronic liver disease, you can accept a prothrombin time as 1.5 times the control value to be adequate. So if your baseline is if your control time of PT is 10 seconds, then anything more than 15 seconds would be considered as abnormal. Anything below that would be acceptable. Now, the reason, the important thing is that factor 7, all the coagulation factors have a long half-life except for factor 7. Factor 7 has a short half-life, only about 2.5 hours, 2.5 to 3 hours, right? So if you are going to have a patient who's going for a invasive procedure and he's got a chronic liver disease, you don't give your FFPs one day prior. You give your FFPs within the first 1 or 2 hours just prior to the surgery, so that, because if you infuse it, 2 to 3 hours later, the factor 7 levels start to drop, and therefore the PT will start getting prolonged, and you start to bleed again. Transfuse those platelets within an hour of the planned surgical procedure. The other thing is that when anticoagulants are in the blood, so for example, if you have a DOAC, your patient is on rivaroxaban, and the patient has started to bleed. Okay, giving FFPs in this situation is of no use, right? Because a 10 milligram of rivaroxaban is going to neutralize the factor 10 in 5 liters of blood. And when you're giving, say, 4 FFPs to that patient, it hardly is just about 200 into 4, just about 750 ml or so. So in 5 liters, the 750 ml of blood of FFP is not going to help in any way. So what you've got to do there is to give 4-factor PCC. These are available now. We've got prothrombin complex concentrates, which are rich in 2, 7, 9, and 10. And these are what are going to mop up the entire drug that is there in the circulation and will help in preventing bleeding. A word on platelet transfusions. So there are transfusion thresholds which are decided, and there's a lecture on transfusion thresholds in bleeding. So I'm not going to discuss that. But the life of platelets in immune-mediated platelet destructions can be only a few minutes. So you transfuse platelets while invasive procedure is going on, or if the patient is actually bleeding. Otherwise, in an immune-mediated platelet destruction, if you transfuse platelets in the 10th minute or in half an hour's time, all the platelets are going to get destroyed. And platelet transfusions are of no use in the presence of antiplatelet drugs or uremia. I think Shailesh just mentioned, I just heard him mentioning that you also gave platelets because you thought there is uremia in that patient. So one, uremia has to be chronic to cause platelet dysfunction, right? And so in that patient where acutely he became uremic, you won't have platelet dysfunction. And secondly, when you transfuse platelets into an environment of uremia, they immediately get dysfunctional. So platelet transfusions are of no use there. If you want to prevent the bleeding, you either compensate for the platelets by adding more cement, compensate for the bricks by adding more cement. So you give either PCC or you can actually give cryoprecipitates. Okay, so that will sort of help in preventing bleeding in these cases. All right, so just key messages. Nature of the coagulopathy in the ICU depends upon the underlying condition. Appropriate laboratory tests need to be asked for. We're taking extreme care of the pre-analytical variables. And interpretation of deranged coagulation test requires clinical correlation. Decision of transfusing blood products is a combined clinical and laboratory guided decision. So thank you.
Thank you, sir. It was nice and crisp presentation from basics to applied physiology of coagulation, and many things like antiplatelet in uremia we sometimes use in acute. Thank you for these concepts. Forum is open for any discussion or questions.
Our patient who has got coagulopathy gave FFPs 1 hour before the procedure. How long that effect lasts for FFP?
Yeah, so the factor 7 in the FFP will start getting depleted by 2.5 hours, right? Also, it depends upon how much the patient is consuming during the surgical procedure. So it can be pretty rapid consumption. So depending upon how much of blood loss is there, that would dictate how much of the FFP is still going to remain in the patient's blood. So if it's not too much of a blood loss, then the FFPs are going to last for something like about 3 to 4 hours. So if you're going to check, if you feel the patient is at risk of bleeding or is actually bleeding, you would check the PTT 4 to 6 hours later on. And if it is deranged, again give another load of FFPs.
Any more questions? Thank you, Samir sir, for expanding our knowledge and shedding light on a topic which we feel we know well and still can't know enough. Thank you, chairpersons, for conducting the session so well. Now, I would like to request chairperson to kindly present memento to Dr. Samir Melenkeri sir. Now I request Dr. Deepak Jeswani sir to present token of appreciation to chairpersons. Thank you, sir.
Now coming on to our next topic, which is mapping of hemostasis, to be elaborated by our own Dr. Amol Mishram sir, for which the chairpersons are Dr. Deepti Chand, ma'am, who is a diabetologist and intensivist at KIMS Kingsway Hospital, Nagpur. Dr. Sanjay Kriplani sir, who is senior consultant intensivist at Max Hospital and director of High Tech Hospital, Nagpur. Dr. Vaidehi Nayak ma'am, who is consultant pathologist in KIMS Kingsway Hospital. As someone said, measurement is fabulous unless you are busy measuring what's easy to measure as opposed to what's important to measure. So to elaborate on how to map hemostasis, I would like to invite Dr. Amol Mishram, for whom I need not give any introduction to the Nagpur crowd, but friends, let's observe all formalities. Dr. Amol is a renowned intensive care consultant with number of years of experience in managing critically ill patients. Amol sir is presently president of Diabetic Association of India Nagpur chapter. He has also been involved and held leadership in many different organizations. Sir is at present consultant in Criticare Hospital Nagpur and Janta Hospital Nagpur. Amol sir.
Dr. Amol, of course, everybody knows him. He's our favorite intensivist physician from Nagpur itself. So he'll be enlightening on rotum, TEG and rotum. So Dr. Milankari just told us about different tests which are used in a bleeding patient. He will combine all together into one and tell us that what's gone wrong. So Dr. Amol Meshram.
Thank you, ma'am. At the outset, I would like to thank my own teacher, Dr. Deepak. Actually, I am his 12th student. So, thank you for giving me this opportunity. Today's talk is actually, first of all, let me be very clear that I am not an expert in doing all these things, but I am a clinician, and today's lecture is basically to introduce all of you to this concept. Rotem is basically not a new test. It's a very, very old test. Actually, it was discovered, I mean, TEG, thromboelastography, was discovered much before APTT and PT. So, let us just go through and understand the basics. This is just the basics. You need to see a lot of graphs and practice to, clearly interpret this thing. So, but this lecture will probably a kickstart for you to understand what is TEG and rotem. Excuse me. Okay. So, what is TEG or rotem? It is basically a graphical representation of a clotting process. It tells you about the entire life history of a clot, right from formation till lysis. Like clot initiation, stabilization, and strength, how it propagates and how it breaks down. So it is just a visual graphical representation of the complete life cycle of a clot. So why APTT and PT, is said to be inferior to rotem? Because, PT APTT will tell you only about a certain part of clotting. It tells that, okay, clotting has started, right? It fails to tell you whether the clot is good, is it strong, is it able to hold the bleeding, and how the lysis is happening. These are all things which are very important for us as clinician when we are treating our patient on the bedside. So that's why TEG or rotem scores over PTA PTT. There are two types of machines which are there. If you see this machine, this is basically a thromboelastography machine. It is a very sensitive machine. You have to have a very stable platform for it. There should not be any motion artifacts going over there. And this is the advanced version, which is called as a rotem delta machine. It does 4 to 5 tests at one time, while TEG does only one. The basic principle is the same. There is a pin inside this machine, and there's a cup. This cup is holding your whole blood. The difference between the two, they both have a pin and a cup, but difference here is that this cup in TEG, the cup rotates around the pin, while in rotem, the pin rotates, the cup is stationary. So what happens is, when there is blood and it slowly started to getting clot, it will stick to the pin, and once it starts sticking to the pin will also move, and depending on the strength of the sticking process, the range of movement will increase. So the graph with this is, I'm sorry, this is my handmade just to show representation how it actually happens. There is no clot formation here because there is no sticking of any clot to the pin. Once the clot starts forming, the pin slowly starts moving, and the amplitude increases gradually till the clot is completely sticking to the pin. And at one stage, it forms a plateau. And once the clot starts breaking, there's lysis, then again the graph goes down slowly until it breaks down completely, and again there is no graph line coming here. So what the machine does, it just connects all these points and gives you something a very beautiful leaf-like structure. This is a TEG structure, TEG graph. It will be looking very busy or elaborate right now, but let us break it down. It has many parts like this R time, there's a K time, there's an angle, there's something called as MA and fibrinolysis. This part from here to here, it is called clot formation, and from here till here, it is clot lysis. It must be very confusing right now, but just let us break down everything one by one and just learn. So let us see the first part, just only this part. This is called as R, reaction time. It is a time recorded from beginning of the tracing to the first measurable clot, like first deflection. From 0 to the first deflection, this is called as R. You know, it all depends, as the Millenkeri sir has told us how the clot forms. It depends on clotting factors and anticoagulants present in the blood. If there is heparin, there won't be any clot formation. This line will be straight, right? There is no clot formation. So this line will be straight. So it all depends on the clotting factors and presence of heparin in sample. Normal range is 5 to 10 minutes. You know what I would like to suggest, don't remember these normal values because these are all given in your graphs. So you don't have to stress your mind, just see the normal ranges in your reports and interpret accordingly. What R time, if increases, what does it mean? You know, either there is clotting factor deficiency or if there is a heparin in the sample, right? So what you are going to do, if there is a prolonged R, your treatment options are, if the patient is on heparin, give him protamine till this normalizes. If this normalizes, yes, there is good reversal. Otherwise, the reversal is not good. Or if the patient is not on heparin, what you do, you give clotting factors by giving FFP. So this is the R time. Now we go to the next part, which is called as the K time or kinetic time. What it is from the first measurable clot to 20 minutes formation of the clot. The first 20 minutes of clot formation is called as the kinetic time. Again, this part is very important. It is influenced by fibrinogen level, which is present in the blood. Imagine what will happen if this K time is prolonged. It means there is fibrinogen level deficiency. So this patient requires either a synthetic fibrinogen or cryoprecipitate. Am I clear with this? So up to now, what we have learned, R time and the K time. Let us move ahead. There is something called as an alpha angle. What it is? You draw a horizontal line in the K part, which is up to 20 minutes, and draw a slope here. This angle is called as alpha angle. You know, faster the clotting, bigger is the angle, right? It tells you about the rate of formation of clot. So faster the clotting, the angle will be more bigger. Smaller the angle, it means the clotting process is small or slow down. So this tells you about the rate of clot formation, and it depends on fibrinogen level. So again, if the angle is narrow, what you have to do? You have to give either fibrinogen or FFP, right? Let us move ahead. Sorry, you have to give fibrinogen or cryoprecipitate. Next is something called as maximum amplitude, the one which I showed where there is plateau formation of the graph. So this is the maximum strength of the clot. It is not going to go beyond that. This is the maximum height of a clot which the strength is shown. Again, don't remember normal ranges, but yes, it is good to remember if you want to. But what I believe, don't stress your mind. The graph tells you what the normal range. Bigger, thicker the MA, better is the clot. More stronger is the clot. And mostly depends on the platelet, but also on the fibrin factor 2 and factor 4. So what if this thickness is decreased? If the thickness is decreased, it means the clot is not strong enough. Either there are not enough platelets or the platelet function is not good. So what you have to do here, you have to give platelets to the patient or DDAVP. So till now what we have learned here is the R time, K time, alpha angle and maximum amplitude, that is clot initiation, formation and strength, right? Now let us move ahead. This is coagulation. Let us move ahead to fibrinolysis now, how the clot breaks down. So this second part of the leaf tells you how the clot is breaking down. There is something called as LY30. LY is lysis at 30 minutes after MA, after the maximum amplitude. So what you see, how much lysis is going on at this 30 minute of time, how much the slope has gone. Normally it should not break more than 8 to 10%. The clot should not break more than 8 to 10% 30 minutes. What if it is breaking more than 10%? It means there is hyperfibrinolysis. the clot is breaking fast. So the treatment here would be an antifibrinolytic agent like tranexamic acid. You know, so this part is also very equally important. It will tell you about how fast the clot is breaking down. So, let us see some abnormal graphs, keeping this normal graph in mind. I'll keep this graph in one side of the slide and let us see and try to interpret some graphs. So this graph you see, this is normal and this is the TEG graph. What you see clearly here, the R time is increased, right? If you compare with this, the R time is increased, right? So the problem is either the patient is on heparin or there's clotting factor deficiency. So what you have to do? You have to give either protamine or FFP, right? So just compare with the normal one. You will understand. This is just the beauty of TEG and Rotem is it is visual. But say you can see and identify and diagnose it and treat the patients. Next graph here again. What you see? Clearly seen the thickness is decreased, right? If you compare with this, the thickness is decreased. So what I have to do here? I have to give platelets. Is it? Here, the leaf is tapering faster. So clearly I can say I don't have to think about how much is lysis at 30 minutes. This graph will tell me, okay, this is hyperfibrinolysis, I have to give pause or tranexamic acid, right? Correct? So let us move ahead. Here, if you see, this is long, this is short. So everything is hypo. Everything is less. So you have to give everything here. And here, everything is hyper, thickened out, right? So you have to treat accordingly. Just by looking at the graph, it gives you a good idea कि अब मुझे next क्या करना है. मेरे bleeding patient, what I have to do. Move ahead. In DIC, sir has told very nicely, you will see a graph like this, a thickened graph, and then there is secondary hyperfibrinolysis. So now comes a little bit of confusing part here. When you start talking about Rotem, TEG is easier. When you start thinking about Rotem, there are some terms which you should know, and because otherwise you'll get confused. So what is Rotem? Rotem is actually an advanced version of TEG. Here what you do, the test is same, but you add some activators or inhibitors to the blood to see its effect on what happens next. By putting some activators, is something getting prolonged or shortened? By putting some inhibitors, is something which is prolonged get shortened or not? So we'll move ahead and we'll understand how does it help. There is change in nomenclature. Again, whatever the R time is, here it is called as CT, that is clotting time in Rotem. K is called as clot formation time. Angle remains the same. Maximum amplitude becomes maximum clot firmness. Easier to remember, and lysis at 30 is clot lysis at 30. It's the same thing. So just the nomenclature changes, but rest everything is the same. The other part is, again, normal ranges you don't have to remember. It is a colorful chart. It had different colors. So what it tells you, this color, many times, the color coding helps you to just to diagnose. Just by seeing the color of it, it will help you to diagnose. How? We'll see. As sir has clearly told us that there are intrinsic pathway, extrinsic pathway, and a common pathway. There are 3 tests which are done in Rotem. One is called as INTEM, which tells you about the intrinsic pathway. Other test is called as an EXTEM, which tells you about the extrinsic pathway. And the third test which is done is called as FIBTEM, which tells you about the fibrin or common pathway. So these 3 tests are basic tests which are done in a Rotem. These are the basic tests which you should order to your pathologist. Okay, I need an INTEM, EXTEM, and FIBTEM. This is the graph paper of Rotem. It has green lines, just like I told you, you should be able to read it faster. So these green lines are marked at 40. Any graph which is thicker than this, you should understand, okay, the clot is firm. So you don't have to remember the clot. The graph itself tells you, okay, it is above green line, okay, I'm good. The clot is firm, it is fantastic. Bigger the amplitude, firmer the clot, as we have learned. There are other color coding. The CT or R time, which we call in TEG, is also color coded, and the K time is also, which is called as CFT here, is also color coded. So now, just to tell you how, just looking at the graph, how we can diagnose. This is a normal graph. I told you 40, beyond 40, excellent, clot is good. just jump on this graph. It is less than green line. So we are sure that this clot is not firm. We'll be requiring platelets in this patient. And here, just by comparing, there is tapering off of the leaf. It means there is hyperfibrinolysis. We'll have to give him tranexamic acid. So this is how easy it becomes, just by looking at the graphs. So there are many variables which you see in a TEG and ROTEM. Again, CT, CFT, alpha angle, A10, MCF, too much of, understanding. So just make it simpler. These three things are very important. Clot formation, there's CT. A10, that angle or amplitude at 10 minutes, and 20 is 20 minutes, and ML is maximum lysis. You have to concentrate only on these 2-3 things. CT, it is measured in second. It reflects the patient ability to generate a thrombin resulting in concept of clot formation. Simple. The first basic straight line, what we were seeing. Amplitude at 10 minutes. How fast the clot is formed at 10 minutes. You have to see this time. Third, how fast the lysis is happening. Is it, the lysis is faster or it is normal? Only these 3 things you have to see. So just to see that CT, both in INTEM and EXTEM, you can see there are reference ranges. Again, I request, don't remember them, just see the charts. 10 minutes, how the clot is formed. Okay, both in INTEM and EXTEM. It tells how the speed of the clot formation is. And maximum amplitude, just what we saw there in the TEG also. So these 3 things, one thing you have to remember, whatever is coming in A10, you add 10 to it. That should be the normal range of maximum amplitude. So easy to remember, A10 plus 10 is maximum clot formation. Again, lysis, anything which is more than 15% takes 60 minutes, there is hyperfibrinolysis. Okay? So again, just by looking at the graph, you can tell, okay, what pathology is going on. Fifth time here, it is a smaller graph, thinner graph. The amplitude is also not much. It ranges somewhere from 1 to 4 mm or to somewhere. If you see a 10 to 20 type of mm, it is a good graph. So why you should see a fifth time, I'll go through in the next slide and you will understand. This I have told you already. CT basically tells you about influence of enzymatic coagulation factors in INTEM, about heparin effect. A10, again, clot firmness. A10 at fifth time, it tells you about amount of fibrin, and maximum lysis, it tells you the clot lysis. So this is how the normal graph you will see, INTEM, EXTEM and FIPTEM. These are 3 things which you have to ask your pathologist to do, basically. INTEM, just like what Malenkeri sir told, it is about intrinsic pathway. What you do, you add some activators here to activate the intrinsic pathway. It is simple like APTT. What is in HEPTEM? HEPTEM is a simple modification in INTEM. What they do, they add inhibitor of heparin, a heparinase. So what will happen is the patient is having heparin in his system. If you see a prolonged CT, put a inhibitor, heparin inhibitor, what will happen is the graph will become normal. Like this. This patient who was bleeding, his CT is prolonged. Okay? What you do, this is on INTEM. What you do, you add an inhibitor of heparin. What happens is this becomes normalized. From 350 becomes 210. So here you have a diagnosis that the patient is on heparin and you need to reverse it to correct the graph. EXTEM tells you about extrinsic pathway. Again, you add some activators, tissue factor activators, and it gives an idea like PT. FIPTEM and EPTEM are modifications of EXTEM. What you do in FIPTEM, you inhibit the platelet and you concentrate only on the fibrin levels. While in EPTEM, what you do is add aproctentin to inhibit fibrinolysis. So again, difficult to understand. Let's see the graphs. Simple. If you have a bleeding patient and you see the graph, what you see here is thickness is decreased and A10 is reduced. Okay. What you do is, now I have a problem. Okay, the thickness is decreased because of platelet or fibrin. I will do a FIPTEM. FIPTEM, if you see, this is a very thin line as compared, and the A10 is just 4. So what I come to conclusion is that this patient's problem is basically fibrinogen deficiency. What I need here to do, I have to give a cryoprecipitate or synthetic fibrin. Similar patient, similar graph, but the FibTem is normal. Now what? Simple, I have to give platelets now, right? Here, again, you see hyperfibrinolysis, and now what you do here, you do an aptem here and see if it gets corrected. Once you do an aptem, the graph normalizes. Now what here? Here you have to give antifibrinolytic agents. It's that simple. So these modifications actually help you to pinpoint your diagnosis, whether platelet defect is there, fibrin defect is there. That's why these modifications are required. There's a simple example, a patient undergoing a cardiopulmonary bypass. These patients are on heparin, and the surgeon is thinking, okay, now I have to reverse. So what he does, patient is on heparin, there will be no graph formation. Intem will be just straight line because there is heparin here, clot cannot be formed. So what the anesthetist will do, he will do an heptem. He will add an inhibitor of heparin. And if he sees, a graph is corrected, okay, I'll give protamine to him. But will protamine be enough? If you do a FibTem, you see a very thin line. So it means even after giving protamine, the patient will not stop bleeding. You'll have to give a cryoprecipitate. You have to give fibrinogen in this patient. So this is how basically it pinpoints your diagnosis and helps you to treat the patient. So there are, based on all these things, there are ROTEM and tech guided resuscitation protocols. I've simplified them. Simple thing is what to do. Increase R time, I have to give an FFP. Decrease alpha angle, I have to give a cryoprecipitate. Decrease MA, that is the amplitude, I have to give platelets. Hyperfibrinolysis, I have to give a tranexamic acid. This is that simple. Just look at the graph, treat the patient. So to summarize, TEG-ROTEM is a useful tool at the bedside. It is very easy to operate. Unfortunately, presently it is little bit of expensive and not all places do have. I think Nagpur has two places. One is in Kingsway and one is in Alexis. So I've been doing, and our team is being doing ROTEM at the Kingsway Center, where he always readily helps us in this thing. It is basically very helpful in your bleeding patients like trauma, obstetric bleeding, sepsis and cardiac surgery patient. So what to order, once you have done, test order karu, Vedi, what should I do? So you tell Vedi, okay, Vedi, I need an Intem, Extem and FibTem. And then you leave her, you analyze, and you then tell me. Then Vedi will call you, sir, there's a problem with R time or CFT. I'll do a HepTem or a EPTem. Just by this, you will get a diagnosis and you will treat the patient. Imagine you're treating, pinpoint diagnosis is happening within 60-65 minutes. Such a beautiful test. Okay, so believe your pathologist, have a good communication with him, and try doing this test more often to help your patients. Thank you once again. Keep learning more. There is a website called as roteminc.com where you can go there, visit that website, see more charts and learn accordingly. It's very easy. More charts you see, more faster you start interpreting. Thank you so much.
Absolutely wonderful, Dr. Amol. It was good as a sensitizing lecture for the audiences. We require a lot of day-to-day practice in interpreting these tests, specifically used in cardiothoracic surgeries, even pregnancy bleedings, and of course in sepsis and all. So we do require to do this, and we have been treating patients after the ROTEM analysis and accordingly giving the supplements to these patients. Alexis?
Yeah, absolutely. You see, we do ROTEM very frequently, and there are actually 4 modules, as you have seen in your diagram. So these are, one is EXTEM, FibTem, INTEM, and HepTem. The way you have described how to order it, you see, the INTEM is intrinsic pathway, and HepTem is to see the heparin effect. So if there is a bleeding during the cardiopulmonary bypass, usually only INTEM and HepTem is required. For other cases, you have to, or because these tests are very costly, every module costs 7,500 rupees. So for other cases like trauma and other hemorrhages, you need to order only XTEM and FIPTEM. Uh, how to diagnose is probably a detailed discussion we will not discuss. Apart from that, there are other modules to see the effect of the antiplatelet drugs. There is no method to see what are the effect of the antiplatelet drugs. So there is a separate module for platelet aggregometry that can be attached, and you can see the effect of antiplatelet drugs. These tests do not uh, uh, show the effect of the antiplatelet drugs because of the inherent thrombin generation, high amount of thrombin inside the additives that we add. So that is one thing. And one more thing is to see the effect of NOx. So there is one test called as ECATM, like Icarian clotting time, ECT. It's the same as Icarian clotting time. So the effect of NOx, the direct thrombin inhibitors, like dabigatran, you can see on ECATM. So if you want to diagnose in the routine trauma and other hemorrhages, you have to order XTEM and FIPTEM. And in case of cardiopulmonary bypass, you order INTEM and HEPTEM.
Yeah.
And for NOVEX, ICATEM. And for to see the effect of antiplatelet drugs, there is something called as PLATEM. There are more variations to it, and which is beyond this thing. Lot many things to discuss about this.
The machine is such beautiful thing that so many modifications and additions can be done. This is beautiful to pinpoint things. But what I feel is, we should stick to basics.
And one more thing, you see how it is useful in trauma and other hemorrhages. You see the maximum clot firmness takes around 25-30 minutes. Yeah. What he has shown is A5, A10. A5 or A10 are surrogate markers of maximum clot firmness. So when you are running the ROTEM at your place, you can see live within 10 minutes how firm the clot is. Then you can decide, because the simultaneously goes, if you are running simultaneously like XTEM and FIPTEM, at 10 minutes, within 10 minutes, if the width of the FIPTEM is low, you know the fibrinogen deficiency is there, you have to replace it with cryoprecipitate. If FIPTEM is normal, you have to know that you have to give platelets. This has helped us many a times in giving unnecessary cryos. And many a times, if you are not doing it, you might end up giving many cryoprecipitate when it is not indicated. So that is the beauty of this test, that real time within 10-15 minutes, you in a bleeding patient, you come to know what is deficient and how much. And second thing is, upon depending on the amplitude of this thing, you can decide the dose of the cryoprecipitate also, and also 4-factor concentrate. Prothrombin concentrate, PCC. So the dose of PCC also depends on the amplitude. There are many studies, and they have given how much PCC has to be given in a patient looking at the ROTEM. That is one of the added advantage of ROTEM. Yeah, thank you.
I just wish to mention about one of our cases who was a stroke patient on antiplatelet drugs. He had 2 weeks before he had a stroke, he was on dual antiplatelets. His FIPTEM was normal. He was bleeding. So that was obviously a platelet disorder occurring. He had eaten something, and the relative tried to remove the food from the oral cavity with a spoon, and he traumatized the oral cavity, and the patient was profusely bleeding from the oral cavity. His platelet counts were normal. And he was profusely bleeding. We packed him up initially, and then we asked for the platelets and all. It was a corporate patient, and the railway doctor said that, why do you require platelets in a person whose platelet count is normal? So he was on antiplatelet drugs. He had a platelet disorder on the analysis, and we gave him platelet transfusions and all. So it does help in an emergency, that how we are going to manage the patient. So the forum is open for any question.
No, ma'am, I don't agree with you. Number one, these tests does not show the platelet dysfunction of the antiplatelet drugs. There is a separate module for this that is called a PLATEM. The reason is, as I said, the additives which we add for these tests contain high amount of thrombin. So what does thrombin do? is they activate the platelet by PAR1 and PAR4 receptors. So even in the presence of antiplatelets, these receptors get stimulated, and you may see a normal ROTEM in the presence of antiplatelet drugs. So the antiplatelet drugs, the ROTEM and TEG may be normal in on the patients who are on antiplatelets drugs. So looking at the maximum amplitude does not show you the effect of the antiplatelet drugs. It is only thrombocytopenia. Whatever, matlab, this is not for antiplatelet drugs. There is a separate module for this. The reason is thrombin generation. PAR1 and PAR4 are the receptors where, because of the high thrombin, they get attached to it, and you may see a normal MCF and FIPTEM. Yeah, thank you.
Any questions from the audience?
Actually, I'm very happy because I see discussion happening more than my talk. so thank you so much, Chairperson, sir.
Thank you so much, sir,
Thank you, ma'am. Thank you so
for
much.
such an insightful and elaborative talk. We also thank the chairpersons for the wonderful guidance of the session. Now I request chairperson to kindly present token of appreciation to Dr. Amol Meshram, sir. Thank you, sir. I would like to invite Dr. Deepti Jeswani ma'am to present a memento to chairperson. Thank you, ma'am.
Dear friends, we started Criticare Convention in 2023, not only to celebrate the resounding success Criticare is, but to bring together a diverse group of professionals and experts in the field. किसी ने कहा है, देखी जो नब्ज मेरी तो हंसकर बोला हकीम, तेरे मर्ज का इलाज महफिल है तेरे दोस्तों की.
हाँ मोनिका मैम, ये महफिल ही तो है हमारे दोस्तों की. So, what is a convention but a gathering of friends to meet, greet, celebrate, and of course to show off a little bit of our jewels. For us, those jewels are our knowledge and our experiences.
Imagine what would medical science be today if our predecessors have not shared extensively their knowledge, their successes, and their failures. So, dear friends, our organizing chairman, Dr. Deepak Jiswani, with Criticare family, started this convention in an ongoing endeavor to learn, evolve, and excel in caring and treating patient. दीपक सर के बारे में मैं क्या कहूँ? परिंदों को मंजिल मिलेगी यकीनन, ये फैले हुए उनके पर बोलते हैं. अक्सर जो लोग खामोश रहते हैं, ज़माने में उनके हुनर बोलते हैं. Deepak sir did not land in Nagpur a running success, but started at various hospitals as consultant intensivist. At one point, he felt that now he wants to do things his way. So he, with Deepti Jaswani ma'am, started a 15-bedded hospital in May 2008, which, dear friends, was no less advanced and dedicated to patient care as we are now. He shifted to the new premises with a larger capacity in 2014. And though I would say Criticare is one of the medically advanced hospital in Nagpur, his thought behind this is always about the better care of the patient rather than the betterment of the hospital. Criticare was sir and ma'am's dream, but they have collected so many people in their embrace that Criticare has become a huge family of people who have the shared goal of doing it better than the best. So dear friends, I give you Dr. Deepak Jeswani to say a few words and lead the lighting ceremony to inaugurate the event. Dr. Deepak Jeswani, sir.
Thank you, Monica.
Good morning, my teachers, seniors and friends. It is pleasure to begin this auspicious day by welcome you all, wonderful people present today. Criticare is not because of me, it is because of the team. I just initiated the thing and log milte gaye, karma banta gaya, as we said previously also. So the day of second Criticare Convention has just begun, and I thank you all for wonderful and timely beginning of the program. This convention is different every year. It has a theme. This time it is bleeding patient. Maybe next time it is infections in ICU. I thank all the faculties, Dr. Ravi Ghawat from Mumbai, Dr. Bharat Jagyasi, who actually could not make it to the program because he had chikungunya, so he'll be going live on Zoom. Dr. Samir sir from Pune, renowned hematologist, Dr. Suyash Kulkarni, and we are proud to say that Dr. Ravi Ghawat and Dr. Suyash Kulkarni are our own products from Nagpur, IGMC, and we proudly welcome them here. The main aim of this type of convention is to have a wonderful, in-depth discussion of a particular topic every year. And we have to begin these with prayers of God Almighty to give us strength to make this convention successful year after year. So we will begin with lighting the Samai, and I will request my dear friend Dr. Nikhil Balanke and Dr. Sudhir Jafle, who gave unconditional support to this program, and we could do this with API Vidarbh chapter. And also, I request all the faculties, Suyash, Ravi, who are here to join me in lighting Samai. I request my wife Deepthi and the scientific committee to join us for Samai lighting. And I'll also request my teachers, Dr. Munle sir and Dr. Jhawar sir, to come forward and be with us while we are lighting the Samai. Thank you.
या
Please.
कुन्सेन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीम्
As we conclude our Saraswati Vandana, we invoke her spirit of knowledge and creativity. But before we dive back into our session with open minds and heart, I would like to invite on stage Dr. Nikhil Balanke sir to say a few words. Dr. Nikhil Balanke sir who is a senior consultant physician in Viveka Hospital Nagpur and GT Memorial Hospital Nagpur. Sir is also present chairman of API Vidarbha chapter, whose guidance and unconditional support, I would say Deepak sir insisted on it, unconditional support, have played a pivotal role in execution of this event. Dr. Nikhil Balanke sir.
Good morning all. Deepak, तू conditions भूल गया क्या? On behalf of the organizing committee, Criticare Convention and API, I welcome you all.
to this wonderful gathering and to this, you can say, Super Sunday of academics. The ball set rolling with some wonderful cases by Shailesh and excellent lectures by Dr. Malinkari and our Amol. Amol, gaya, gaya? Amol, it was like a professor, learned professor who's ready giving a lecture and teaching us. It was a wonderful, really, it was a great lecture. It was, both the lectures gave us a lot of knowledge and practical implementations of those lectures are there. And similarly, the rest of them also going to follow in the same way. So don't go till 3 p.m. There are some wonderful lectures lined up. And as Deepak has said, this convention is going to give you more of theme-based conferences. So the next year it will be infectious diseases and some more to come afterwards. Amol, your lecture was good for the audience and also it was very good for, if I am permitted to say, very good for the faculty to come and for the chairperson because you said our time goes long and you are in trouble. So here the R will be replaced by the lecture. So if the lecture time goes long, we have so many good things to discuss today. So we need to restrict the time to the stipulated allowed time. So, and again the amplitude, you said the amplitude goes down, again you have to infuse platelets. So the depth of lecture also needs to be maintained when while you are trying to keep the length short. So wonderful, and it was learning experience, Dr. Malinkari and Amol and Shailesh, and we are looking forward to much more in the day to come. Thank you and congratulations Deepak and Deepti for this, the process which you are going through and trying to educate us and trying to give us some good practical lectures and themes. Thank you very much.
Sir. Now I request.
तुम्हारे ध्यान में आया होगा क्रिटिकेयर में दीपक कुछ भी बोले लेकिन मोनिका के जा बोलने सिवा कोई बाहर नहीं जा सकता. So I am here.
Now I request Dr. Sudhir Chafle sir and Dr. Sanjay Kriplani sir to please come on stage.
All three are stunned. What is going to happen?
Now, I request Dr. Deepak Jaswani sir to please present a token of our appreciation. Sir, we are honored to acknowledge your support and guidance in this journey.
Dr. Sudhir Chafle sir is a senior consultant at Critical Care Medicine at Getwell Hospital, Nagpur, and also present secretary API Vidarbha chapter, whose support, time and advice is very much appreciated by us. Thank you sir for all your support. Dr. Sanjay Kriplani sir, who is a chief intensivist at Alexis Hospital, Nagpur, and is with us as a designated MMC observer. Thank you sir for giving us your precious time. As we move on to our next session by Dr. Deepak Jaswani sir on how do we approach a bleeding patient, I would like to invite as chairpersons Dr. Pradeep Mishra sir. He is a critical care physician at Shiv Ganga Hospital, Nagpur. Dr. Imran Noor Mohammed sir. He is a critical care physician and anesthesiologist at Critizone Hospital, Nagpur. Dr. Manoj Chauhan sir. He is a managing director of CT Care Hospital, Bhandara. Sir.
As they say, no one can whistle a symphony. It takes a whole orchestra to play it. Similarly, nothing can be achieved in an ICU without teamwork and multidisciplinary approach. Our speaker, Dr. Deepak Jaswani, will now elaborate on how to approach a bleeding patient as a team in a systematic manner so that patient receives best treatment in the shortest possible time. Deepak sir is Managing Director of Criticare Hospital and Research Center, Nagpur. Sir is without doubt not only a very good intensivist, but a wonderful human being who has played a pivotal role in development of intensive care in Nagpur. Sir has done exceptional work during his tenure as President ISCCM Nagpur chapter. He has been IDCCM teacher for training critical care fellows since last 8 years. I give you Dr. Deepak Jaswani.
Good morning. Thank you, Monica. Coming on to how do we approach a acutely bleeding patient in ICU, I will be showing what we are doing and does the literature support whatever we are doing, and just a practical approach, how do we see these patients in ICU. And we all know the bleeding is the important cause of morbidity and mortality, and as we know, trauma patients bleed heavily, and almost 30% of the patients, they die within few minutes to few hours before reaching a hospital or immediately after reaching a hospital. And the main principles of management are airway breathing circulation, multidisciplinary approach with physician, intensivist, pathologist, blood bank. And main thing is to identify the source of bleeding, minimize the blood loss, maintain tissue perfusion, and achieve quick hemodynamic stability. And there is definite need for availability of point of care testing and early goal directed hemostatic therapy. Massive bleeding is defined as blood volume loss in 24 hours, or half of the blood volume loss in 3 hours. These are roughly the causes of bleeding patients in ICU, whether they are coming with bleeding or they are developing bleeding in ICU. And this is given by American Society of Hematology. And these the common causes can be structural causes like trauma, surgery, or it can be medications like antiplatelets or anticoagulant drugs. Patient might have thrombocytopenia, which decreases the threshold for bleeding. Patient might have liver disorders or coagulopathy, and vitamin K deficiency. Rare things can be acquired bleeding disorders or vitamin C deficiency, and further rare causes could be inherited causes like hemophilia A, B, and C, or von Willebrand disease. As discussed, it's a team approach while dealing any patient who is bleeding heavily in ICU. Main importantly, whenever we are talking regarding bleeding patient, we are more concerned about critical bleeding or massive bleeding. So it requires a team approach, maybe 4 or 5 people in the team, and it is a team in charge intensivist who gives commands, who do primary survey of the patient, identifies the source of bleeding, do a bedside ultrasound to know the volume status of the patient, do assessment, and maybe he will insert arterial line to the patient for invasive hemodynamic monitoring. A junior medical officer at the head end will deal with the airway of the patient, put a Riles tube if it's a GI bleeding, and start with ventilation and maybe help in inserting arterial line. There are 2 important nursing staff in the team which might help in arresting the bleeding. If there is a extremity bleeding, they will apply compression or a tourniquet, or second staff will put a 2 wide bore cannula of 16 gauze in both the forearms and administer drugs, fluids. They will alert the blood bank and send pathology and the sample for cross match. The in charge nurse will procure drugs, give oxygen, and arrange for invasive monitoring, documentation, and alert the pharmacy regarding various drugs which are required. So it's a team of 4 or 5 people which are required for a patient who is massively bleeding, and you need a multi-prong attack. And simultaneously, you have to alert blood bank, simultaneously to start fluids, give oxygen, maintain airway, and so on and so forth. Now, one person will quickly, after stabilizing the patient or he's being stabilized, will ask for history, whether the bleeding is new or if there is previous history of bleeding, whether patient has suffered a trauma, injury, or a procedure or a vascular intervention, whether the puncture site is bleeding or not, any intervention has been done in recent past which can be a cause of bleeding. And or patients has some bleeding disorder in past, inherited bleeding disorder such as platelet dysfunction, von Willebrand disease, hemophilia, and so on. There may be some causes of acquired coagulopathy like liver-induced coagulopathy, or patient is on medication, patient on antiplatelets and anticoagulants, which may cause lowering of threshold of bleeding. A trivial trauma may start bleeding. So initially you have to assess the patient, and we all know American College of Surgeons classification of acute hemorrhage, in which class 1 is blood volume loss less than 50%, class 2 is 15 to 30%, class 3 is 30 to 40%, and class 4 hemorrhagic shock is more than 40% of blood volume loss. And you can see that in stage 3 and stage 4, only patient develops overt hypotension. Otherwise, there is no significant hypotension, although you may see a telltale sign like delayed capillary refill, tachycardia, some tachypnea, and patients may become anxious and confused in the latest stages of shock because of CNS hypoperfusion. And stage 1 is mild stable patient, stage 2 moderate patient, shock responding to fluid, stage 3 shock responds transiently for 20 minutes and again patient becomes hypoxemic and patient does not respond even to 2 aliquots of 500 ml of crystalloids. This is stage 3. And stage 4 shock is shock which doesn't respond, and this is blood volume loss of more than 40%. You have to identify the source, like injury or trauma, extremity bleeding. If there, you have to apply compression, give tourniquet, look for GI bleeding. If you are not able to find out the cause, put Rice tube and find for GI bleeding. If there is any hematuria or a prior history of liver disorder, any hemorrhagic fever nowadays, a lot of patients are coming with viral hemorrhagic fevers. They may bleed as a first presentation to hospital, or patient's drug history should be taken into consideration while dealing with those patients. By point of care testing, I mean other tests also, although the tests like Amol discussed, Rotem and TAG, they are actually point of care testing in bleeding patients with, when we want to know the exact situation of the coagulation status of the patient. But other tests also like ECG, random blood sugar, the EFAST ultrasound assessment, ABG, chest x-ray, I would also consider into point of care because you can apply that test within minutes on the bedside of the patient. We all know the EFAST scan, wherein different the chest, the ultrasound probe is kept in different positions over the lungs on both the sides, over the flanks on both the sides, in subxiphoid area, and we diagnose different problems, especially when patient has undergone has suffered a trauma. You may have a torso injury and patient might have some bleeding inside the peritoneum. So it is the earliest thing by which EFAST we can apply bedside immediately, which is not invasive, cheap and repetitive for monitoring and diagnosing trauma in these patients. You can see initial free fluid in the Morrison's pouch. And so coming on to TEG and ROTEM, which is already discussed extensively, it gives you specific coagulation disorders in real time, guiding hemostatic therapy. Whether you want to give coagulation factor concentrates or drugs can be decided on TEG. Now, it can also differentiate between the surgical causes of bleeding and medical causes, so that you can go accordingly, and you can alert your surgical team to take the patient to OT, operation theater, for arresting bleeding in some cases. Now, I want to highlight this paper which was published in Trauma Surgery and Acute Care, where they have stressed upon that even if the TAG or ROTEM is not available, we can still design an algorithmic approach to these patients, especially of trauma, where viscoelastic testing is not available. And you can see there is some color coding, and there are some basic checklist where you have to look after airway, oxygen, send laboratory test, look for logistics, then maintain pH, maintain normal temperature, hypothermia is bad, maintain ionic calcium of the patient, then go into medical history. As soon as possible, if the patient is actively bleeding, give tranexamic acid. Fibrinogen can be given in the dose of 30 milligram per kg body weight, looking into certain factors which we are going to discuss in subsequent slides. Prothrombin complex concentrates nowadays, they are being advised more and more because of the advantage of low volume. And as Milankari said, 4-pair PCCs available, which will reduce the chances of trally, which will reduce the volume load, and small volume can be infused. And PCC is preferred over plasma nowadays. It can be given in an active bleeding patient. Even though you have not initiated massive transfusion protocol, PCC can be easily given to these patients to arrest bleeding. Now, in case of massive transfusion protocol, we all know that we have to initiate the transfusions of blood and blood component in 1:1:1 proportion. And platelets can be also given to keep a threshold of more than 50,000 in all patients. And in patients who have got traumatic brain injury, the cutoff is about 1 lakh. Last but not the least, in a desperate situation when nothing is working, you can use factor 13 and the recombinant factor 7A, although studies and meta-analysis has not shown any survival benefits, but still it can be used in certain situations. This is the decision tree of, in nutshell. Tranexamic acid can be given in almost all patients. Please mind the color code. Green is you have to wait, yellow is you have to be cautious, and orange and red you can give immediately. So as far as fibrinogen dosing is concerned, you may not wait for fibrinogen report to come. You can just check hemoglobin, you can just check base excess, and if possible fibrinogen level to know whether we want to give fibrinogen or not. So if hemoglobin is between 10 to 12 and base excess is the less than -6, then you can start with fibrinogen of around 1 gram. And if hemoglobin is between 8 to 10 and less than 8, you are supposed to give fibrinogen. So these parameters like hemoglobin, base excess, and lactates can be seen quickly in ABG. Prothrombin complex concentrates are recommended in moderate to severe bleeding only. FFPs is again given in patients who have liver-induced coagulopathy or patients in whom you have initiated massive volume transfusion. Desmopressin can be given in patients who have qualitative platelet defect. And you have to maintain tissue perfusion. You have to give balanced crystalloid solution, which is grade 1B recommendation. Hypotonic fluids like ringers should be avoided in patients who have simultaneously traumatic brain injury. You can add vasopressors and inotropic support according to situation. Hemodynamic monitoring should be done in all these patients who are massively bleeding, who are unstable to start with on admission. Maintain a mean arterial pressure of more than 65. Try to find out the lactate levels, and it should be less than 4. Patient should pour about 0.5 ml per kg of per hour of urine output while you are resuscitating the patient. Catheterize this patient. Monitor blood lactate serially. There is a concept of targeted hypotensive resuscitation. We'll come to next in the next slide. Large volume crystalloids are not recommended because this causes dilutional coagulopathy, and it will increase tissue edema and increase morbidity and mortality. Now, targeted hypotensive resuscitation is a relatively new concept, and you have to restrict the amount of fluid, restrict the amount of colloids to these patients, and while we are maintaining a blood pressure of about 80 to 90, so that the perfusion is maintained, but blood pressure doesn't go too high to again start bleeding of a vessel which has stopped bleeding. If you increase the blood pressure by pouring a lot of fluids and volume, the patient may develop tissue edema and bleeding might increase. So target BP in these patients is around 80 to 90, and it can prevent blood loss, it can reduce the need for blood products and improve patient recovery. Biochemical environment and clot-friendly environment is mandatory for this patient. Maintain temperature because it causes, it reduces the clotting factor. Hypothermia reduces clotting factors, it reduces platelet function, it increases fibrinolysis, and also it prolongs PT-PTT, right? So effort should be made to avoid hypothermia. Put a warmer blanket in the patient whom you are resuscitating very fast. The patient is not covered well, so try to cover with warm blankets. Serum lactates and base deficit should be monitored in this patient, and they are also the downstream marker of poor tissue perfusion. The lethal triad of bleeding and trauma is hypothermia, coagulopathy, acidosis. It should be treated aggressively, and also you should keep in the back of your mind the serum calcium levels, because adequate coagulation will require normal calcium level. Tranexamic acid has been much thought of and discussed, and it is an antifibrinolytic agent. Early administration in especially two situations, trauma and postpartum hemorrhage, within 3 hours can save life, and the trials have proven, like women trial in PPH and crash 2 trial in trauma, have proven that it should be advocated before hospitalization of the patient, while patient is coming into ambulance, somebody should administer tranexamic acid to these patients, and it should not be given in isolated head injury. And recent halted study has shown that there is no benefit in use of tranexamic acid in gastric bleeds. So it is not recommended in other situations except trauma and PPH. Hematocrit, single hematocrit value may be misleading. It is not the gold standard, and it may confuse you. And you should have a serial hematocrit monitoring. It needs about 4 hours for hematocrit to show some changes of hemoglobin, and entire compensation take around 48 hours. And in an acutely bleeding patients, the hematocrit may not reflect anything. You have to assess the blood volume. Anemia management, restrictive transfusion strategy of if the hemoglobin is less than 7. But if hematocrit is not giving you idea, you should always assess the amount of blood loss and give blood accordingly. Restrictive policy of transfusion has shown improvement in survival and also improvement in coagulopathy. Massive transfusion, we all know that if the loss of blood volume is more than 40%, or if there is 4 liter of blood loss, 2 liters of blood loss in 3 hours, or blood loss of more than 150 ml per minute, then you have to initiate massive transfusion protocol, which will be discussed in a subsequent lecture. Time is precious, we all know. There should be fast initial assessment, resuscitation, and prevention of bleeding if there is extremity bleeding, or if there is a GI bleeding, we should call for help and do urgent upper GI scopy to arrest the bleeding. Minimize the time elapsed. It is recommended that if there is a overt cause of surgical bleeding, we should wheel the patient to OT as soon as possible to improve survival. Damage control resuscitation, we all know it is non-surgical intervention to stop bleeding, and the components are permissive hypotension, minimize crystalloids. Massive transfusion protocol should be initiated if the significant blood volume loss is there, and goal-directed correction of coagulopathy guided by viscoelastography, as we have already discussed. Prompt and proper trial has shown that if you initiate MTP protocol in 1:1:1 proportion, it has shown to improve survival. And trials have shown that blood and blood products are given in the ratio of 1:1:1 in first 24 hours to reduce mortality. Tourniquet use should be done, especially if there is extremity bleeding, because pressure compression will not stop the collaterals or small bleeders. So you have to apply tourniquet. The time of tourniquet should not be more than 2 hours, and surgical intervention should be initiated as soon as possible, because that will stop the bleeding permanently. Call for help, either surgical help or anesthetist help, obstetric for postpartum hemorrhage, gastroenterologist for a GI bleed. And this is a very important narrative view which I came across: early goal-directed hemostatic therapy for severe acute bleeding, which has given a very important inference, like viscoelastic testing has been associated with reduction in transfusion utilization, improves morbidity and outcome, and it has shown that if you use prophylactically improper and more number of blood and blood products, it is going to increase morbidity and mortality. These are the 10-step approach and 10 commandments. ABC, tissue perfusion have to be maintained. Anemia management judiciously with restrictive policy. Then biochemical environment like treating acidosis, hypothermia and hypocalcemia should be done. Bleeding source should be identified and arrested. You can do early goal-directed hemostatic therapy in guidance with ROTEM or TEG. Early administration of tranexamic acid is especially important in trauma patients and postpartum hemorrhage. Labs should be sent early. Blood bank should be alerted for blood and components. Platelet function can be assessed in those patients in whom the patient is not responding, bleeding is not getting arrested, and you should always keep into mind newer oral anticoagulants which are now many of the patients are taking, and you should know what are the antidotes of these patients. So the main 3 pillars are to manage anemia, to prevent bleeding, and to avoid unnecessary transfusions in this patient. Thank you for patient listening. Thank you.
Thank you, Deepak. And as rightly professed by Nikhil, you have kept the depth and the length both perfect. So I would call this presentation an updated, most recent advances in management of acutely bleeding patients in ICU. Bleeding patient in ICU, as we all know, are a nightmare, and maybe we can even call it a minefield to traverse. Of late, because of improved blood bank services, and I would also call improvement in intervention radiology, both have made things a bit easier to manage, although bleeding in ICU is one of the most adverse prognostic factor. I have nothing more to add, and I would pass on to my two colleagues.
Yeah, thank you. Deepak sir, wonderful lecture, quite detailed. The crux of your lecture, the image you have shown, it is basically the heart of your lecture, that the structured approach. Many a times people ignore ABC and directly jump to the managing the patient. The beauty of intensive care is to keep the patient alive, and the images you have shown in that thing, like two sisters, a junior doctor behind, and intensivist. So wonderfully presented. Thank you, sir.
Excellent talk, sir. Sir has been guiding us physicians who practice in periphery, like I practice in Bhandara, for such critical patients, bleeding patients and other. Only thing I want to say is such patients require a team, not only intensivist, we need the help of surgeons, intervention radiologists, and all the other pathies patients who will, along with the RMOs and nursing staff who help. A single person, single physician cannot manage patients.
Yes.
Okay,
Thank
thank you.
Forum is open for questions.
We are using bioreactors. What is the practical standing for that? Fluid responsiveness, two most important things which are important in this patient is monitoring ultrasound for fluid responsiveness. You can see global end diastolic volume by bedside ultrasound. You can see inferior vena cava diameter, whether the diameter is small or it is increasing after giving fluid challenge. Most important minimally invasive thing is putting an artery line, and you can activate pulse pressure variation in your monitors. Nowadays every monitor has got PPV, and if PPV is more than 12, that means patient is fluid responsive, you can give more fluids. And if PPV is less than 12, then patient is not fluid responsive, you have to stop. But here fluid responsiveness is difficult to assess, because patient is very critical, he is exsanguinated because of bleeding, and just by seeing IVC or seeing PPV, you cannot push in more fluids, because this fluid is going to add on to coagulopathy, dilutional coagulopathy. So a word of caution for giving fluid, because in other patients we gave 2.53 liters of fluid also, and then we de-escalate the fluid. But in bleeding patients, it is better that you give blood and blood components if patient is bleeding heavily. Thank you.
So Deepak sir, one short question. Now, with the good use of a direct acting oral or DOACs in many patients, so how frequently do you get this kind of patient for reversal? And about the availability of the reversal agent for dabigatran and other things?
The drugs are, antidotes are available, and the beauty is that dabigatran, the company, the research company has given an insurance, and as soon as the patient comes with dabigatran induced injury, bleeding, the company will reimburse the entire expenses of hospitalization and everything that is given by company, but it should be dabigatran, which is the research products are, right? And these drugs are available now, but as far as you ask the frequency, it is very less frequent as far as my hospital is concerned.
Thank you. Thank
you. Yes, Sanjay.
4-factor PCC contains, apart from the factors protein C, S, antithrombin, and heparin. What is their role?
This I have just touched the approach to bleeding. The the next lectures are in detail about it. They will cover the entire thing. Thank you.
Catch is thrombosis because they contain CS, so they can also lead to thrombosis. That's a catch with using 4-factor concentrate.
So what is the use of adding heparin, protein CS, and antithrombin to it?
Still, they lead to thrombotic events. Activated protein,
They are
the
antithrombotics.
4-factor.
They are antithrombotics.
No, but still, one of the complications of using 4-factor concentrates is thrombotic events.
So to prevent those antithrombotic events, heparin is added. So we have to be.
Initially, they reduce protein C and protein S for first 24 hours.
Yeah.
There is a time when they go into thrombophilia.
One additional reason is to keep these factors in the non-activated state. That is number one reason. Number two is probably what sir has said. And number three is probably those patients who are having heparin-induced thrombocytopenia, you have to be cautious of using these agents because they contain very little heparin. So they are relatively contraindicated in HIT patients. Thank you.
Thank you. I will like to take this opportunity to recognize my fellows, the critical care training, to the doctors who are undergoing critical care training, IDCM training at Criticare, to acknowledge them and thank them for whatever help they are doing it for me since last so many years. Just to mention few names, I'll request them to come forward. Dr. Tushar Pandey, Dr. Mukesh Mahajan, Dr. Dilip Shirsagar, Dr. Suhas Tiple, Dr. Manas Bindra, Dr. Apur Gharwal, Dr. Paras Jurke, Dr. Avinash Gandhare, Dr. Snehal Daga, Dr. Bhushan Itkedwar, Dr. Sanjeev Bains, Dr. Amol Mishram, Dr. Shailesh Lute, Dr. Prasad Udhoji, Dr. Shweta Golkar, Dr. Gunjan and Dr. Ankita. I really thank them from the bottom of my heart. The amount of work, all around that day and night, and इन्हीं की वजह से मैं जिंदा हूँ. You भी will. They are lifeline. Please. Please come forward. A big round of applause. Shailesh, please. Thank you all for making my day, and thank you for everything you have done for me. Thank you. Big round of applause.
Thank you, Deepak sir, for that enlightening talk on the approach to bleeding patients. Your insights will undoubtedly enhance our understanding in management of bleeding patients. And I feel all your fellowship students feel privileged, truly blessed to have learned under your guidance. I now request Dr. Nikhil Bhalanke sir to present a token of appreciation to the chairperson.
एक मिनट. सर देना बोलना बोलना. I request the chairpersons to please present a memento to Dr. Deepak Jaswani sir. उनका ही है लेकिन देना तो पड़ेगा ही ना.
Thank you, sir. Marching to our next topic, when platelet count drop in ICU, for which I would like to invite as chairpersons Dr. Rajiv Bankar sir. He is a physician at Government Medical College, Nagpur. Dr. Mrinalini Hardas ma'am. She is a assistant professor of medicine at IGGMC Nagpur. Dr. Nishad Dhakate sir. He is a consultant hematologist and medical oncologist at HCG Hospital, Nagpur. So,
Thrombocytopenia is not just a condition. It is a sign that the body is battling something more profound, more often silently. I request Dr. Samir, now Dr. Samir Melinkeri sir will delve into the causes, implications and management strategies of thrombocytopenia in ICU. Dr. Samir sir.
Thank you. So the topic of the discussion is thrombocytopenia in the ICU. So just as an introduction, the bone marrow at any point of time contains about 1 trillion cells, and it produces about 200 billion red blood cells, 100 billion white cells, and about 400 billion platelets into circulation each day. So each of the platelets survive for about 7 to 10 days in the circulation, and then are utilized. But transfused platelets stay for about for a variable period of time. And when you collect these platelets and kept them in the blood bank, they last for about 5 days. So thrombocytopenia generally defined as a platelet count below 1.5 lakhs. And thrombocytopenia can occur in almost up to 50% of patients admitted in the ICU for a prolonged period of time. And the platelet count is controlled by complex interactions regulating platelet production within the marrow, pooling within the liver and spleen, and their elimination in the reticuloendothelial system. And patients with severe thrombocytopenia that continue sort of, they tend to have a higher mortality than in non-thrombocytopenic patients. The important thing is that generally thrombocytopenia in the ICU, supposing the patient came in with a normal platelet count and went to the ICU and 10 days later started having thrombocytopenia, the hematologist actually has no role at all, right? You can't have a patient developing blood cancer in the ICU in 1 week's time. So obviously the hematologist has a very little role to play here most of the time. It's actually the intensivist and the physician or the treating doctor who has to just put into his mind and find out why exactly the platelets have dropped. Okay, so that's what platelets look like under the scanning electron microscope. A little bit about platelets. So the dots that you see in the purple dots that you see over here, these are the platelets. And in general, in one oil field, when the pathologist looks under the microscope and he sees one platelet like this, he will call it as a rough platelet count of 15,000. If he sees two platelets, he'll say the rough platelet count is 30,000 and so on and so forth, right? So as you can see here, the platelet count looks normal. That is the megakaryocyte from which the platelets are budding off from the cytoplasm of the megakaryocyte. This is inside the bone marrow. So coming to the causes and mechanisms of how thrombocytopenia can develop in the ICU. It's much different from thrombocytopenia that develops in a hematological patient, right? Okay, so we come to a case each, and then I'll illustrate one case to discuss each mechanism. So a 67-year-old male who had an acute coronary injury and a PTCA was planned, and then he received all these drugs. And then 6 hours post-intervention, the platelet count, which was 2.7 lakhs in the baseline, dropped to 6,000 in just in a matter of hours, or in a matter of few days, in a matter of within 24 hours. It will suddenly drop to this. So anybody has an answer as to what the cause would be? Anybody? Sorry? Hit. That's the last thing ever. I'll come to hit in the next slide, very next slide. Okay, in the very next thing. So the first thing is you must look at the peripheral blood smear, and you can see that these platelet aggregates that are formed here, right? So this is called EDTA-induced platelet agglutination. Now, what happens is, this is actually, this can be seen in normal individuals also, about 1 in 1,000 people. When you take the platelets and collect them in the EDTA will alter the surface antigenicity of the platelets and make them clump. So it's only an in vitro phenomenon where actually inside the body, the platelets are normal. When you take them in EDTA, they clump, and so you can't measure the platelet count properly. And the pathologists look at the smear and tell us that this is a pseudothrombocytopenia or platelet agglutination. But important thing is that
the GP2B3A antagonists, apixaban, eptifibatide, and tirofiban, they are known to actually increase the incidence of pseudothrombocytopenia. Okay, so you must look at the previous first, and if it's like this, don't unnecessarily sit giving platelets, etc. to these patients. But in addition to this, they can actually cause a genuine severe drop in the platelet counts also in a very small percentage of patients, and you must know this, right? So thrombocytopenia due to 2B3A inhibitors can be either true or pseudothrombocytopenia. True thrombocytopenia can be severe and rapid within 24 hours. That's the incidence. So less than 1% of people who actually receive these drugs actually develop this kind of thrombocytopenia. You have to differentiate it from HIT. Because HIT has a later onset, and of course the anti-PF4 assays which are now available will help you in diagnosing them. The mechanism of this thrombocytopenia is some people, or in general, in majority of drugs that cause thrombocytopenia, some individuals tend to have naturally occurring, the way we have anti-ABO antibodies which are naturally occurring in people. Similarly, you can have naturally occurring antibodies which, when the drug comes into the body, they activate it and they cause thrombocytopenia. So, naturally occurring drug-dependent antibodies that occupy the 2B3A receptor. So, examining the PBS is the key to preventing unnecessary interventions, and the treatment whenever it is a true thrombocytopenia due to GP2B3 antagonist is cessation of the drug. And the platelets will revert within 24 hours. Tirofiban, usually it's an infusion. You stop it within 24 hours, automatically the platelets tend to rise. So thankfully, most patients will not bleed over here, and platelet transfusions will not help over here at all because they just get consumed very rapidly. So coming to this important topic of drug-induced thrombocytopenia, which is probably, I would say, the second commonest cause of thrombocytopenia in the ICU. Mechanisms of drug-induced thrombocytopenia can be one, bone marrow suppression, and that's non-immune thrombocytopenia. And the second mechanism is drug-induced immune thrombocytopenia. Bone marrow suppression, typically chemotherapy drugs, will cause dose-dependent thrombocytopenia most often, and they will not suppress only the platelets; they suppress all the other cell lines also. So obviously it is because of the drug. But azathioprine, linezolid, carbamazepine, valproic acid, all these drugs may not cause dose-dependent thrombocytopenia. They can cause genuine thrombocytopenia also. Lenalidomide is another drug which we use very commonly nowadays in hematological disorders, and that can cause thrombocytopenia. And the NSAIDs also can cause. So these are, of course, the vast list. If you look at the net, you'll see lots of drugs which are occasionally known to cause thrombocytopenia, but these are by far more common. Now, drug-induced non-thrombocytopenia. So it's a direct cytotoxic effect of the drug on the platelets. I'm sorry, this is actually immune thrombocytopenia. I'm sorry, it's not non-immune. It may or may not be dose-related. So coming to heparin-induced thrombocytopenia, a very important topic. In this, there are antibodies which develop against the heparin platelet factor 4 complex. So there are two types of hits. One is the hit 1 and hit 2. Now they are called non-immune hit and immune hit. The non-immune hit typically happens within 1 to 4 days. And the important thing is that it is a very benign drop. So suppose the patient came with a platelet count of say 2 lakhs, and then you started the heparin and dropped to 1 lakh, okay, or it dropped to 1.5 lakhs. Now 50,000, 1 lakh drop sometimes, which happens immediately after starting heparin. Don't get bothered by that. Continue the heparin. Okay, immune hit doesn't happen within the first 1 to 4 days. This is generally not benign drop, and it's generally not a very massive drop. You can continue heparin. It tends to just go off on its own. But the immune hit typically happens between 5 to 14 days after exposure to heparin. It is immune mediated, and there's a drop of more than 50% from the baseline, but the platelet count almost always will remain more than 20,000. Okay, you can't have a 5,000 platelet count because of hit. Generally, it will be more than 20,000. The treatment is fondaparinux. Any of the DOACs can be used, and babalurudin, agatrobran used to be used, but nowadays we don't need them most often. Absolute contraindication in hit is any heparin, including hep flush, should not be used.
warfarin should not be used, and platelet transfusions, absolute contraindication over here. And then there's a third type of hit called as the autoimmune hit, in which the heparin can actually induce an autoimmunity, where the heparin is gone from the circulation, but there are autoantibodies which are developed against the platelets, and that's induced by heparin. These are some of the mechanisms in which you can have, this is the 40 score for as a pre-test probability for hit, right? So I won't go through this in too much detail. It's all available in your textbooks. But just to mention that the thrombocytopenia will be more than 50,000, but the platelet nadir will be more than 20,000. So if you have a platelet nadir less than 10,000, it is less likely to be hit. The timing of the platelet fall, most important, between 5 to 10 days, and or if the patient has been exposed to heparin in the past and there is some such history and already antibodies are developed, then when you expose it into heparin again, supposing he had a hit earlier, now you're giving it again, within 24 hours you can have platelet counts dropping. Okay, so that's just one important thing you must know. And then thrombosis, the other sequelae. If thrombosis is there, very important marker towards the diagnosis of hit. And if there are other causes of obvious alternative causes of thrombocytopenia, then again the chance of it being a hit is less likely. So if you suspect hit, you perform that 40 score, and if the score is high, then you do a PF4 assay. This is now available in quite good labs. And why it is available? Earlier it was not available anywhere in India. But after vaccine-induced thrombosis developed, secondary or COVID vaccines, that is also exactly mediated by the same mechanism. It's against the platelet factor 4. So that's why PF4 assays, ELISA came in quickly, and many labs now have it available. So you can ask for this test, and you get the report pretty soon. If it is positive, then you're actually supposed to do a serotonin release assay or other important tests, other tests which sort of confirm the diagnosis. But these are unfortunately not easily available at all. So therefore, most of the times we rely on the 40s and the PF4, and then you assume that it is hit and treat it that way. Drugs which can cause the immune thrombocytopenia, all of these are known to cause immune thrombocytopenia, and these are some of the mechanisms in which they can cause, but I won't discuss this in detail. There are various mechanisms of how immune thrombocytopenia develops in these. So drug-induced immune thrombocytopenia develops about 5 to 10 days after the drug exposure. Bleeding risk is generally in a small percentage of people. But how to suspect that a drug has caused thrombocytopenia? Very simple. You just note that the thrombocytopenia occurred after the exposure to this drug. No other drug was started along with this drug, and complete recovery after discontinuing this drug. Just basic common sense. And treatment, platelet transfusions generally don't help so much. IVIG in high dose may help in some of these cases. And you have to, of course, withdraw the drug. The second case, this is a 17-year-old gentleman. He had a resection anastomosis of the small bowel. He required re-explosion for leak. He had melena, and again he had UTI, low-grade fever. Platelet counts dropped to 10,000. Patient received platelets, romiplastin, IV immunoglobulins, and steroids under the cover of appropriate antibodies. All this was given to this patient. So consumption-related thrombocytopenia accounts for majority of the cases in ICU. Most patients will have some sort of infection going on somewhere, and that sort of causes a lot of consumption of platelets. And if the infection is chronic, one infection, then some other UTI, some other infection here and there, constantly platelets get consumed. So sepsis is an important cause of consumption of platelets. Along with that, if you have bleeding to add to it, then the platelets are going to really drop down more significantly. If there's DIC, of course, no doubt, we discussed DIC a little earlier. And if you have HLH also, that's an important cause of consumption of platelets, right? So here you must check the PT-APDT serum fibrinogen, make sure there's no DIC. If there's DIC, you correct it. If it's deranged, you give FFPs and repeat as required. If fibrinogen is low, give cryoprecipitates. Maintain the platelet counts more than 50,000 when you suspect a consumption-related thrombocytopenia. A hemostatic platelet count more than 50,000. So you must maintain that. If bleeding if bleeding is there, measure Suarez the same. Dr. Jeswani just discussed all of these things, and you can follow it and arrest the bleeding. Third case is a 30-year-old lady who came with purpura and oral mucosal bleeds, and her CBC showed a platelet count of 2,000, but the hemoglobin and the WBC count are perfectly normal. This patient is seen in the casualty, and because of the platelet count of 2,000, patient is immediately admitted to the ICU. PT-APDT here is normal. What's the diagnosis? Quickly. Yeah, it's ITP, right? ITP patients, well, a hematologist generally doesn't admit these patients in the ICU, but physicians will feel worried and tend to admit the patient in the ICU. This patient will go to my general ward. So is it dengue? Right? Is it dengue? Well, what are the pointers towards dengue when you see a thrombocytopenia? One, because of the hemoconcentration, the hemoglobin will tend to be high. Second, leukopenia is common. Third, lymphocytosis with reactive lymphocytes will be seen on the peripheral smear. And if the patient is actually recovering from the dengue, then monocytosis will often be seen. So these are pointers toward the fact that it could be a dengue infection. Investigation on ITP, just a good PBS examination, HIV and HCV in all patients, because these can cause ITP, biochemistry, PT-PDT, and bone marrow only if you suspect that there could be an alternative diagnosis. But if you don't, PBS is clearly normal, everything else is normal, only isolated thrombocytopenia diagnosis is ITP, and you start treating it with IVIG, steroids, platelet transfusions only if there's ongoing bleeding. Otherwise, if you transfuse platelets within 10 minutes, they're all going to get destroyed, right? So only if there's bleeding, you give it. So role of TPO agonists, they are not approved in acute ITP, but we often use them off-label sometimes to quickly get the platelet count up. They actually used only for approved for chronic ITP. Well, this patient did receive Eltrombopac in addition to IVIG and steroids, and subsequently 4 days later the patient platelets were 70,000. They improved, but the platelet developed a cerebral venous sinus thrombosis. Right? Now, how to manage this? So, management of thrombosis with thrombocytopenia. So, you give therapeutic dose of anticoagulation if the platelet count is more than 50,000. Reduce to prophylactic dose, that is half the dose, if the platelet count is less than 50,000. And stop anticoagulation if the platelet count is less than 20,000. Okay. In very high risk situations, this is exceptional, but sometimes you have these antiplatelet antibodies which are activating thrombosis, and there you can actually anticoagulate even at platelet counts below 20,000, but that's only with a consultation with a hematologist. Okay, the third case, patient presents with altered sensorium. These are the blood counts, hemoglobin slightly low, TLC, DLC normal, platelet count is 10,000, CT is normal. So with 10,000, you would suspect an ICP, but the CT is normal. And that's the report. What's the diagnosis? Yeah, so the diagnosis is the PBS shows cystocytes here, LDH is raised. You saw the hemoglobin was low, and this is thrombotic thrombocytopenic purpura. Very important differential of ITP. You must differentiate it, otherwise you're going to land up in trouble. And this is because of reduction of the ADAMTS 13 levels, because of it's generally an autoimmune disease, or rarely it can be congenital as well. These are the drugs which can known to cause TTP, and here you have because the ADAMTS 13 is not there, you won't have large molecular weight, large multimers of von Willebrand factor in the circulation, which spontaneously aggregate platelets and cause platelet clots within the circulation, right? And secondarily, the red blood cells, when they're passing through these platelet clots, they get chipped. But because there is no activation of the coagulation system, there's no coagulopathy here. It's only platelets which are decreased, and that's the lab platelets are decreased. LDH is high, schistocytes are seen in the peripheral blood, hemolysis is seen. Treatment of TTP: don't give platelets ever. Give daily plasma exchange and immunosuppression with steroids and rituximab, and sometimes you can use antiplatelet drugs as well. So you must know how to diagnose a TTP and suspect it. Typically, when they come with neurological symptoms and you have actually ischemia in the brain rather than bleed, and you have some anemia and thrombocytopenia with the presence of schistocytes in the blood, you diagnose TTP. Next case is the case of chronic liver disease with portal hypertension admitted with hepatic encephalopathy. He's got a pancytopenia. The PT is deranged. There's no bleeding. In this patient, are you going to transfuse platelets? You're going to transfuse FFPs? No. Right. So important to know that in hypersplenism, there is sequestration of blood cells. Right? Now, here the platelets are the part of the exchangeable pool of platelets. So what happens is, it's like the platelets are only sequestered transiently in the spleen. Whenever they are required, they will come out. A massively enlarged spleen can sequester about 90% of the platelet mass within it. But the patients generally don't bleed, because when the body needs them, they can immediately spleen will contract and push them out. So generally these patients don't bleed. So if an invasive procedure is planned, one can use TPO agonists to actually push out the platelet count more. And platelets are transfused only if if it's like to get the platelet count up to somewhere around 50,000, but that's a little it's not very clear, because you really don't know what actually the platelet count is when you have a hypersplenism. So generally, only if you're going for a major surgery, then only you should transfuse platelets or give TPO agonists. And of course, you use vitamin K and FFPs if there's an invasive procedure plan. And the last case, polytrauma, 10 RBC concentrates are given within 4 hours. The CBC on admission was like this, with a hemoglobin of 5 and platelet count of 1.5 lakhs. Post transfusion of all these RBC concentrates, the platelet count dropped to 30,000. So this is typically dilutional thrombocytopenia, because when you give RBCs, you've diluted out the coagulation factors and the platelets, and therefore they become low. Here, you must just transfuse platelets and make sure the platelet count is more than 50,000. And of course, if you've activated the massive transfusion protocol, the 1:1:1 ratio of RBCs, platelets, and FFPs must be given. So a platelet transfusion, in general, one random donor platelet will have 10 to the power 10 platelets. One SDP will have 10 to the power 11 platelets. So how many RDPs will make one SDP? 10, correct. So about 8 to 10 RDPs will make one SDP. The shelf life is generally 5 days, but they need to be kept at 24 degrees on an agitator. And one RDP raises the platelet count of a healthy individual by 10,000, but in a patient who's got a lot of consumption, it may not be this high at all. Transfusion triggers for platelets is the lecture on this, so I won't discuss in detail, but in ITP and hypersplenism, only if there's a major bleed. When there's a consumption-related thrombocytopenia, you maintain platelet count more than 50,000. Post-chemotherapy, generally we maintain 10 to 15,000. If it's below that, we transfuse. And therapeutic procedures, if you're going for any surgery or any biopsy, you need a platelet count of more than 50,000. For neuraxial anesthesia, you need 70,000. And if you're going to go for a delicate surgery like barium parenchymal surgery, delicate retinal surgery, or plastic surgery, you need a platelet count of more than 1 lakh. That's general guideline. So just to revise the mechanism of thrombocytopenia, platelet underproduction, generally you will have an association of, associated underproduction of all the other cell lines as well. So you have anemia and thrombocytopenia as well whenever there's a marrow problem, right? So all of these are marrow related problems, which you generally don't get to see in ICU unless the hematologist has admitted that patient in the ICU. Increased destruction is the immune-mediated thrombocytopenia, autoantibodies. There'll be isolated thrombocytopenia most often, alloantibodies and drug-dependent antibodies. And non-immune mechanisms, we discussed consumption because of sepsis and DIC and hemophagocytosis. And sequestration because of hypersplenism, and hemodilution because of massive blood transfusion. So with that, I thank you. Sorry, it was a big topic, so I had to just rush through it a little bit.
So it's very small questions from me, sir.
Sure.
Which antibiotic is preferred in an ICU setting when there is thrombocytopenia?
So the answer to that question is whatever the patient, whatever the infection actually demands it, you just need to give that. Don't bother about the thrombocytopenia, because the thrombocytopenia is a rare event. It is not very common. So don't bother about whether in a thrombocytopenic patient whether I can use XYZ drug or not. If you feel that drug is really important for that patient, just use it by all means. If you feel that it is genuinely causing a significant drop in the platelet count, you can decide to withdraw it. But supposing there's a patient of ITP who's got a platelet count 10,000 and it requires some antibiotic, and you want to give linezolid or whatever, vancomycin or whatever, please give it. Cephalosporin, please give it. Because the chance that the patient will actually develop thrombocytopenia because of the drug is very low. An occasional patient only is going to develop it.
Secondly, whether we need to withhold aspirin or clopidogrel or antiplatelet agents in a patient who has dropped platelets or thrombocytopenia?
Yes, that's a good question. So aspirin, so it depends upon how much the patient needs the aspirin. So supposing it was for a secondary prophylaxis. If it was for a primary prophylaxis because somebody gave aspirin because the patient had diabetes and he thought there was some ischemic disease, but there's no clear documentation, there you wouldn't be too worried about taking off the aspirin. But if it's for a secondary prophylaxis, meaning the patient actually had a stroke or he's got obvious coronary artery disease and he needs the aspirin, then I would be worried about taking it off, and I would actually want to continue it unless the platelet count is probably above 50,000. Surely I'll continue it. If it starts to drop below 20,000, surely I'll stop it. between 20 and 50,000, I'll see how important that drug, the aspirin, is for that patient and decide to continue it.
Samir, good morning. That was a fantastic lecture, and it's nice to see you here. Yeah, really nice to see you here. The case scenario presentation was fantastic. It really gave us a good insight into.
She was my 1 year senior in BJ, and I didn't recognize her actually. Now that she started talking, I recognized her.
Yeah, that's
I'm meeting her after
30 years.
Yeah.
Very nice. It was really good. Really good.
So that was an excellent talk. Sir, I have a question. Patients who are on aspirin and now they need an emergency surgery.
Yes.
So what would you advise?
Just
Give?
go ahead. Just go ahead. You just operate.
Do you give platelet transfusions before the surgery?
No. So the thing is, unless if it's like a delicate surgery, you're really concerned.
Neurosurgery?
Yeah, neurosurgery, then you probably may. But it's important to know that, the platelet transfusions actually don't help so much. When you give platelets in a dysfunctional environment, either uremic environment or when you have antiplatelets sitting over there, when you give those platelets, they immediately become dysfunctional again. So you would have to really give a lot of platelets to mop up all that aspirin, so-called, and then have some more platelets. So it's a very what should I say? It's not like a clear-cut answer, but you would give probably a huge number of platelets if you think it's going to be a delicate surgery. Otherwise, for any other routine surgeries, most of the times we don't stop aspirin at all. Just continue in an emergency situation. But not so if it was clopidogrel or prasugrel or any of those drugs. There, of course, you really need to stop.
Same line. Is there any absolute contraindication, any surgery which you should not do when the patient is
A very delicate surgery where you think is high risk of bleeding.
What about prostate surgery, sir?
That's one of the most important ones. Prostate
So-
surgery is very important.
Yeah. So another, I had since this program is also live on FB, I had a comment to make. Actually, whenever in the season dengue, we get all the reports of thrombocytopenia. One thing I was thinking that this message should be loud and clear that diagnosis of thrombocytopenia should be done by a pathologist. It should not be taken from the machine report. Many times we all know how the machine calculates the platelets. It was very surprising for me when one of my pediatric colleague, told me, sir, ऐसा कैसा होता है मशीन में इतना दिखा रहा लैब वाला बोल रहा है कि इतना नहीं ज़्यादा है. This message should be very loud and clear. In today's era, when there are mushrooming labs of DMLTs and all who just take out the reports and give, we should not believe them. We should ask the pathologist that about the platelet count and then only act. This is a very important thing. Otherwise, unnecessarily the patients are getting platelet transfusions and all.
Thank you.
Sir, if I may ask a question. Good morning, sir. Sir, in critically ill patients and mainly septic, if they're having severe cytopenia, especially thrombocytopenia, can we consider giving Septran to this kind of patients if they are sensitive to it, considering it may worsen the cytopenias?
No, not at all. Just give it. We give it to all our lymphoma patients who are on chemotherapy, etc. We always use.
Okay, sir. Thank you.
Just one more question from an obstetrician. Patient is in my care from last 2 years. She is having a platelet count between 50,000 to 70,000 and now planning a cesarean. So what should be the precautions I should be taking before cesarean and what are the tests? I have sent him to the hematologist, but they said everything is okay. So I think it may be ITP. Yeah.
Probably a chronic ITP. If it's a cesarean section,
Yeah.
I would just go ahead without bothering too much.
Okay.
Because in pregnancy, particularly towards term, the blood is so thrombogenic because the coagulation factors have really increased. So it's a very thrombogenic situation. Platelet count of 50,000 is not a problem whatsoever.
Okay.
You can just go ahead.
Okay. Thank you.
A drop in platelet always feels like a bad omen and often turns up in ICU like a bad penny. Thank you, Samir sir, for your enlightening and comprehensive disclosure on such a common yet frightening topic. Thank you, chairpersons, for your valuable insight. I now request Dr. Deepak Jeswani to please present the chairpersons with a memento as our gratitude.
नहीं रुक जाओ, उसका होने देना उनका। थोड़ा जल्दी जल्दी मैंने कट शॉर्ट कर दिया था।
Stepping on to our next topic is Road to Resuscitation, for which we would like to invite as chairpersons Dr. Nitin Kimmatkar sir. He is a consultant orthopedic and trauma surgeon at Kimmatkar Hospital. Dr. Sachin Chinche sir, he is a managing director at Chinche Hospital, Katun. Resuscitation in polytrauma isn't just about saving a life. It's about stabilizing chaos where the body systems are under siege, and every action taken is a step toward reclaiming stability. We are honored to introduce to our next speaker Dr. Ravindra Ghawat sir. He is an eminent figure in the field of critical care medicine. Sir is currently the director of critical care at Jupiter Hospital, Thane. Sir is a distinguished faculty member at various national and international critical care conferences and workshops. Among his accolades, Sir has received a prestigious Scopes Award for Best Paper Presentation at the Anesthesia National Conference in Kochi. He is one of the author of the recently published Dengue Guidelines by ISCCM. Sir will be sharing his insights on the road to resuscitation in polytrauma. Please join me in welcoming Dr. Ravindra Ghawat sir. Sir.
Thank you for those kind words. It always feels homely when I come to Nagpur, Amravati at this region, because I'm basically from Nagpur and I have completed my graduation and post-graduation from Nagpur. So it's been privileged, and thank you Deepak for giving me this opportunity to share some views and discuss things with you all. So before we can get down with the presentation, how many of you are working in the ICU here or intensivist? Very few. And how many of you are running the nursing home? Excuse me, can you help me with this? Okay, what do you, we'll start by the time these slides are ready. What do you understand by polytrauma? When do you say that the patient has a polytrauma? So when do you say that the patient has polytrauma? Suppose a patient comes to you with a fracture of tibia, profusely bleeding, hemodynamically unstable, with no other injuries. Is it polytrauma? So polytrauma is when there is a significant injury of three or more points in two or different or more than two different body regions, with one of the following variables that we have, that the patient is unconscious, has acidosis or coagulopathy, and an elderly patient, and if the patient has hypotension. So then we call it as polytrauma. And when you think about resuscitation a patient of polytrauma, in the initial resuscitation phase or during the resuscitation phase, there are few main goals that we need to follow. The first thing is identifying and immediately treat the potential life-threatening problems. while the patient is undergoing a primary survey and then switching over to secondary survey. Like obviously, as I said, if there was a fracture of the tibia and you can see blood loss going there, you can do a compression and packing there. If you see that the air entry is decreased grossly, you can see a lesser chest movement on one side. Probably there is a tension pneumothorax and hemothorax and patient is hemodynamically unstable there. So rather than going through the primary and secondary, so you can directly think about putting in a tube or a needle to release the air or the volume. It usually requires more than 1500 ml of hemothorax to actually cause a hemodynamic compromise. And simultaneously, because the sonographies are available, bedside focus is available in most of the hospitals and even in nursing homes, by the time you do a complete the surveys, you can also look at the circulatory assessment and look at the abdomen and thoracic cavities to see a source of bleeding. The second thing that you need to think about is whether I need to transfer this patient or I am good enough after the initial resuscitation. My setup is good enough to actually manage this patient, and these decisions needs to be quickly taken because the patients can really exsanguinate or patients can really die fast with trauma and polytraumas and multiple injuries. And with simultaneous resuscitation, there is a concept of permissible hypotension which will come to, and then of course early surgery and damage control resuscitation and damage control surgery whenever it is possible. So I am not going to go into the details of this, but as we all know, when we talk about trauma and primary survey, you need to go through those A, B, C, Ds and E, and you need to stabilize the spine and look for foreign bodies, and whenever the GCS is down and the patient is massively bleeding or has obstructed bleeding, you need to intubate those patients. Remember that whenever you are using sedative doses in this patient, you need to give 25% of the dose that you would usually give for a normal patient, and give some good resuscitation or volume resuscitation before you actually give sedation and then intubate the patient. While you are looking at the breathing, always watch for the chest, do a percussion. Tension pneumothorax can be relieved, and that can be the reason for hemodynamic instability, and the rest of the things as they are. Again, then you switch over to secondary survey. Simultaneous monitoring is important, and prevention of secondary injuries is also important. Your goal is always to maintain adequate oxygenation and adequate perfusion. And when you are giving crystalloids, you need to have a fluid warmer because large volumes of crystalloids would be required. You need to have all those routine monitorings like ECG, blood pressure, ETCO2 if possible, urinary catheter. That will give you two ideas. One, you can monitor the urine. Second, if there is a pelvic injury, you might have hematuria and probably would know about whether there is a pelvic injury or traumatic bladder injury. Gastric catheters, you need to be careful when you're putting a Foley's catheter in this patient because you can actually, increase the trauma if there is a urethral rupture or something. Gastric catheters to decompress the stomach and if there is any evidence of bleeding, and of course the blood lactate to know about the perfusion, X-rays, fast as I said before, and the diagnostic peritoneal lavage if it is required sometime. So when you look at shock in trauma, the most important thing in a patient who has come to you with polytrauma is identification of the shock and which type of shock it is. We know that the most common shock is the hemorrhagic shock, but at the same time, rest of the shocks, you can have, as I said, a tension pneumothorax or a hemothorax or even a cardiac injury causing a cardiac tamponade and then an obstructive shock. A severely contused myocardium and then leading to a cardiogenic shock, or a trauma to the spine with complete quadriparesis and a neurogenic shock, right? And you need to identify that septic shock in the initial period would be less likely, but in the latter phase, yes. But the most important cause is hemorrhagic shock, and as the talk may be, we will focus on that. And previously, Deepak mentioned about the types of hemorrhagic shock. So the important thing is the hypotension becomes apparent only when the shock is at the third stage, so that is very important. So remember that you need to identify shock in hemorrhagic patient or bleeding patients early. And the hypotension is probably not the way you can identify the shock early because it appears only when the blood loss is more than 30 to 40%, especially if younger patients, they have good compensatory mechanisms and they don't develop hypotension so early. So tachycardia is something which you can look at there. You can look at the tachycardia which is usually an earlier sign, and a pulse pressure, which is very important, where you can probably diagnose the difference between the systolic and diastolic pressure, which can easily be measured by measuring a blood pressure, which probably drops in the class 2. So usually the blood products would be required. So by the time you diagnose hypotension and shock in a hemorrhagic patient, you are already on the verge of a severe injury 1, and then the patients require transfusion. Sometimes you might have to actually activate the massive transfusion. So early identification of the shock is extremely important. So with that baseline, now we move on to what is about trauma resuscitation. So basically there are four key principles that you look at when we are resuscitating a trauma patients. The first is control of bleeding. The second is restoring a tissue perfusion. The third is when you are doing resuscitation, you should not cause any iatrogenic injury, like you are giving massive transfusion. You know there are so many problems with blood transfusion. When you are giving large amount of crystalloids, there are other problems. So you should try to minimize iatrogenic injury from the resuscitation itself and promote hemostasis. And we will look at them one by one. The first is minimizing iatrogenic injury. Now, if you, the concept of balanced resuscitation or controlled resuscitation or permissive hypotension, it is about maintaining a lower blood pressure than a physiologic blood pressure. So normally blood pressure would be 100, 110, 120. That's what you would usually want to maintain. In a patient who is actively bleeding, if you maintain a normal or a higher blood pressure, the patient is likely to bleed more. And that's why a current concept is about a permissive hypotension, which will not be detrimental to the patient. At the same time, it will not cause excessive bleeding. And the usual recommendations, acceptable recommendations, recent recommendations are for a penetrating trauma, especially the blood pressure should be kept systolic at 60 to 70, for blood trauma around 80 to 90, and without head injury. And if there is head injury, you require little higher targets. And do we have any evidence for that? Yes, we have enough evidence to say that even when they looked at patients where the target blood pressure was more than 100 systolic versus 70 systolic, there was no difference in mortality regardless of which target systolic blood pressure you maintain. Mind you need to be careful about patients who are elderly and patients who have a higher chronic arterial hypertension, whose body and organs are used to having a higher blood pressure mean. So for somebody who is hypertensive and keeping a blood pressure of 180 by 110, for him 20% drop of or 30% drop of 140/80 is also hypotension. And if you keep them at a systolic blood pressure of 70 and 80, that would be really, really low. So you need to look at an individual patient, what his blood pressures were, and you need to go into the history and look at those. So do we have evidence for the permissive hypotension in TBI patients? So what this study has shown, that this is a shock, this is the study from the Shock Journal in 2012, and it showed that SPD target of more than 90, it resulted in a mortality of 7.8% versus SPD target of less than 90, where the mortality was 33.4%. So there was higher mortality when the targets were less than 90 in head injury patient. So that's why in head injury patients, you have to keep a little higher target for maintaining a systolic blood pressure as compared to a patient who has laser targets in patients who have other injuries rather than head injury. Now, this is like a cycle which is called as a cyclic hyperresuscitation. So if you have a patient with hypotension, you resuscitate, you give blood, the blood pressure goes up, the patient starts bleeding again. Then again you sort of resuscitate, the blood pressure drops, you resuscitate, the blood pressure goes up, patient bleeds, the blood pressure drops down, again you resuscitate. So the cycle continues, right? And this is called as what is called as cyclic hyperresuscitation, and that is detrimental, and that's why sometimes goal-directed therapy is not a very good tool. So what you look at actually is the clinical parameters, like targeting physiological markers of perfusion. You look at the mental status of the patient, you look at the urine output, you look at the capillary field, and these are more important than actual targets. As I said, for different patients, the target for blood pressure might be different. We see many patients in our OPDs and IPDs, young females who come with a blood pressure of 90 and 100, and they would always say, "Mera blood pressure kami rehta hai," and they are all healthy, walking, talking, running, doing all their work. So their systolic or their pressures are set at 90 congenitally or traditionally, So here, probably you require a laser beam. So similarly, like I said about the hypertensive patient. So what you look at is that the endpoints of resuscitation, at endpoints what you are getting, apart from in clinically like mental status, urine output, and capillary refill. As far as fluid resuscitation is concerned, we talked about fluid resuscitation a lot. The principle is limiting the use of crystalloids and give blood as much as possible when there is a blood loss. Give blood and blood products more and limit the use of crystalloids. What happens, you give a lot of crystalloids, resuscitate, the patients become volume overloaded, and then we give blood. So that becomes an additional volume challenge for the patient and the systems, and then it can be detrimental. The choice of fluid, as far as choice is concerned, in traumatic brain injury, it is normal saline, whereas in other patients, you can use normal saline or a balanced salt solution. Why do you choose balanced solution over normal saline is probably because of the development of hyperchloremic metabolic acidosis, which is associated with large volume normal saline resuscitation, which contains higher chloride as compared to balanced salt solution. So balanced salt solution, but in traumatic brain injury, you don't require a hypotonic or isotonic fluid, because normal saline is slightly hypertonic as compared to the blood plasma. That's why you use a normal saline, which would be helpful in brain edema. Colloid albumins, hypertonic salines have been studied and not been found to be very effective. What is again important is to assess the patient's response to fluid when you are using it. And usually once you have resuscitated a patient with 1 liter of fluid, you need to look at the response, whether the patient is really responding to my fluid challenges and resuscitation. So the patients can be divided into rapid responders, transient responders, or minimal to no responders, so depending on the response. So usually those who are rapid responders would return to normal once you give a 1 liter of fluid challenge. Approximately, that it's not 1 liter is 1 liter. Transient responders will stabilize on their blood pressure and heart rate, and then again they will go back to hypotension and tachycardia. And the no response would be continued to be having low blood pressure or tachycardia or abnormalities even after giving fluid challenges. Why this is important? Because on this basis you can actually plan your management. So if you look at the downside of those that table, the need for operative intervention is highly likely in a non-responder, likely in a transient responder, and possibly in less. Even blood transfusion is immediate here, right? The estimated blood loss is very high. Here you may not use a cross-match blood pressure, and in emergency transfusion, a quick transmatch would be required here. And you need to inform the surgeon immediately if you have a patient who is non-responder. Overzealous fluid resuscitation is detrimental in the first 24 hours, and it has been shown to be associated with increased mortality and morbidity. It also increases the duration of mechanical ventilation, and it also increases the risk of acute coronary syndromes in patients. Once you have resuscitated the patient and you have controlled everything, it is very important to de-resuscitate. There are various methods. You can restrict the fluid, or sometimes you also have to use diuretics to de-resuscitate, because again, if you have fluid overload, and it has been shown that if you have a patient who is over-resuscitated, the outcomes are less, the morbidity increases, the duration of ventilation also increases, especially in patients who have show signs of tissue edema, compartment syndromes, or pulmonary complications. Do we have evidence for this? Yes. This is a trial for NHGM in 1994, and it showed that when crystalloid fluid resuscitation can be counterproductive, and delay of aggressive crystalloid fluid resuscitation until hemorrhage control is achieved improves outcome. If blood products are not available, consider small volume. Rather than giving big volumes, give small volume just to maintain the permissive hypotension. And then once the blood products are available, replace blood for blood. That would be a good strategy. The other thing that is a little bit controversial, rather everybody of us use vasopressors to maintain blood pressure. The question is, when you use blood pressure, will you use vasopressor? Will you use vasopressin or noradrenaline on a patient who is empty? So somebody who has an empty tank, you give vasopressor, the detrimental effects can be more. It can actually cause limb ischemia or ischemia of the gut or many other organs. So the initial phase of trauma, the patients usually have a sympathoexcitatory phase. They try to compensate, and the blood pressure is maintained. And the subsequent phase is a sympathoinhibitory phase. Probably this is the phase where you require vasopressors to maintain the blood pressure. After initial resuscitation, it would be a good thing to administer vasopressor. The Abbott shock trial showed that the use of vasopressor is controversial and requires a nuanced approach, and you have to actually choose a patient where you want to use it, where you don't want to use it. Simultaneously, you need to continue resuscitation of fluid and then use vasopressors with increasing dose. and not directly. In this trial, a bolus of vasopressin was given after the control of bleeding, and it was shown that where the patient received boluses versus where they did not receive, there was a difference in mortality. But there were controversial trials one by one, and at present you cannot recommend whether the vasopressors should be immediate, like bolus of vasopressors would be started. It would be good to start an infusion of vasopressors and simultaneously resuscitate the patient with fluid and blood. So summary of iatrogenic injury, you need to have permissive hypotension, crystalloids minimize, but if needed, give 250 cc to 1 liter of boluses, vasopressors nonce approach, and the BP targets are controversial. Rather than having targets, have the targets of resuscitation. About restoring perfusion, we know the lethal triad of trauma is hypothermia, acidosis, and coagulopathy, and there are various reasons why the traumatic patients can have coagulopathy. One is a cause which is known, which is an endogenous coagulopathy which can develop within 30 minutes after trauma. The other is the consumption coagulopathy because there is loss, the products are used. Dilutional coagulopathy because you're giving lot of volume and the blood and the products get diluted. And hypothermia, as has been discussed before, as well as an independent risk factor for coagulopathy. So volus replacement again has to be more with blood as compared to crystalloids. And this JAMA article tells us, or this study tells us, that there is no difference in overall mortality at 24 hours, but 1:1 achieved hemostasis, faster and fewer experienced death due to extinguishing at 24 hours. So initially, before this proper trial, the idea was to give 1 FFP or 1 platelets for 2 blood transfusion, and now that has changed over a period of time from 2015. The newer guidelines are that for each blood you have to replace with 1 FFP and 1 platelet. So 1:1:1 ratio has to be followed, which has been confirmed in this trial, but there were some controversial result in the refill trial, where they did not find any benefit, but this trial had to be stopped before it could be achieved because of it could be completed because of the COVID-19 pandemic. So at present, we still follow the same rule. Now, which patients require massive blood transfusion are those patients who have a penetrating mechanism of injury, or those who have systolic blood pressure of less than 90 or heart rate of 120. We have a positive fast on the abdominal ways, and if the score is more than 2 present, then probably you will have to consider be ready for the massive transfusion. This score has been modified for the shock index, which is into the shock index is derived from when you divide heart rate by the systolic blood pressure, and if the shock index is more than 1, now the modified shock index also mentions about mean arterial pressure. But if the shock index is more than 1, that means if your heart rate is 120 and if your blood pressure is 90, so obviously the shock index is going to be maybe 1.5. So as the shock index is more and more, the patient is more severe and more hypotensive and more in shock and likely to require transfusion. The other question is whether we should use a whole blood or a component therapy. The current guidelines says the argument is that whole blood gives you other components as well. But if you use PRVC, you can restrict the volume. The evidence are coming more towards use of whole blood now. So that is the summary of how you restore the perfusion by giving plasma platelets RBC in 1:1:1. Negative trial, but then that doesn't change our strategies till now. And of course, the coagulation parameters corrections and so on. What about promoting hemostasis? I think Deepak talked about this tranexamic acid, the CRASH-2 and CRASH-3 trial. The CRASH-2 trial was for trauma patients who were bleeding and where they used tranexamic acid for 10 minutes and then for 8 hours and placebo where it was not used. And what they found was tranexamic acid given over 10 minutes as compared to when it was given over 8 hours versus when it was not given, it reduces the risk of death in bleeding trauma patients when given within 3 hours of injury. So some benefit when it was given within 8 hours, more benefit when it was given within 3 hours. And because it was a twice a day or thrice a day dose, they also found that when you give a bolus of 2 grams, that was better because then you don't have to give it again and again and you can lose the dose. So that was additional advantage. The CRASH-3 trial was done for predominantly traumatic brain injury patient, and where it was found that the risk of head injury related death in patients with mild to moderate head injury was reduced, but not in patients with severe head injury, where the GCS was 3 to 8, right, or less than 8. But in moderate injuries, it was found. So in traumatic brain injury, whether you should give tranexamic acid or not is again controversial, and you can individualize the patient. If you want to give, you can give only a single dose of tranexamic acid. It should not be continued for more than 24 hours. That is very important to know, that if you continue it for more than 24 hours, then the chances of thrombotic complications are more. Cryoprecipitate, again patient-based and value-based if you want to control bleeding. And this trial looked at the feasibility of cryoprecipitate being administered, and they found that it is not very feasible in a setup. Probably it was feasible there. What are the labs target? Usual transfusion triggers is platelets. In trauma bleeding patient, you try to maintain it more than 50,000. If there is head trauma, then more than 1 lakh, INR of less than 2, and a fibrinogen of more than 150 or so. And if you give 10 cryos, it would increase the fibrinogen by around 75. Calcium infusion is very important. It augments the clot formation, and because of the citrate in the blood products, it dilutes the calcium. We know that. So you can give calcium chloride, which is usually not available with us, or you give calcium gluconate for 6 units of 6 gram of calcium gluconate for every 6 units of blood products as an. So usually it's a practice that when you are having massive transfusion, you put them on either calcium gluconate infusion, or you give them in repeated doses. What is the role of TEG and ROTEM? Yes, it looks very fancy, and you can, the advantage that you can individualize this component therapy, whether you want to give FFP, whether you want to give cryoprecipitate, or you want to give, tranexamic acid, the antifibrinolytic, or a platelet, or a desmopressin. Yes, it helps in it, but the problem is it available? Is it not available in every hospital, every nursing home? So is it going to help? Whether you want to change, check a coagulation parameter, suppose you say the PT-PTT INR, or people had some recommendation that you should monitor hematocrit every 4 hourly. Is it feasible? By the time, see, the problem is blood products are given so rapidly. The patient is bleeding, patient is hypotensive during resuscitation, that it is practically impossible to use standard labs to guide product administration. By the time you get report, you would have lost and what is the downtime for getting the reports, isn't it? So it's not that easy to monitor the frequently. So you have to go by clinical parameters. And the other thing is, when you are using TEG and ROTEM, I will take some 5 minutes extra. Is that okay? I have a next presentation which would be 10 minutes. So, because most of the things I'll cover there. So I'm sorry for that. So no, not every institution have that. And the other thing is, when you are doing a TEG or a ROTEM, the sample has to be really, really processed very fast. So you need to take a sample and immediately it has to be processed in the machine. If there is more than 2 minutes of delay, you are not going to get good results, because it calculates a graph. So that is, if you have a machine in the ICU, you have a machine in the OT, and you're collecting a sample and immediately processing, then it makes sense. But if you are collecting a sample and sending it to some other lab, which is 10 minutes, 15 minutes away, and then they process it after half an hour, and then you get a report, it is of no use, so it doesn't give you a good result. So again, as I said, if it is not available very readily, it doesn't really guide your resuscitation. More than that, clinical parameters are should be looked into. Now, there's a lot of talk about the 4-factor PCC, and a recent trial, which is a PROCAC trial published in JAMA 23, which showed that there was no difference in the median 24-hour blood product consumption when 4-factor PCC was compared versus placebo. And what they found was that the thromboembolism event was way high, 35% versus 24%, where the 4-factor FFP was PCC was used. So at this time, the use of 4-PCC is not supported in patients with trauma at risk of massive transfusion protocols, or who require massive transfusion, because it resulted in a higher rate of thromboembolic event. So those are the ways you can promote hemostasis that we discussed. That is the summary of that. The last and the most important thing is the controlling of the bleeding, and where can be the bleeding. That's where the external source or the internal sources are required, concerned. These are the major ones where you usually see bleeding. You look at the scalp. So head to toe examination of the patient is extremely important as soon as you get the patient. So yes, there is a methodology of looking at the primary survey, then go step by step A, B, C, D, E, and then go to. But what is important in the first place is to expose the patient completely, that even if it's a female patient, so that you don't miss a single injury or a concealed hemorrhage, right? So usual areas are where, which you can remember by this mnemonic called as scalper: scalp, chest, abdomen, long bones, pelvis, extremities, and retroperitoneum. And you easily have a sonography machine available. It is like a stethoscope, and you always palpate the abdomen and also do a fast, which can be quick. For controlling the bleeding, use these fastest strategies to get the hemorrhage control. So tourniquets, yes, we talked about it. Direct pressures, packing, sutures, interventional surgical repair, and definitive surgical measures. The concern with tourniquet is whether it causes a limb ischemia when they were applied. But when patients were applied tourniquet, they were less likely to arrive in shock in compared to no tourniquet. So when you are transferring the patient, or initially you are managing the patient, apply a tourniquet. Tourniquets result in decreased incidence of shock without increasing the limb complication, or if they are into minimum range. And when you are applying a tourniquet, what you can do is you apply a tourniquet, release it after 5-10 minutes, then again apply a tourniquet, release it, so that you also prevent the ischemia complications of that and you reduce the bleeding. Whether you use a larger chest tube or a smaller tube, it doesn't make a difference. The people have used a 14 gauge pigtail, French pigtail, versus 28 or 38 French ICD for hemothorax, and they found equal results with 24 French pigtail which was used for chest drainage. And so you can use 40 French safely, and it will also, the patient will also thank you for using a smaller tube, and it can be removed as well. The other advanced method is resuscitative endovascular balloon occlusion of the aorta, and you put a balloon at the celiac artery or above it, and then try to control a bleeding, a vascular bleeding beyond that. And there are again controversial results. One trial showed no benefit, while the other trial showed benefit. But it's an advanced therapy which may not be available all the time with us. But yes, if you have a therapy which is available, some centers do try it using this rubeola, and that you can use. Lastly, the damage control surgery is extremely important. What is damage control surgery? It is a set of abbreviated surgical procedures for rapid control of hemorrhage and contamination. So you look at the physiology. You don't open the abdomen and do everything, So you just do a very damage control. So wherever there is a bleeding, you just control it, suture in and come out, and leave the rest for the repeat surgery. So you do a damage control, put a chest tube, but don't look at the source. Even in the abdomen, if you have a massive bleeding from the liver, just pack the liver for the time being, come out, resuscitate the patient, and then go for a definitive surgery. That is what is meant by damage control surgery or damage control resuscitation. So in summary of bleeding control, the methodological use fastest strategy. Tourniquets, yes, it would decrease the complications, and patients would have laser shock. You can release the tourniquet in between. Chest tubes, smaller tubes are okay. And the Riboa device, the balloon dilatation you can use, but you require still more evidence and the expertise into them. So the most important thing is probably in our hand at present, and which is very feasible, is to do a damage control surgery as soon as you see that the patient is a lesser responder or not responding to your resuscitation protocols. So in summary, I'll come to the same points. When you are resuscitating a patient of polytrauma, these are 4 important things that you need to do. Control the bleeding by whichever means you can. Restore tissue perfusion, but beware that when you are with vasopressors, with fluids, with blood is preferred over blood-to-blood resuscitation is preferred, replacement is preferred over large volume of crystalloids, and don't use colloids. They cause coagulopathy and renal failure. But when you are resuscitating this patient with large volume, or also using a permissive hypotension, remember that you should minimize iatrogenic injury from resuscitation itself, and use some drugs like the tranexamic acid and others, on cryopacid and blood products to restore the hemostasis. This is a summary of whatever I have said. With that, that is the end of my talk. And the Mahacriticon, the State Conference of Critical Care Medicine, is happening in Thane this year on 22nd, 23rd, and 24th November. So please block your dates, and I would be happy to receive you there. And I personally invite you to join us in the conference. Thank you so much.
Hello. Excellent insights. Two questions on the floor as we are running late. Any burning questions? So till the people are ready with their question, I think uh, investigation of bleeding is very important. Whenever you are doing a primary survey, that is the main senior person should do the primary survey and see for the where is the bleeding form. So that control of bleeding is very important concept. I've seen that placing an ICD and placing an pelvic binder saves many lives whenever a patient of polytrauma has been received in trauma.
So in external injuries and traumatic injuries of the limbs and the pelvic trauma, it becomes extremely important to put an external bandage or an external pressure. It really save lives.
Thank you, sir. Thank you, sir, for your insights into the complexities of polytrauma resuscitation. It has given us a clear understanding of how to navigate these challenging cases. I'm sure we all feel better equipped to handle these cases now. I also thank the chairpersons for their valuable insight. Now I would like to invite respected Sanjay Jain sir to please provide the memento of our appreciation to our speaker Dr. Ghawat sir. Dr. Sanjay Jain is present president of AMS. Sir, request you to please present our token of appreciation to our chairperson. Dr. Nitin sir. We sincerely appreciate the presence of our esteemed teacher, senior teacher, Dr. Pandey Madam, Dr. Deshmukh sir and Dr. Mundle sir here. We are thankful for your presence, sir. Coming on to our next topic, that is transfusion triggers in ICU. For this session, I would like to invite our chairpersons, Dr. Ramesh Mundle sir, who is consultant physician and professor, Department of Medicine in NKP Salve College. Sir, we feel honored by your presence here today. Dr. Harish Barbhe sir, who is managing director of Blood Bank, Lifeline Blood Bank, Nagpur. His name is enough introduction for him in Nagpur. Dr. Devyani Buche ma'am, she is a consultant and general physician at Orange City Hospital and Research Institute, Nagpur. Ma'am is one of the most senior intensivists in Nagpur. In modern medicine, the focus has shifted from liberal transfusion strategies to a more restrictive approach, emphasizing the judicious use of blood and products. We are pleased to again welcome Dr. Ravindra Ghawat sir, who will be shedding light on this crucial topic. Blood transfusion is one of the most common interventions in intensive care, yet it comes with significant risk. I give you Dr. Ravindra Ghawat sir.
So I'm back again. नागपूर मध्ये असं एक I am seeing मी पुन्हा येईन is very popular in I said I must use that in Kenya. So I would first apologize to you for any for these slides because I was not supposed to give this talk. Fortunately, one of our colleagues who was supposed to give this talk, Dr. Bharat Jagas, is not well and he couldn't make it to the conference. He is down at Secretariat. So yesterday night only I came to know that I need to talk on this. So apologies for anything, but we will try to just look at the principles rather than the numbers and and let it be a discussion rather than interactive discussion rather than me talking and just telling about transfusion triggers. So basically, when you talk about transfusion or transfusions in a human being, what do you look at? Say a blood, hemoglobin or PRBC or a blood transfusion. Why do you transfuse blood? Can anybody give me a minute and tell me why do you transfuse blood? What are the basic reason why you transfuse? Or in other way, I just want to ask you why hemoglobin is important in our body. Why blood is important? Okay, very good. So the first thing is oxygen delivery. Because hemoglobin carries oxygen, yes, you require oxygen for aerobic metabolism of the body, and the whole body's metabolism is dependent on the oxygen. So how do you get oxygen to the cells and the tissue? It has to be through the blood, and the blood, how the blood carries the oxygen is by the hemoglobin. That is the first and important thing. The second thing is, what is the second reason why you require blood? Is that a very difficult question? Or you are hungry? It's 12:30 only. Volume. So maintaining the volume in the body, right? So if you have a major blood loss, you are going to have hypotension and hypoperfusion. So basically, we are looking at two things. One is maintaining the oxygen. The second is maintaining the perfusion. So the perfusion has to deliver the oxygen to the body, and that is why you require blood transfusion. And the question is then if we require the blood transfusion for so good, why not transfuse every patient? Why not transfuse every patient? Isn't it? Any patient comes to you, give volume and the blood pressure will be good. Why use crystalloid, vasopressors and so on? And because the primary reason why you give blood, the two reasons or the two goals that you look at for giving blood can be satisfied by the other methods. Number one. Number two, blood pressure, giving blood transfusion is detrimental to many patients because blood is an organ. Remember that blood is an organ, and every time you transfuse the blood or a blood products, we must think at the back of our mind whether I really need to do it. Again, ask the question to yourself, really I need to do it? Again, ask the question to yourself, really I need to do it? Okay, and the answer is yes, then give blood transfusion. Consider blood as an organ, like kidney transplant, liver transplant, or any other organ transplant. Giving blood is also giving transplant to the patient. Right? So we should try to restrict it as much as possible. At the same time, as we discussed, and you only said that there are two reasons which needs to be satisfied when you are giving blood transfusion. So you cannot accept a very low hemoglobin level, and you can have some hemoglobin which is acceptable, which will maintain the volume enough, and which will also maintain the oxygen delivery as such. And this has been studied and proved in many studies that the mortality increases when the hemoglobin is really low. And to tell you that if the oxygenation is a problem, at even a hemoglobin of when does the oxygen delivery really gets affected is when the hemoglobin is less than 6 or 5. Till that time it doesn't, and that too in patients when there is an acute blood loss. Acute blood loss. So in patients who have sort of chronic anemia, we see CKD patients who have hemoglobin of 6, 5, and they tolerate it very well. You don't need to transfuse them. Patients who have Jehovah's Witness, or patients who have this thalassemia minus, thalassemia and the deficiencies of enzymes, they tolerate the low hemoglobin very well. Most of our Indian females and women have low hemoglobin, and they are good at it. Patient. So if it's a chronic anemia which is going over a period of time, the hypoxia and even the volumes are well adjusted to that hemoglobin. So you need to look at whether I am having an acute blood loss or a chronic blood loss or a chronic anemia or an acute anemia. So initially there was a rule of 10 by 30, so for this is based on 10-30 rule that I think that in some of the talks it was covered that you have to maintain a hemoglobin of 10 and a hematocrit of 30. So it was like a blanket follow-up. You have a hemoglobin less than 10, give blood. If you have hematocrit of less than 30, give blood. But that is not true because it is not required. And looking at the various
problems that you have with the blood transfusion, like infection, allergic reaction, volume overload, and the most importantly, transmission of virus with HIV and HBsAgs, which is coming up very fast. Even a single prick, needle prick, the transmission of HBs is around 40%, 30 to 40%. That is a large amount of transmission. That you imagine how much transfusion happen when you are transmitting blood. I'm talking about the HBsAg antigen. A single prick, needle prick that you get, increase the chances by 30 to 40%. So then, how do you decide on what are the triggers when I should actually give transfusion? Okay, is it hemoglobin or hematocrit? Okay, it is easily measurable, but yes, it is a surrogate parameter for oxygen transport. Can I look at the delivery of oxygen? Very cumbersome to manage, not many calculations in it. It's not feasible option. ECG, okay. When would you have ECG changes when your hemoglobin is low? It has to really go less than 5. You can't wait till that time till you get an ECG changes. And again, in all patients, you may not get ECG changes, especially younger patients who may not have any ECG changes or so. So ECG cannot be a marker. SpO2, SpO2 again same. It does determine adequate tissue pressure, but a decline in both parameters is a part of the compensatory mechanism of acute anemia. Arterial lactates, it's a good indicator of tissue hypoxia, but it is neither sensitive nor specific for tissue hypoxia. And then you have these LIRS, that you use for a neuro patient, which allows you for other specific measurement for tissue hypoxia. So at present, if you look at all these things that you can actually look at, the most feasible looks like this, hemoglobin and hematocrit, but again you have to individualize the patient. So what do the guidelines say? Less than 6 gram, transfusion recommended exception, treatment except. So when the hemoglobin is less than 7, usually there is no trouble. Usually you would give, especially if the patient is acutely hypotensive or bleeding, then there is no doubt. If the hemoglobin is more than 10, yes, you don't transfuse because that is very clear. Even when it is more than 9, there is no trouble probably. What is the gray area between 7 to 9 when there is lot of fight between many doctors and intensivists and physicians and surgeons, especially surgeons who are giving blood transfusion to their patient, because they believe that the tissue healing is better when the hemoglobin is maintained above 10, which is not true. In fact, if you maintain a higher hematocrit, you actually decrease the perfusion, and when your hematocrit is lesser or where your hemoglobin is here, the delivery of the oxygen to the peripheries of the tissue is more, right? So it should not be too low, like less than 7, but it should also be not too high, because that is actually going to prolong healing. So the controversy is again between 7 to 8, where the transfusion is appropriate for this patient needs to be chosen on an individual precision medicine basis, whether that particular patient is going to give benefit by transfusion or is not going to get benefit by transfusion. For example, if you have a young patient who used to keep hemoglobin of 30, has a trauma or a fracture or an abdominal trauma, comes to you in the casualty with a hemoglobin of 10 and with acutely hypotension and profusely bleeding, will you stick to a criteria? No, the hemoglobin is 10, so I am not going to give. Like we learned in the last talk that it is to be given, isn't it? So for blood, you need to replace blood. For somebody whose hemoglobin was 14 has dropped to 10, here you cannot wait it to drop to 5 and 6, because you know that the patient is actually bleeding, and in the next half an hour to 1 hour, the hemoglobin is going to be 6. The other thing is, because you are not resuscitating the patient, because you are not giving the patient even a 10 hemoglobin may not be a 10 hemoglobin true, or a hematocrit which is 40 may not be a true hematocrit of 40. In fact, it is because of the concentration effect that with blood, lot of volume is also lost, and that's why the hemoglobin is appearing at 10. Right? So once you resuscitate that patient, you give 1 or 2 liters of pistol and you find that you will check a hemoglobin in this patient, it will be actually 7. It will not be 10. Right? So here, even a 10 hemoglobin is detrimental, and here you will be transfusing blood more for not the oxygenation, more for the volume resuscitation goal, the blood pressure, the perfusion goal, right? So the gray area needs to be actually addressed very well. Now, for specific patients, the patient is symptomatic. Suppose the patient has tachycardia, like you mentioned just now. Here you need to don't think about the hemoglobin level. Look at the patient actively bleeding, give blood. In acute coronary syndromes, the general dictum is to keep it above 8 gram percentage. If there is ongoing ischemia, if the patient is an acute coronary syndrome with ongoing ischemia, then you would like to keep it at 10. But yes, here the threshold is a little higher than the usual patients of patients on the threshold of 7 gram percent. Here you would keep it at more than 8. And there are many trials which have proved, which has been done in AMI and unstable anginas, and the big trial which showed that even 7%, 7 gram percent is good enough, and the mortality was in fact better when you restricted the transfusion to 7 gram percent. In patients with heart failure, ischemia, as I said, that the threshold would be 8 gram percent, usually for patients who are chronic, but somebody who is chronically has low hemoglobin of 8 or less than 8 or less than 9, you cannot transfuse them. So as I said, chronicity is better tolerated and you need to look at that. In trauma patient, again 7 gram is easily tolerated, and when actually you give laser transfusion, you actually cause a benefit to the mortality. Even in patients with GI bleed, it has been found that restrictive strategy had 49 patients undergoing transfusion versus 86%, so large amount of transfusion, fewer complications with restrictive strategy, lesser bleeding, subsequent bleeding event, fewer deaths due to uncontrolled hemorrhage in restrictive strategy, and fewer deaths as to any other cause. So it has shown definitely a benefit. Septic shock is very clear that we mentioned it, that 7 grams you won't need to transfuse in a patient if the hemoglobin is up to 7 grams percent. Less than 7, probably you need to transfuse. Sometimes we accept even 6.5 and 6, and as I said, we individualize the patient to whom to use transfer. Even for surgical patients, in post-operative patient, the threshold is 7 grams is good enough, unless and until the patient is actively bleeding and you see that the drains are going more and high, or the patient is inadequately resuscitated with fluid, where the hemoglobin reflection is not the true level of the hemoglobin, right? And that because the patient is hemoconcentrated, the hemoglobin is actually stable, and there you probably would transfuse them more. So again, and if the patient is hypotensive, then even at 8 hemoglobin you would start. In a CABG patient who comes, it's an ischemic patient, so who comes to you with a baseline 3 of hemoglobin of 12, post-op you find that the hemoglobin is 9, 10, okay, transfuse. Patient is hypotensive, you see drains have come at 400, you transfuse. Oncology patients, here probably in radiotherapy patient, because their vessels are very fragile and the ischemia, the tissue perfusion is grossly, you see oncology patients, they have usually very thin blood vessels, so their perfusion is really lost and the oxygen is lost. Radiotherapy patients, here you have a little higher process for transfusion, and maybe here you keep the hemoglobin at around 8 to 10. In summary, the excellent clinical trials suggest a restrictive policy of transfusion at hemoglobin of 7 to 8 gram percent should guide the transfusion decision in most patients. If the patient is clinically stable, then you can easily not transfuse at 7 to 8, and transfusion is not needed if the hemoglobin is 7 to 8 gram percent. Below 7, yes. Most medical and surgically hemodynamically stable, including those in ICU or with septic shock, they maintain, there you maintain a hemoglobin of 7 gram percent at a high threshold. Patients with underlying cardiovascular disease, here you have a threshold of more than 8 gram percent, and acute ischemia and continuous ischemia 10 gram percent. And there are exceptions to this rule where you would have a little higher threshold with patients who are symptomatic, patients with ACS, where you, as I said, you need to have a better hemoglobin concentration, and patients with ongoing ischemia. So to summarize again, in critical care, more than 7, less than 7 you transfuse. Post chemotherapy 8 to 9, radiotherapy 10. As we said about chronic anemia, you need to individualize the patient, and depending on the patient needs you transfuse. What about FFPs? Usually that is not required. Every time you see an INR for a patient who has come with acute liver failure or CLD, his INR is 3. Do you need to transfuse for the FF for the 3 INR? The answer is no. You transfuse FFP only in patients who are bleeding, and when the patients are actively bleeding, you don't transfuse FFP to prevent bleeding. You transfuse FFP only when the patient is bleeding, number 1, or number 2, if you are doing an invasive procedure. If you are doing an invasive procedure, for different invasive procedures, if you have different targets, and generally if your FFP is INR is less than 4, it is good enough, right? And in patients who are very actively bleeding, you would aim at an INR of less than 1.5 or 1.6. and the doses. What about platelets? For routine surgical procedures, more than 50,000, and there are recommendations that you can go through that, for different procedures, there are different recommendations. What is important to know is patients with head injury, if you want to do a lumbar puncture, you need a platelet count of more than maybe 80,000. If you are doing undergoing, patient is undergone a neurosurgery, you require a platelet of around more than 1 lakh. But for routine minor procedures or something, 50,000 is good enough, and you don't need to transfuse. INR target, as I said, is less than 2. Fibrinogen target, again, you don't transfuse cryoprecipitate, as we discussed in the last talk as well, that prevention is definitely not, even for therapeutics, every time you don't need to correct the fibrinogen unless and until the fibrinogen levels are really low and you have corrected the other factors and still the patient is bleeding, right? So then only you need to give cryoprecipitate. Calcium, we mentioned about it. These are some of the recommendations or general practices guidelines which are used for perioperative patients. So usually you can go through that. Usual transfusion triggers are hematocrits of less than 22 or 24. The dose is and expected increase is 6%, and you have to modify as per. If the patient is bleeding, maybe you will have to give more. If the patient has severe coagulopathy, you have to give a higher dose. The INR is more than 1.5, maybe 2 FFPs. So now more and more evidence and more practice is coming that what we usually used to practice earlier, that FFP then I okay, give 10 ml per kg, that used to be a standard dose, and you give 6 or 7, 8 FFPs, large volume FFPs. So more and more practice is coming up, or evidences are coming up for partial correction of your coagulopathy and thrombocytopenia, which is good enough to control the bleeding, and it also doesn't harm the patient because you can that way avoid the number of transfusions. So partially correct. If your INR is 3 and patient is bleeding, give 2-3 FFP. See if the INR comes down to your bleeding stop. Okay, good enough. If it doesn't stop, give another 2. Rather than giving bolus of 6 to 12 FFPs or even a large volume of platelets and so on. For minor procedure, less than 20 is also okay. For major surgeries, less than or more than 50 you would keep. That is a threshold, less than 50. And for active bleeding and neurosurgeries especially, then you require a higher threshold for pressure. We will just discuss 1 or 2 cases. They are very one slide cases. Now this is a 26-year-old patient who is bleeding profusely postpartum, tachycardic, BP is 80 or 40. Now after listening to these 2 talks or discussing or if you were all listening and not hungry, so this answer should be very easy. If the patient is tachycardic and BP is 80 by 40, patient is conscious, he shows a hemoglobin of 5.4, platelets of 1,50,000, WBC 16,000. Will you transfuse this patient? Yes or no? It should be loud yes. Yes. So there is no doubt about this that this patient requires transfusion and you will transfuse. Now there is another patient who is a 20-year-old student. He is drowsy, he is febrile, he has extensive fatigue after a brief illness. He had some illness for 6-7 hours. Hemoglobin is 8.2, platelets are 6. Sorry, WBC is 6,000 and platelets are less than 5,000. All other things are normal. PT, PTT, fibrinogen normal, creatinine is 1.8. But this patient has PTK. Will you transfuse this patient 1 blood, number 2 platelets? Will you transfuse? Yeah, so it may worsen with, Deepak has rightly said, you will not transfuse this patient. This patient is not actively bleeding. His all other parameters are normal. He has only thrombocytopenia, which is less than 5,000, the difference, and he has altered sensorium. And he had a brief illness before. So the differential diagnosis would be 2. One, it is TTP or aqueous creatinine is 1.8, and the second would be ITP. So even if you give platelets to this patient, you are going to increase the chances of thrombosis, number 1, and the platelets are going to get destroyed. So you repeat it after 6 hours, again the platelet will be 5. So here you require different set of treatment. Maybe plasmapheresis, maybe immunoglobulin and steroids and so on, depending on what is right. This patient requires a bone marrow examination. Now this is the 32-year-old male admitted with suspected dengue fever. That is the last case. Here the hemoglobin is 17. The WBC are 3,001. Common scenario in ICUs and wards. Platelets are 12,000. The PTT is slightly deranged. The PT is normal. What do we do? Now will you transfuse? I will not expect an answer from this. Let others know. How many of you actually transfuse? Don't forget the answer. How many actually transfuse? Let us be honest. Let us be honest. How many of you actually transfuse at 12 for a dengue patient? In fact, most of us do, but that is not correct. In our hospital, we have very strict policy. Many of the physicians, surgeons, or they admit the patient for dengue and they insist on transfusion. I categorically say no, because respiratory transfusion in dengue, again, unless and until the patient is actively bleeding, it doesn't help. They will come automatically good. You don't have to give steroids even, and the platelet count will automatically improve over a period of 3 to 4 days or 5 days. You just have to keep watch. If the patient is bleeding, yes. Otherwise, in fact, this patient requires more of hydration because his hemoglobin is 70 and the hematocrit must be high because it's not mentioned here. But this patient requires more of hydration rather than platelet. If you are unnecessarily exposing this patient for platelet transfusion, the risk of virus transfusion, so many risk factors for blood transfusion. So those were 10 commitments. We have discussed those, and these are the guidelines which you can go through. There are many guidelines about blood transfusion. Again, I would like to invite you for the Criticare, which is happening on 22nd, 23rd, and 24th November. There are some good workshops there, and of course the good scientific session. Please do come to Thane. Thane is becoming big now, and there are many places also to visit. Thank you so much.
Congratulations, Dr. Ravindra, for such a wonderful lecture. And let me tell you that we didn't feel for 1 second that this was this lecture you delivered at the 11th hour. So you were so very well prepared. That tells us about your ability and your status as a intensivist.
I think sometimes less preparation was better.
Yeah, I do agree. I do agree.
Because when you only talk experience. And
Yes, yes. And that becomes more natural actually. The slides were excellent and the carry home messages were very crystal clear. So, so restrict the transfusion, but give whenever it is necessary. And for that, you need triggers. So if there are any questions from the audience, you are welcome to ask him.
Yeah. Good afternoon, sir. So my question is, in a clear-cut case of iron deficiency anemia, and coming to OPD with relatively asymptomatic, not in failure per se, and hemoglobin is between 5 to 7, should we consider blood transfusion or should we give a trial of oral iron therapy?
So you can give trial of oral as well as IV iron therapy. It is not necessary to transfer this patient. As I said, chronically anemic patients, their body and systems are well accustomed to the low hemoglobin level. In fact, these are the patients who are likely to have more reactions. So if you acutely transfuse them. So this patient doesn't require transfusion. What you need to look at is the patient is symptomatic. Is the patient hypoxic? Are there any signs of hypoxia? Is the lactic increasing? Are there signs of hypoperfusion or hypoxia due to the low hemoglobin? So if it is a chronic anemia, you don't need to transfuse.
Thank you, sir.
Especially if it is a young patient. If the patient has ischemic heart disease, cancer, elderly patients more than 60, 70 years of age, maybe yes.
Thank you, sir.
Good afternoon, sir. Sir, my patient developed GBS after the blood transfusion, after some days. So, was there an antigen in the donor's blood which has resulted into the antibody? My question is there an association between blood transfusion and the GBS?
Yes. So, as far as the causes of GBS are concerned, there are many of the causes, and transfusion of blood is very, very rare. But yes, that is mentioned as one of the GBS. Yes, that is possible. It's very, very rare.
Okay. And sir, what is the success rate of plasmapheresis?
So plasmapheresis and immunoglobulins, they are equally successful when you are using it for any therapy. Any therapy. The only thing is that the plasmapheresis shows an immediate effect. So if you have a patient with TTP and who is acutely ill, I would probably prefer plasmapheresis even for patients with myasthenic crisis or even GBS who is severely, who is into a very, the progress is very fast. So probably plasmapheresis because it gives you an immediate result as compared to immunoglobulins. As far as efficacy of long-term outcome is concerned, they are the same. The efficacy is also same, but yes, the studies have shown that the efficacy is same. But if you ask me my individual choice for very sick, acutely ill patient, I would probably prefer plasmapheresis. And of course, the patient has to be hemodynamically stable for that, because plasmapheresis is associated with hemodynamic instability. Whereas in patients with acute renal failure, again, the IVIG can cause volume more when you require a lot of volume when you're using IVIG. So, of course, individualized therapy, but in acute situations, My personal choice is plasmapheresis, though both of them are equal.
Thank you, sir.
Thank you, sir, for delivering such an insightful and informative talk. I want to express our sincere gratitude for agreeing to step in at the 11th hour for this presentation, sir. This really showcases your expertise and deep understanding of the topic. Thank you very much, sir.
Now, I would like to invite Dr. Ajay Kaduskar sir to present a token of appreciation to chairpersons. Thank you, sir. Marching forward to our next topic, role of interventional radiology in bleeding patients, for which we invite as chairpersons Dr. Rajesh Munra sir. He is an interventional radiologist at Pulse Clinic and Hospital. Dr. Atul Revatkar sir, he is an interventional radiologist at Meditrina Institute of Medical Science, Nagpur.
Rajesh sir and Atul sir, I call them Yugal Jodi, and I would say they are synonymous with the name interventional radiology in Nagpur.
Dr. Ramesh Hassani sir, he is a consultant intensivist at 7-Star Hospital, Nagpur. Interventional radiology offers a lifeline to bleeding patients where precision guided techniques can stem the tide when traditional methods fall short. It is an honor to introduce Dr. Suyash Kulkarni sir, a distinguished interventional radiologist and associate professor at Tata Memorial Hospital, Parel, Mumbai, where he has been making significant contributions since 2005. He is a prolific contributor to medical literature with notable publications, including his work on percutaneous CT-guided core biopsy for the diagnosis of mediastinal masses, among others. Sir has also contributed to several book chapters, further sharing his knowledge and experience with medical community. Today, Sir will be discussing the critical role of interventional radiology in managing bleeding patients. Please join me in welcoming Dr. Suyash Kulkarni sir.
Just to correct, now Suyash is professor and head Department of Radiology at Tata Hospital. So, and he is a giant personality in the field of interventions. Suyash, please.
Thank you. So it's really a great pleasure and a privilege for me to come for this conference for the Criticare Convention. So when Deepak called me, I was so delighted. We immediately went back to our residency days and remembered our days together and thought that yes, I have to be there for this conference. And it's always a pleasure to come back to Nagpur and be among our own people. So I will say that role of interventional radiology, like as Deepak remembered me when it was GI bleed, I will request that all critical care people please remember an interventional radiologist when it is a patient who is critically ill because of bleeding. And in next 10 to 15 minutes, I will try to convince you that we are not interfering radiologists, but we are interventional radiologists. So in fact, there are many things that we try to do, and as this prototype goes, like a typical plumber who either opens up the blocked drainages or who seals those which are leaking. Similarly, in body there are many systems that we either open up or we stop the leaking, and one of them important is the blood vessel. So whenever there is bleeding, it is important to stop the bleeding, as even Dr. Ravi said, that the first thing that we need to do is to stop the bleeding. So many times we have this discussion, especially in an institute, that a patient is bleeding, so we have kept the cath lab vacant for the patient. Patient is being shifted. We are waiting for the patient, and we usually get the answer: we are first stabilizing the patient. We are first stabilizing the patient, and then so what I usually wonder that, can we really stabilize the patient when he is bleeding like a tap? The first thing that we need to do is to stop the bleeding, and then all the parameters will come up. And whatever we are doing in the ICU, similar things can continue over during the shifting as well as in the cath lab. But what is the priority here? And the primary problem is bleeding, and that needs to be answered. Another thing is that many times, as usually it happens, we will get these calls typically in the night or on Saturday or Sundays, because everything has been done to stop the bleeding, or everything that is possible has been done to stop the bleeding throughout the day, throughout the week. And then when it comes towards the weekend, or when it becomes the emergency hours, then we get the call. So it's not a problem in an institute, but the availability of seniors and availability of expertise may not be there in the emergency hours. So it is always better that we take the call to call for an intervention early than in emergency hours, so that we can provide the best care to the patient. So there are various systems which cause bleeding to the patient, and as we work in our institute, we go by the systems, like we have thoracic oncology, GI oncology, breast oncology, neuro-oncology. Similarly, there are systems. So I will describe the role of intervention radiology in various systems. So coming first to the most common, like gastrointestinal bleeding, and the usual causes that we come across are variceal hemorrhages, or related to peptic ulcer, polyps, solitary rectal ulcers. In our setup, because we are an oncology institute, most commonly related to the tumors. So it is very important to do the right imaging and right investigations before we take any decision for intervention. And there, one of the important intervention is the CT angiography. Now, if patient is not hemodynamically, if he is stable, then we can have a chance to diagnose him properly, and a good CT scan is the answer. I mean, that is the investigation which will clinch most of the diagnosis, and it can precisely pinpoint the site of bleeding. So a typical CT scan without oral contrast, because that might interfere with the contrast extravasation. So, and either biphasic or triphasic, properly done CT angio is the investigation that we need to take, so that we can take the decision whether to conserve the patient or whether to go for a conventional angiography. Now it is again, it should be done properly, that is important. And what we usually see, that sometimes we need to know that how much bleeding should be there to detect it. So all these modalities, none of the modalities will be 100% accurate. So each modality has its limitations. So similarly, even an angiography, like there are nuclear medicine studies also, with which you can make out in which quarter of the abdomen the bleeding is there. But to be precise, with an angiography, we can it is as sensitive as to detect 0.1 ml per minute of bleeding if it is happening anywhere in the body. But at the same time, negative CT angiography does not mean that there is no bleeding in the body. It sometimes, there are many factors that we'll discuss further. Although this is a busy slide, what I need to point out here is there are various terminologies that you will get in a report of a CT angiography, like there is extravasation, or there is arterial or venous bleeding, or there is a pseudoaneurysm. So all these are the words that we need to see in the impression of the CT angiography to understand whether the patient is actually bleeding and whether there is a need of an active intervention. So what is the role of interventional radiologists here? The basic role is to reduce the arterial bleeding and the inflow. Sometimes the inflow of the blood, so that the bleeding will be less critical. Sometimes it is not possible to completely stop it, that is very rare. But if it is like in mesenteric vessels, then we should always weigh the risk of causing ischemic damage as against decreasing the pressure head of the bleeding, so that even if we reduce the pressure head, there will be significantly less bleeding, patient can be stabilized, and then he can be taken for the definitive surgery or definitive treatment. So angiography, it is one of the important investigation and treatment for the patients. And what we usually do, we do embolization. So usually after doing an angiography, we block the vessel, and that is called as embolization. So embolization can be with particles, or it can be with liquid embolizing agents. So particles, as we say, the gel foam powder, or polyvinyl alcohol powder, or some mechanical embolizing agents, like there are sophisticated coils that we can use, or some liquid embolizing agents like the glue that NBC, I mean N-butyl cyanoacrylate glue that we use, which causes polymerization and thrombosis of the vessel. So essentially we do the embolization procedure. I will just show some typical cases. This was a patient who of CS stomach who presented with hematemesis and hypotension. So you can see that on angiography, this is the celiac angiography, and you can see this is a pseudoaneurysm. And on this, this is by the left gastric artery. You can see that this particular artery is been super selectively cannulated, and this is the cast of glue that we use. So glue is a liquid embolizing agent and it's a permanent embolizing agent. Whenever it comes in contact with the blood, it causes panangiitis and thrombotic occlusion, and also it gets polymerized and causes mechanical occlusion of the blood vessel as well. So immediately you get cessation of the bleeding, and on control angiogram you can see that there is no active bleeding. So patient was off inotropic support immediately. His hemoglobin was also restored, and patient has gone for further chemotherapy. This is another patient, hematological malignancy, and when they undergo the chemotherapy, sometimes the tumor gets sloughed off and the patient starts bleeding. This patient again had a hematochezia, and so we did angiography for him. Here you can see that there is active extravasation on angiography, and this is the sign of an active bleeding, and we need to go super selectively in that particular branch of mesenteric artery, and we can embolize it. So this is how it can be detected, and again we use blue over here. So there are some limitations. Why I am showing mesenteric angiography? Because even if we detect the bleeding, sometimes we do not embolize mesenteric angiography because it can cause mesenteric ischemia. So it is very important to have a dialogue with the treating physician that what is the risk of embolizing and causing mesenteric ischemia versus can we can delineate that particular segment of the bowel by putting dye like indocyanine green, and we can send the patient for surgery, and that particular segment can be resected if we have that much time. But if patient is hemodynamically very unstable, then it is better to go ahead, take some risk and embolize it. If at all patient develops gangrene, then electively he might be operated. So that we need to decide on table and with discussion of the treating physician. So this was again embolized, and after embolization there is no active bleeding. Patient improved significantly. This patient of renal cell carcinoma, you can see on CT scan, he presented with a hemoglobin of 2.7. On plain CT scan, you can see there is something over here which is enhancing on the contrast CT scan. So what this enhancing component is, the basically submucosal lesion which is a hypervascular metastasis, and that is what was the reason for bleeding. So on CT angiography we can definitely look for the source of bleeding, and then it can be targeted. This is the angiography for that patient. We go selectively into the gastric artery, and we can see the blush. This is the metastasis which is bleeding. Again, practically now the hardware has become so sophisticated that we can practically go in any vessel in the body. So we usually use a routine angiographic catheter, and these are the microcatheters which can go in any part in any blood vessel, and we can embolize the artery. This is again cannulated super selectively, and we injected polyvinyl alcohol particle through which then this is the follow-up angiogram where you can see that the bleeding has completely stopped. So again patient improved and went for further treatment. Another case of hilar cholangiocarcinomas, like we get lot of patients with biliary obstruction, and we keep on doing biliary drainages for them, but essentially they are invasive procedures, sometimes blind procedures, and we land up with situations like this patient who had hemophilia with a hemoglobin of 6. In such cases, we do CT angiogram, and you can see there is a pseudoaneurysm over here, which in the segment 6 of liver. We did an angiogram for him, and we could see that there is a, in this particular segment 6 artery, there is a pseudoaneurysm. So this needs to be embolized because the patient was having significant hemophilia, and but it was difficult to cannulate for some reason. We tried all the microcatheters, but it was difficult to go super selectively in that particular artery. In such cases, you can see on ultrasound, this is the artery and this is the pseudoaneurysm. Pseudoaneurysm is basically, it doesn't have all the layers of the artery. and it is a blind pouch which is communicating with the artery. So it is important whenever you get a pseudoaneurysm to embolize it. So in such cases, we do a direct puncture of the pseudoaneurysm under ultrasound guidance. We can see the needle. We directly puncture the pseudoaneurysm and injected glue over there. And on follow-up angiogram, you can see that this particular segment is embolized and the bleeding stopped significantly. Now, so it is these are the cases where we need to embolize aggressively, but there are situations where we should not embolize. And as we discussed, especially in mesenteric, when it is SMA, we are a little more careful because the collateralization is less and there is a risk of bowel gangrene. So we need to discuss it with the clinician and then decide whether to go for embolization or whether to go for surgery. Coming to genitourinary cases, like this is a 2-year-old child with ruptured Wilms tumor, and patient presented with bleeding on CT scan. You can see that this is the tumor which has ruptured and there is ascites on, like I think Dr. Deepak showed in his presentation, that the ultrasound is a very useful modality over here, and you can see that the ascites over here is showing internal echoes, which is an indication of this is not a clear fluid, it is a turbid fluid, and in this situation it was blood. So we decided to intervene, and you can see the angiogram, the renal angiography. This is the tumor which has ruptured, and after embolization it has stopped significantly. Patient was shifted from ICU to ward and went for further therapy. This 18-year-old girl, she came repeatedly to us. She had gestational trophoblastic disease, and these are the patients we usually embolize. But in this particular case, you can see on this is the CT scan where there are large venous legs or large venous pool pouches, and the patient was, we embolized her once, we again embolized, but the bleeding was not stopping completely. So this is an angiogram, a pelvic angiogram, which is showing the significant vascularity of the gestational trophoblastic disease, and like they practically behave like AV malformations. And in this particular patient, you can see that the venous pouches are significantly big. So after even arterial embolization, because the patient continued to bleed, we directly punctured the venous pouch, and you can see this is the glue cast in the venous pouch. And after the embolization of the from venous side as well, patients, this is the glue that we inject, and it immediately causes polymerization and thrombotic occlusion of the venous varix. So after this, patient's bleeding stopped, and this is the angiogram before embolization, and this is the angiogram after embolization. Patient was completely stabilized and then went for further treatment. Coming to thoracic system, this is a patient, many of these patients, they get fungal pneumonias because they are immunocompromised. This particular patient has got middle lobe and right lower lobe infection, and our definite, parameter usually is if the bleeding or hemoptysis is more than 250 ml per hour per 24 hours, then we that is the indication of embolization. But in our patients, we have kept the threshold very low, and whenever there is significant bleeding, we go aggressively and embolize. So this is the bronchial arteriogram. You can see the abnormal blush over there, and we decided to embolize this because these patients we have lost some patients whenever we did not intervene, and we thought that we'll conservatively manage the patients. So from then, our threshold for selecting the patients of hemoptysis is quite low, and we aggressively embolize them. This patient was embolized, and there was no further episodes of hemoptysis. This again an unfortunate child, 11-year-old. She had completed her treatment of leukemia, but presented with hemoptysis, and you can see on CT angio there is a outpouch from the aorta. So that was practically an aortic aneurysm that she developed because of the fungal infection. So this is a mycotic aneurysm, and because she was a small child, we wanted to do a surgical treatment for her, but we did not have the right heart lung machine and that infrastructure. So before that, we thought we'll stabilize her first. So she was treated with an aortic stent graft, and the patient's bleeding stopped and patient was stabilized. Another patient with who presented with hemoptysis and respiratory distress, and you can see that there is a pseudoaneurysm which is an indication of active bleeding, and for a change it was not from the bronchial artery but it was from the pulmonary artery. So the teaching point is that we need to look for all sources of bleeding. 90% of the times it is the bronchial artery or intercostal artery that causes bleeding, but sometimes we get it from the pulmonary artery as well. So we need to intervene, and it was selectively cannulated, and the lesion was embolized with glue. Unfortunately, this patient succumbed to the worsening of respiratory distress after 10 days, but the bleeding was stopped. So the message is that first we need to stop the bleeding, stabilize the patient, and then we need to go ahead. Head neck cancer is one of the commonest cancer in India, and these patients they undergo a lot of radiation, because radiation is one of the mainstay of therapy. But whenever, because of radiation, there is sometimes blowout of the arteries or carotids, and patients come like this with us. And these are because of radiation, it becomes so stone hard that surgical intervention is also not easy. Such patients, when they come, we first do CT angiography, and you can see here there is a big pseudoaneurysm that is seen on CT angio, and it is quite tempting to directly, because it is just below the sternum, we thought that we can just directly puncture it and put glue into that, but that is not the right way of treating it, because it is always better to go endovascular. So we did an angiography. On CT angio, you can see that there is a pseudoaneurysm coming from the common carotid artery of this patient. So this is the Doppler, what we call, this is a typical pseudoaneurysm on Doppler. And then this patient was treated by, this is an angiography, this is the pseudoaneurysm. You can see that there is active bleeding happening over there. And but the treatment is simple. That way, you just put one covered stent graft, and with that the patient can be completely treated. The bleeding can be completely stopped. So the right, if we intervene at the right time, treatment is very simple. This is a 15-minute job. But if the patient comes within time, and another within time means sometimes what we see that while taking the decision, patient continues to bleed and he goes into DCIS, and in that case, if once patient goes in that, then even embolization will not help. Then even our femoral puncture will keep on bleeding. So before patient goes in that, we need to intervene and stop the bleeding. Head neck patients, again, the juvenile angiofibromas we get very frequently. When they operate, sometimes they bleed in the tune of 20 to 25 liters of blood. So we need to embolize them. We usually embolize them aggressively, but even after embolization, you can see this patient was bleeding because the supply was from internal carotid artery. So we avoid embolizing internal carotid artery, but when the patient was bleeding in the operation theater itself, we decided to directly puncture it and inject glue. This is the glue cast, and after that the patient was, the bleeding was stopped, and patient can be, the surgery could be completed. So what is important is that interventional radiology has diverse applications in various systems, but it is we need to intervene at the right time and at the right place. It is technically not that difficult, but it can be life-saving, and a close coordination between the team of intervention radiology and critical care expert is very important. We work in our hospital with stalwarts like Dr. Atul Kulkarni, who happens to be from Nagpur only. So a very good coordination between the IR team and the critical care team is important to save the lives of these patients. Thank you very much for giving me this opportunity.
So any questions from the floor?
So before that, like Suresh said, but then see, the timing has to be good. And what timing he has also maintained here also, in this talk also, how rapidly he has covered everything, and that within the time, that is very important. It's like IR is like a fire brigade. Once you have a fire of bleeding, the IR has to come and just seize off the fire. Then what is the cause, and later on can be detected by the critical specialist or any other physician, and that can be corrected. The first thing is put off and then think about what is the cause. So that was an excellent lecture. Thank you.
Excellent talk, sir. I really find it helpful, sir. Every time when we see this bleeding and not getting control, or many a times we get confused where exactly it is coming, sometime from upper GI, lower GI, and we get stuck. At that time, your team really help us. Thank you so much, sir.
My question to the eminent interventional radiologist of Nagpur and Suyash. Literature mentions few cases of massive pelvic injuries with fractures, and you do a Reboa catheter, and then you stop the bleeding, and patient survives because massive blood loss is prevented. So I have not seen it. Have you encountered any such case?
Sush, would you take?
So it's talking about trauma. We are more into
Yeah.
oncology, but I think you can answer that.
So the thing is that the first CT angio, unless and until you see something in CT angio, you really can't pick up the right thing from where it is bleeding. Many a times you can see avulsions of the external iliac arteries in patients with pelvic trauma, because that is the artery which doesn't have much of support and it ruptures. And it doesn't give you time if you find it out on CT angio. So in those pelvic injuries, if you find extra iliac arteries, either a surgeon or a interventional radiologist who can place in a stent graft across the bleeding artery can be of a great help. Or we can just, if we don't have anything, we can place in a balloon, just inflate it, give time for a resuscitation, and then the patient can be subjected for many of the procedures.
So
Thank you.
as rightly said by Rajesh, so in trauma, CT angio and intervention has got actually a great role, which is very much underutilized in our sector. So now AIMS Delhi now is having a trauma unit where they are planning a infrastructure where you have a cath lab and OT, which is a common thing. I mean, the same on the same OT table, the cath lab is the moving entry, CT scan is a moving entry. At the center, there is an operation theater. The CT scan comes inside, do a CT angio. If it has to be operated, the surgeon operates. If it has to be embolized, there's the cath lab. So that kind of setup is required. I mean, the CT scan is done first. All the specialists, they come over there, right, from neurosurgeon, the thoracic surgeon, and they take the decision where is the bleeding and which particular treatment should be done. So from that CT angio, the trauma patients are tried, and that is the way we can save these precious lives. That kind of setup is required.
Why Delhi? I would say we have interventional radiology at trauma center at GMC Nagpur, where Jawar is heading the entire thing. So I strongly believe whenever it is bleeding, just remember we as medical plumbers are there to help you out, and you can subsequently take the entire credit of treating the patient and sending him back to home. Thank you.
Thank you very much, sir. I would say interventional radiologist solves problem you don't know you have in ways you can't understand. Thank you very much, sir, for this excellent talk. A comprehensive overview of how advanced, minimally invasive techniques can be pivotal in critical situations. I would say you guys are surgeons who do magic with a stick just without the wizard's hat. Thank you very much, sir. I now invite Dr. Parikshit Janai sir to please present a token of appreciation to Kulkarni sir and the chairpersons. हाँ हाँ
Thank you, sir. Ladies and gentlemen, be ready with your thinking caps on. The quiz is just around the corner. We have mind-boggling questions and attractive prizes ready.
Moving on to our next topic, that is managing DICU in ICU, for which I would like to invite the chairpersons, Dr. Ajay Kaduskar sir, who is a diabetologist in Nirame Hospital Diabetes Care Center, Dr. Ashish Gandre sir, who is consultant critical care medicine in Aureus Hospital, and Dr. Sucheta Meshram, who is a professor anesthesia and critical care medicine, AIMS Nagpur.
So, good afternoon, everyone. An important topic, a dreaded complication which we don't want to have, but then we have to face it every day. To talk on this, we have our dear friend Dr. Paras. Over to you, Paras.
DIC feels like gabbar in a bleeding patient. कितने आदमी थे रे सांबा? 3 सरकार. Tissue factor, platelet, and fibrinogen. Right. I would like to take this year to thank Dr. Paras, who has stepped in at the last minute in place of Dr. Tyagi sir, who could not be here due to some reasons. Thank you, Dr. Paras.
Thank you.
Dr. Paras is a prominent figure in critical care and diabetes management. Sir's extensive experience includes serving as past executive member of the Society of Critical Care Medicine and the Diabetes Association of India, as well as an executive member of the Association of Physicians of India. Currently, he is a joint secretary of Diabetes Association of India for 2025 period. He will be sharing his insights on managing DIC. Dr. Paras.
I would like to thank you, Dr. Jeswani sir and team, for giving me opportunity to talk on this convention. I will be talking on management of DIC in ICU in a short term with a intensivist perspective. So, what is DIC? DIC is a syndrome characterized by the systemic activation of blood coagulation, which generate intravascular fiber, leading to thrombosis of small and medium-sized vessels, eventually organ dysfunction. Ongoing consumption of platelet and coagulation protein leads to thrombocytopenia and low concentration of clotting factors, which leads to profound hemorrhagic complication. So, DIC present as a thrombosis as well as hemorrhagic complication leads to MODS. It should be emphasized that DIC is not a disease in itself, but it is always secondary to an underlying condition that causes the activation of coagulation. Some of the clinical conditions most frequently associated in DIC have been mentioned here. Sepsis and malignancy contribute about 70 to 80% of the cases of DIC. Severe infectious disease from gram-negative, gram-positive, tropical hemorrhagic fever can be presented as a bleeding as well as thrombosis. Malignancy with solid tumor may be presented as a VTE or thrombotic consequences, as well as hematological malignancy with APML can be presented as a severe bleeding. Polytrauma, brain injury, burns, primarily presented as acute bleeding and followed by thrombosis. House complication, vascular malformation, and transfusion reaction initially presented as a bleeding complication. Heat stroke and post-CPR status presented as a thrombotic features followed by the bleeding. These are the guidelines published for the DIC. There are 3 guidelines. First is the British Committee for Standard in Hematology, the Japanese Society of Thrombosis and Hemostasis, Italian Society for Thrombosis and Hemostasis. Although they are broadly similar, there are variations in recommendation. Scientific and Standardization Committee of the International Society of Thrombosis and Hemostasis harmonize the recommendation of these 3 guidelines. These are the differences between the guidelines and the recommendation given by the International Society. The scoring system for DIC as well as the treatment for underlying disease are recommended in moderate quality evidence, while the single test analysis of DIC is not recommended in any of the guidelines. Transfusion of platelet concentrate, FFP, fibrinogen, cryoprecipitate are recommended but in low quality evidence. But prothrombin complex concentrate are not mentioned in any of the guidelines. Activated factor 7A transfusion is not recommended, but as well as not mentioned in the Japanese literature. Treatment for thrombosis as well as the prophylaxis for VTE, heparin as well as low molecular heparin are recommended, but low molecular heparin is preferred over the unfractionated heparin. Other transfusion blood products like heparin sulfate, protease, protein C concentrate, and plasma exchange are not mentioned, while transfusion of the recombinant human activated protein C, thrombomodulin, and antithrombin are potentially recommended. as you all see that there is a difference between the recommendation as well as the mentioning of the guideline, as well as the mentioning of this guideline. So to diagnose DSC, the underlying clinical condition can be a influence on the lab test that are usually performed to diagnose the DSC. As you all know, there is no gold standard test to diagnose, as well as there is no single test that is capable to accurately diagnose the DSC. So use of scoring system is recommended. The scoring system of the DIC criteria is known to correlate the clinical observation and outcome. We have to repeat the test many a times with the dynamic changes of the lab result and clinical observations. To facilitate the diagnostic process, scoring systems are recommended by the 3 different guidelines. That is by the International Society, second by the Japanese Ministry of Health, Labor and Welfare, and third by the Japanese Association of Acute Medicine. International Society of Thrombosis and Hemostasis DIC score is useful for diagnosis of DIC resulting from infective and non-infective tumors. We usually follow International Society over the other two to avoid DIC, that is disseminated international confusion. A combination of tests repeated over time in patient in suspected DIC can be useful to diagnose the disorder. Japanese Ministry of Health and Labor only predict the mortality of the patient with the DIC, while the other not. The scoring system is only appropriate in patients with underlying disorder that can be associated with DIC. The international group produces simple scoring system for the diagnosis of DIC, and the parameters include platelet count, prothrombin time, fibrinogen, FDP, D-dimer. The score of more than or equal to 5 points is compatible with DIC. If the score is less than 5, consider repeating after 1 to 2 days. So lab test. What are the lab tests we have to do to diagnose the DIC? Global coagulation tests such as PT, fibrinogen, platelet count, fibrin-related markers has to be done. It provides evidence the degree of coagulation factor activation and consumption. As you all know, reduction in the platelet count or clear down tending is subsequent measurement is sensitive sign for DIC, but single test is not sufficient. Reduced fibrinogen level is valuable for diagnosis of DIC, but it may be elevated. Although PT is elevated, but it is prolonged in 50 to 60% of the cases of DIC who has a concomitant liver disease. FRM, fibrinogen, D-dimer, and soluble fibrin can be seen as elevated markers, but that leads to thrombin formation. Reduction in the level of natural anticoagulants such as antithrombin, protein C, ADAMTS13, RBC, elevation of soluble thrombomodulin, plasmogen activator inhibitor 1, and von Willebrand factor has to be observed in DIC, but it carries only prognostic indications. These are the many attractive markers, but there is no single marker that is able to diagnose DIC. This is the algorithm we can follow in our ICU. A patient has a clinical suspicion of DIC with the underlying condition associated with it, and lab showing a decreased platelet count with prolonged globular clotting assay. We have to follow the scoring system by the International Society. If score is less than 5, then there is no DIC, and you have to repeat the test after 1 to 2 days. If the score is more and compatible with DIC, you have to treat the underlying cause. A patient is actively bleeding and need to undergo invasive procedure, transfusion of platelet, plasma, and fibrinolytic treatment and vitamin K can be supplemented. If there is no major bleeding or thrombosis, prophylactic low molecular heparin can be given. When patient having overt thrombosis or organ failure related to clot formation, therapeutic anticoagulant treatment can be initiated. This is the form we can create in an ICU for the risk assessment as well as diagnosis of DIC. We have to order a global coagulation test, scoring of it, and then decide whether it is DIC or not. Treatment of DIC includes treatment of underlying conditions, role of blood products, anticoagulants, anticoagulant factor concentrate, and fibrinolytics. So, treatment of underlying condition is the cornerstone of DIC treatment. It includes administration of antibiotic or surgical procedure if necessary. DIC will spontaneously resolve in many of the cases. In case of sepsis, many of the patient will require additional supportive therapy, specifically to aim the correction of coagulation system. What is the role of blood products? As you all mentioned, the platelet is recommended in DIC patient when patient is actively bleeding with a platelet of less than 50,000 and high risk of bleeding with a platelet of less than 20,000. Administration of FFP are useful in patient with active bleeding, iron prolonged fatigue, or decreased fibrinogen. The administration of fibrogen concentrate or cryoprecipitate may be recommended in actively bleeding patient who have been replaced with FFP and has a persistent severe hypofibrogenemia. PCC may be considered an actively bleeding patient if FFP transfusion is not possible. So, anticoagulant. Therapeutic dose of heparin should be considered where thrombosis predominate. Low molecular weight heparin is preferred over unfractionated heparin. Patients with DIC are at high risk of VT, and VT prophylaxis with unfractionated heparin, low molecular weight heparin, or mechanical methods have become the standard of care in the patient with DIC. Anticoagulation factor concentrate require further prospective evidence from RCT, and administration of antithrombin, recombinant human thrombomodulin, and protein C is considered in DIC patients. But there is lacuna. Multicentric RCT performed to directly assess the effect of AT concentrate on mortality in patients with severe sepsis. There is no significant reduction in mortality. And clinical efficacy of recombinant and protein C in severe sepsis was demonstrated in large RCT, but a prospective trial in septic patient did not show any benefit of it. Many clinical trials and studies are done to assess the safety, efficacy, and treatment effect of anticoagulant factor concentrate, but there is no improvement in mortality. Antifibrinolytic therapy are effective in bleeding patients, but the use of this agent in patients with bleeding result from DIC is generally not recommended. Tranexamic acid significantly reduces the mortality of patients with trauma, as shown by RCT in CRASH-2 trial. I'm going to the cases to better understand the DIC. A 63-year-old male with severe cholangitis due to obstructive stone in the CBD presented with shock, respiratory distress, and developed acute renal failure. Blood culture were positive for Klebsiella pneumonia. Investigation revealed hemoglobin of 10.2, TLC of 15,000, platelet count of 48,000. Coagulation analysis show prolonged PT, APTT, increased fibrinogen concentrate, as well as D-dimer concentrate. My question is, what is the score of it? So as per International Society, the score comes to 7. Patient was treated with vasopressor, intubated, and mechanically ventilated, treated with antibiotics. So my question is, what will be the appropriate treatment of this coagulopathy? Keystone is management of DIC, adequate treatment with the underlying disorder. In this condition, which cause DIC is properly dealt with, for example, in this case is bile duct drainage and antibiotic, the coagulopathy will resolve spontaneously. ERCP to maintain the duct patency is a definitive treatment with antibiotics. Low level of platelet and coagulation factor may increase the risk of bleeding in post-operative or those planned to undergo invasive intervention. So adjuvant supportive therapy can be given. Second case, a 68-year-old male hypertensive admitted to ICU because of respiratory failure 3 days after hemicolectomy. Blood pressure was 100/60, heart rate was 120, respiratory rate was 28, and temperature was 100.5. Post-op treated with broad-spectrum antibiotic and continuous subcutaneous heparin prophylaxis pre-op as well as post-op. APG shows PO to 63, oxygen saturation of 84 with 5 liter of oxygen, lactate concentrate of 3.3 and bicarbonate of 8. Patient was intubated, achieving an oxygen saturation of 98. He was hemodynamically stabilized with fistula and IV noted. Lab analysis show HbO of L1, leukocyte count of 16,000 with 12,000 of neutrophil and marks of 2 left. Platelet count of 98,000, cystocytes in peripheral smear, creatinine 2.4 and bilirubin 1.2. Patient is presented in the MODS. Coagulation test result increase in prothrombin type, INR, APTT, T-dimer concentrate and fibrinogen concentrate. So what is the differential diagnosis in this patient? Sepsis. Lab abnormalities are compatible with DIC. However, some differential diagnosis consideration is taken into account. Sepsis per se is clearly associated with thrombocytopenia and reduction in the platelet count due to impaired platelet production. Second is thrombotic microangiopathy and TTP. As peripheral smear shows platelet cystocytes with a decreased platelet count, but the D-dimer levels were normal in TTP HS. Heat may be another differential diagnosis, but the coagulation factors are not deranged in heat. So in our patient, the platelet count is 1, prolongation of PT is 1 point, and a strong increase in a D-dimer 3 leads to score of 5, which is compatible with the diagnosis of DIC. So take off message for this, there is no single laboratory test with sufficient accuracy for the diagnosis of DIC. The scoring system and algorithms will be used to diagnose DIC. Severity of DIC according to scoring system is strong predictor for mortality in sepsis. To treat DIC, underlying cause has to be dealt with early recognition from treatment and supportive care. Continuously assessing the patient clinical status and lab result to guide underlying treatment, adjust treatment plan or as the condition evolves. Lastly, engage in multidisciplinary discuss with hematologists, intensivists, and other specialists. Tailor the best management plan for the patient. Thank you for patient.
Thank you, Dr. Paras. It's really an enriching and enlightening session. And the forum is open for any queries or questionnaire. I just want to put a practical perspective to it, as it has been said that it is a disseminated international confusion, as you have depicted on a in a low profile. But the thing is, considering the practical aspect, we have to look for the concomitant possibilities. Like in our setup, I always look for the possibility of metabolic acidosis. So because it is a factor which causes disruption of the endothelium, and even in a scenario of acidosis, the vasopressors won't act optimally. So I address this issue very efficiently and on priority basis. So I would just add into this that considering the treatment of metabolic acidosis as a adjuvant therapy along with other modalities is to be think about.
Paras, you have very well walked us through this confusing part of DIC, when to suspect, how to diagnose and how to treat. In fact, your cases were very good, and the algorithm slide which you shared about how to diagnose and how to separate it between overt thromboembolism and bleeding and how to go about it. I think you have got given us some great take-home messages. If there are no questions, I think over to the MOCs.
Thank you.
Thank you, sir, for not only enhancing our understanding of DIC, but also providing us with the practical tips and strategies to improve patient care. Now, I would like to invite Chairperson to felicitate Dr. Paras Junke sir with a token of appreciation. Thank you, sir. I would like to invite Dr. Sudhir Chafle sir to kindly present memento to chairpersons.
Our next topic is obstetric hemorrhage, for which the esteemed chairpersons are Dr. Anant Rajput sir. He is consultant critical care medicine in Aureus Hospital. Dr. Shashikant Raghuvanshi sir, he is managing director Raghuvanshi Hospital. Dr. Ashwini Talpe ma'am, who is gynecologist at Arneja Hospital. The speaker for this talk, Dr. Bharat Jagyasi sir, could not be here in person because sir is suffering from chikungunya, but he is going to be with us virtually. If nothing else, COVID has taught us virtuality. Sir, with great humility and gratitude, I welcome you. Welcome you for this talk. Dr. Bharat Jagyasi sir is a renowned intensivist and currently Director of Critical Care Medicine Department at Kokilaben Dhiru Ambani Hospital, Mumbai. Dr. Bharat Jagyasi sir.
Thank you for your kind introduction. If you could please allow me to share my slides. And thank you very much, Dr. Deepak, for having me over here and arranging this virtual thing for me. I couldn't be here because of my health, and all is well as of now. If you could allow me to share the screen. I can see Dr. Anand as the chairperson. Hi. Yeah.
Welcome, Dr. Bharat.
Yeah, thank you. I can't share my screen as it.
Till the time,
Yes,
Bharat.
it made me host. Yes.
You are still having fever, or are you okay?
No, I don't have a fever as of now, but
Any kind of arthritis or something?
Yeah, pain is there. Yes.
Okay.
Can you see my skin as of now?
No.
See my screen as of now? You see?
No.
No, not yet.
Not yet. We can see you, but not the slides.
Slides are not visible.
They're doing the job in the back.
No. Is it seen?
No. Yeah.
Is that? Yeah.
Yes.
Okay. So there's a lag of a second or two, and that would be there. So, of course, thank you for having me over here, and thank you for all that introduction. And sorry, apologies to Deepak for not making it over there. I would have loved to see you all and meet you all in person. Got few calls in the morning. Dr. Vikas, Ashish, everyone called up. They had arranged few things for us. So, of course, we'll soon come to Nagpur and we'll be there. So, talk is on the obstetric hemorrhage, and as been introduced, I'm General Secretary of ICCM and also Director of Critical Care Kokilaben. So, why this talk has been chosen? Because amongst the maternal admissions, so whatever we see in the critical care, majority of the obstetric hemorrhage then followed by the pre-eclampsia. This is what we look into, and as we all work in the metros, so we've been the referral center for the high pregnancy risk and high maternal risk factor. So, I mean, Kokilaben itself is a very big referral center. Same would be with you all. So, we should be prepared with this, as severe bleeding is a major cause of maternal mortality, and more than half of maternal deaths are within the 24 hours of the delivery, and all of those because of the major bleeding. And there's the low turbulence and high flow is what's seen. I'll come to that. So the uterine flow is the blood flow in the uterine arteries is of the low resistance and the speed is very high, and this is why even the minute artery which has been opened can lose the blood of 600 to 900 ml per minute. This is why we have to look into the blood loss every minute. It can really turn the tables around if you miss it for just few minutes or so, which is not true in the other arteries except for the uterine artery. So definition, if we look into it, maternal hemorrhage is being classified into two types, mainly the antepartum hemorrhage and the postpartum hemorrhage. And antepartum hemorrhage is being said when it's after 24 weeks till baby's been delivered. And usually the Royal College of Obstetrician has defined antepartum hemorrhage as 50 to 1000 ml. So small bleeding, even the 50 ml of blood is considered as a antepartum hemorrhage, which is not true with the other bleeding cases. And it's a massive antepartum hemorrhage when the bleeding is more than 1 liter, and or any kind of bleeding associated with the clinical sign of shock is antepartum hemorrhage. So other would be the postpartum hemorrhage. So when it occurs beyond 24 beyond after the baby has been delivered, it's the postpartum hemorrhage. So it could be the primary and secondary, and it's when it's within 24 hours is primary, and it's after 24 hours till 12 weeks of delivery is considered as a secondary hemorrhage. And again, there have been many classification into this. So I'll just show you the different areas where it. So usually it's 500 to 1000 ml is what's being classified as a hemorrhage in this case. And the shock is whenever is more than 1000 or there any kind of bleeding less than 500 ml also associated with symptoms of the shock is being considered as a hemorrhagic shock in this case. So as I was talking to the pathophysiology, so there's a different variability as compared to others. So it's a high flow system with the low resistance, and almost at the end of the pregnancy by term it receives around 25% of the cardiac output. So this is why in a minute the blood loss is around 600 to 900 ml because the resistance is very low and the flow is very high. So as we evolve physiologically, even the moderate losses, so nature always prepares you for the turmoil. So in this case, nature always prepares us by increasing the plasma volume more as compared to the red cell mass. So even if there's a loss of blood in terms of ml, red cell mass loss is less eventually. And when the uterus involutes, there's a termination of placental circulation. There's an autoperfusion of around 500 ml. So this is what nature has prepared us for this. In the same way, it has also pregnancy is an inherent hypercoagulability stage. So God has seen this. This will happen. So this is why the autotransfusion and there's a hypercoagulability stage as well, where there's a immediate clotting, but there's hyperfibrinogenemia as well. So now when we look into the causes, it could be the varied causes of placenta previa, abruptio placenta, uterine hemorrhage, bleeding from the vulva. But when it comes to the postpartum hemorrhage, the mostly 4 T's what we look into. So one is tone, when the uterine tone is lost. Another one is trauma. It could be the tissue, that is retained tissue or the invasive placenta, or the thrombin, that is a coagulopathy, which is what we look into. So 4 T's are the major cause, and this is how our treatment is also dependent on all these 4 T's. So causes, we'll go one by one. So atony could be the medical, uterine, or the placental reason. So medical could be the maybe prolonged induction. This is what has exhausted the uterus. Overall, is not able to contract. It could be the multiple pregnancies, hydromnias, or fibroids, which are not allowing uterus to contract again. And the placental causes maybe the abruptio placenta as a reason which is caused. So uterus is usually underperformer when it's overstretched uterus. There are multiple gestation, macrosmia, polyhydramnios. Tired uterus, high parity, prolonged labor, prolonged oxytocin use, we really exhausted the uterus out. And the sick uterus, which is seen in choriomnatus, is really too sick to respond to the tone is totally lost. And then it's an obstetrical trauma, which can again lead to it. So it could be the laceration or the hematomas. Of course, when you find out those hematomas increase in size, patient should be wheeled back to the labor room. And again, those hematomas should be addressed and the bleeder should be controlled. Uterine inversion is a major cause of it. I mean, not a major cause, but it's a very important cause. So it's usually when the uterus protrudes out to the introitus during the delivery, and it's characterized by the hypertension. So immediate manual replacement is what is required in those cases. And if it cannot be replaced, then we have to use the tocolytic agents. If it's in the OT, we can use the halothane or the nitroglycerin, and still we are unable to replace the uterus. In extreme cases, laparotomy might be performed, and cervical ring has to be incised to allow the uterine replacement. Retained placenta, we all know this is the the second most commonest cause. So it could be because of the retained product of conception. So manual intrauterine exploration and uterine ultrasonography is required to diagnose it, and a simple procedure of removing can be helped. Coagulopathy, eventually, when we don't replace enough blood or we don't address the issue in time, will lead to the coagulopathy, and I'll come to this as we go ahead. So for the uterine atony, we use the uterotonics during the third stage of the labor, and prophylactically also being used by the obstetricians. So oxytocin is the preferred one as is the most commonly used. And the other techniques what we use are the control cord traction when the placenta is still inside and is not coming out, or the surveillance of uterus tonus through the abdominal palpation we all been practicing. So it's very important to clinically assess the blood loss, because pregnancy itself, as I told you, there's an auto transfusion. So for some time you might realize, yes, BP has picked up, heart rate has resolved, there's no tachycardia, and we tend, because of the amniotic fluid, we tend to actually misjudge the real blood loss which is happening. This is why it's very important to have a low threshold and assess it. So a prenatal assessment is very important. If you look into these are the 4 categories, it's a low risk, medium risk, and high risk. So in this way, we can characterize the patient. This is a patient who's going to have a bleeding or not, depending on these characteristics. And the early warning signs as well, what we look into. So if the systolic blood pressure less than 90, diastolic is more than 100, if heart rate is this, so what we usually use. So those areas, the reason I'm showcasing this is because we need to be very vigilant, because it's very easy to miss it, because we consider the blood volume maybe an amniotic fluid, and resting tachycardia is always high in the pregnancy because patient being in labor and physiologically as well. So we don't really get those signs. So it's very important to be aware of the underestimation, and we have to look into it. So dangers would be, of course, tachycardia in APH will be a sign of fetal distress. We need to be extra cautious in obese patient, preeclampsia, and the dark skin patient as well. And the blood loss of more than 1,000 should make us start resuscitation and look for the obstetric hemorrhage. So control of the uterine tone could be done by the different medication, what we use by the obstetrician very commonly. Tranexamic acid is not a uterine tonic, but because I'm covering the medical part of it, it plays a very important role by inhibiting the enzymatic breakdown of the fibrin and thereby stabilizing the architecture of the clot, and is well established in the non-obstetric situations as well. So if you look into this, World Maternal Antifibrinolytic trial showed that tranexamic acid, that's by using tranexamic acid, that's reduced by 20%, and greatest benefit was seen when it was used in 3 hours of the childbirth. And the most important, what we always look into, because pregnancy is a thrombotic stage, by giving tranexamic acid, do we increase the chance of thrombosis? So study says no, it's not associated with the increased risk of thrombosis in healthy women. And the dose which has been fixed is 1 gram over 10 minutes. We can repeat a dose after 30 minutes if bleeding is not under control. Now we come into the non-formal physiological measures. So these are varied measures from ligating the artery to like having sutures around the uterus, tamponade effect by inserting the balloon inside the uterus, even the Foley's catheter, or you can see with the balloon dilatation, obliteration of the internal iliac arteries, or with the even with the embolization as well. So uterine massage is what we've been always practicing, and if the placenta is not expelled within 30 minutes of the delivery of the baby, we can look into the controlled cord traction that can be practiced, and prophylactic antibiotics to be used to prevent the infection and again further worsening the coagulopathy. Uterine tamponade can be used by inserting Langston Blackmore esophageal catheter, or we can also use a different balloon techniques in the multiple. There are certain case reports that the multiple Foley's have been used to just create the tamponade effect. There are different sutures which can be put around the uterus. These are the various types of sutures. Obstetrician would know it. This is just for the reference. So they can maintain the tamponade by just tightening it and compressing it. This is very important when it comes to the decision making, because internal ligation of internal iliac and uterine iliac will diminish the pulse pressure of blood flowing to the uterus, and bilateral uterine artery ligation is really quicker to perform, and it can prevent hysterectomy in many of the cases. So this is what they should be trained with, to identify the artery and ligate. what uterine balloon, artery balloon occlusion, what we usually practice in our institute as well. So in the high risk cases, especially in the placenta accreta in those, where we anticipate blood loss. So always the interventional radiologist is there. We insert the two catheter, femoral artery catheter inside, and we are ready with the balloons as well. So moment the baby is been delivered, balloons are inflated, so the flow is down of the uterine artery. They immediately slowly get the placenta out. We watch for around 10 to 15 minutes, and slowly and gradually the pressures in the balloons comes down, and eventually if there's no bleeding, we take out the balloons and even the catheter at the same moment. So this is what we practice very often in our center with the help of the interventional radiology. Hysterectomy is of course an extreme step. If at all we can't control it, we have to go ahead with it. Blood component therapy have to be used. Eventually, the problem is in these cases, whenever there's a massive hemorrhage, the cases what we actually see in the critical care will land up into the massive transfusion. So massive blood transfusion by definition is when more than 10 units have been given over a period of 24 hours, or 4 units within 1 hour with anticipation of continued need of blood, or replacement of 50% of the total blood volume, that is approximately 5 pints of PRBCs within 3 hours, or when we have to transfusion support to anticipate a loss of more than 150 ml per minute. So when we use these products, we need to really be very sure what are we using. Either we follow the massive transfusion protocol, that is 1:1, 1:1, 6 units of 6 pints of PRBC, 6 pints of FFPs, and 1 SGP. Either we should be following it, or if we have an access to the point of care test like TEG and ROTEM, we can actually make out. So what exactly these TEG and ROTEM does is, it will tell you what stage the clot is hampering. So what they look into is how fast, how long, and how the clot get lysis. So there are various areas available. So if you look into it, R is the reaction time on the first clot formation, that is how fast. Then achievement of clot formness, that is how long is going to be clot there. And then again we look into this LY30, that is the percentage of lysis in 30 minutes. So these are the process which is being used, how fast the clot is being formed. If it's taking time, then you give FFPs and PCC concentrate. How strong, if that is taking time, then one can consider giving platelets. Then how long, that is if there's a clot is getting lysed early, is not stabilized for a longer duration, that means there's a deficiency of fibrinogen. We can either give the cryoprecipitate at this moment or the tranexamic acid. So that makes you identify at what stage what is missing, so that accordingly we can transfuse either FFPs or platelets or the tranexamic acid. And same is true with the ROTEM. So it has many areas like XTEM, INTEM, FIPTEM, and HIPTEM. So this is what look into its external coagulation pathway, internal coagulation pathway, and fibrinogen. So when the fibrinogen deficiency, then FIPTEM would be more than 15. So these are the areas where actually we can find out. And if we do it very often with just one look, you can make out what is missing and accordingly what needs to be transfused. If you look at the FIPTEM is less than 12, then there's a low fibrinogen. We need to transfuse the cryoprecipitate or fibrinogen concentrate and also consider tranexamic acid. If the XTEM is less than 35, then it's an early indication of excess fibrinolysis. Again, consider tranexamic acid in this. If XTEM is less than 35 and XTEM is more than 20, INTEM is more than 25, along with the FIPTEM being low, so low platelets and low fibrinogen to be given. So these are the various permutation combinations what we can use if you have this facility available within your institute, and it will exactly guide us what is to be transfused to the patient by identifying what is missing the patient. So apart from this, I would like to share one case also. We had it around a month back in our institute. So there was a patient, of course, it was a high-risk patient, PIH. There were low platelets, there were HELLP syndrome as well. It was operated and came down to ICU just for the observation, as other patients do. But in next 2 hours, patient collapsed to BP from 110 to straight away to 40. Eventually, we had the artery line in those cases. So BP just went down to 40. Of course, it was a bleeding. We announced the code transfusion in our unit, and everything of patient was transfused. BP came down to 110. BP stabilized. Patient was on inotrope. So we moved that patient to the for the DSA, and eventually it didn't pick up anything because the patient is stabilized for a while after giving all the blood components. Then after 4 hours, again the patient collapsed in the night. We had to push in everything, and BP stabilizes 140. We came down on the inotropes. Again, 12 hours later, patients collapsed. So we didn't know what to do. That moment DSA couldn't be done because specialist wasn't, it was a night time. But we did not resuscitate that patient because we realized to pick up a bleeding, it has to be an active bleeding. So what was happening whenever we stabilizing the patient and then moving out to the DSA or CT angio, we couldn't find out anything. So this time we moved the unstable patient without major resuscitation to the CT angio, and we found there was a bleeder. So again, we took that patient to the, we called the specialist intervention radiologist. He came and he embolized the patient. It got settled. So in all this, in between the two sets of DSA and CT angio, the patient was re-explored as well. And they did not find any bleeder. So uterine artery ligation was done. So the second set where what I told you, again, that patient was explored, even the hysterectomy was done. So the third hypotension happened after the uterine artery ligation, after the hysterectomy. And this is where we took the patient down to CT angio. So what had happened, there was one artery which had retracted retroperitoneally. So they had not retroperitoneally, there was a bleeder inside, which was, and it was a very small bleeder which was picked up inside the CT angio, and it was embolized. So normally, had we not picked this up, this would have been labeled by us as a DIC because of the massive blood transfusion. This patient received around 50 products of blood. So it's very important of these investigations and the timing and the facility also available. Otherwise, we tend to miss, even though there was a when the second time patient was explored, there was an oncosurgeon which was taken on board because they did not want to miss anything. Even they missed it. So it's not really a simple thing. We tend to miss things, and we need to have the facilities available. As I told you, like intervention radiologists with those ballooning techniques and all. And we always keep identifying and keep looking for the causes so that we can correct it. So if you look into this, if there's a major obstetric hemorrhage call, always call for the transfusion code, and when the blood loss is more, immediately intervene. Of course, initially look for the ABC, have the center line and artery line amongst us. If you have the TEG and ROTEM available, the point of care, try to find out what exactly is missing and where to, and also keep doing the serial investigations radiographical to find out what where to intervene and which point is required, whether it's a surgical bleed or it's a non-surgical bleed. So again, it tells you, it's a very busy slide, tells you the same thing about the ROTEM and TEG, what we missed it. So I think I've covered everything. Thank you very much.
That was very excellent presentation, Dr. Bharat. As far as the gynecologists and obstetricians are concerned, I think the direct communication with them is very important, because a lot of time we see the patient has been transferred to the ICU in night hours. The things have been done throughout the day. The patient was in labor, and labor goes on, and suddenly things change. Everybody is waiting for the good news, and suddenly the scenario changes. This happens very frequently. A lot of time with obstetrician, the estimation of blood loss is very inaccurate because of liquor and everything. So what I feel, any amount of bleeding which is causing changes in vitals like rising tachycardia and hypotension should alert the obstetricians, and direct communication with the obstetrician is really very important. Certain things like now we have apart from balloon and all that, we have Ponicus cannula. It's a very simple cannula. It's a 30 centimeter long cannula with a lot of fenestration. What it works on is a negative suction pressure, because once you remove the tamponade, sometimes again the atony comes in, and again PPH ensues. So this cannula is really very wonderful cannula. Basically designed for periphery, but I think every ICU should also have it. It's a very simple and very cheap instrument what we have with us, but it saves lives. I think this should be there in our armamentarium.
Bharat sir.
As you rightly said, the timing is sometimes the case which I was talking about, that baby was delivered at 11 p.m. in the night. And the reason being is that time was given by the astrologer.
Bharat sir, one point is, can there be some warning points that you can give for the gynecologist where they should really say that now it's not too late to shift, and now it is right time to shift?
So
instead of waiting.
So there was a early warning signs slide in that. I'll play it as slide again. So as rightly suggested, always there's an underestimation of the thing. The reason being is there's a liquor, so we actually can't make out what amount of blood is there and what amount of liquor is there. And second is the resting heart rate is always high even in the pregnancy. So prenatal assessment among this PPT is very right, and the Early warning signs, as this shows, when the systolic blood pressure is less than 90, when the heart rate is more than 120, when the SPT rate is more than 30 and oxygen saturation dropping and there's no urine output or decreased urine output for more than 2 hours, then these are the signs we should be, our threshold should be very high for re-exploring the, threshold should be low for re-exploring the patient and looking into the causes, whether the patient is really bleeding or not. So maybe doing serial APGs, lactates or serial hemoglobins will help us out.
Going on the same line.
So no, also in the ICU, we can look into the clot, increasing the size of the clot. So in the case what I discussed, which I summarized, so we were evaluating, so to start with, when they had explored the patient, they couldn't find the bleeding. The first exploration, the gynecologist is very sure it's not bleeding. So we have to prove it by demonstrating increasing the size of the clot and decreasing the hemoglobin to tell us that this is bleeding. So they were looking into there's an obstetric physician also which came in picture. So he was looking into some hemolysis. They were contemplating an idea of plasmapheresis in this patient as well, because they had explored the patient and they couldn't see the bleeder inside. So we have to have those areas where we have to prove them, no, there's increase in the size, there's a drop in the hemoglobin, they have given it to the lysis. So increase in the size of the clot is what we have to explain it to them, no, this is the bleeding. Then eventually the second exploration, what happened? So happened with the multiple surgeons. So of course they could find the clot, but they couldn't find the bleeder. Then eventually they realized there's something inside which we are missing, which was a very small retroperitoneal artery picked up in the angio.
One small thing is for the critical care people, can we have a PPH kit which can be kept in ICU? Dedicated PPH kit, which will include some form of uterine tamponade device or.
What we can do is we can have the PPH kit, but the kind of hemorrhage which is happening, Anant, over here, I think it's mostly will be the bleeder, because the atonic uterus is mostly taken care of during the surgical time. And whatever amount of tamponade we create with the different catheters, it won't be enough. It has to go for the exploration. What is important from our point of view, there's no denial in the fact that we cannot have we can have the PPH, but more helpful is going to be the blood products in this situation, because many of them die because of under resuscitation. So if you have something kind of code transfusion in your ICU, or you can simulate these, so there are certain centers which are very high, they simulate the code PPH as well, where they make those kits available. So those things would be more helpful rather than having along with the PPH kit. I wouldn't say not to have the PPH kit, we can have it, but we need to have more sensitization about the hemorrhage and availability of the products and availability of the team to transfuse it.
Any questions from the audience? Umesh is here, please. Mic is here, Umesh. Dr. Umesh Ramtani.
I want to know what is the policy of uterotonics at your place, because now we are not using methargens, and there is a different policy followed in every institute. So I wanted.
So I'm not the right person to answer it, because usually uterotonics are being used by the obstetrician. So what we have seen is mostly oxytocin, but I would advise some obstetrician to answer this.
No, I believe uterotonics are quite frequently used. Every obstetrician goes with the uterotonics. They use oxytocin. Now carbidocin is with us. Methargine selectively, yes or no. Misoprostols are there. So it actually depends upon how you monitor the labor, how you progress the labor, and every patient is at risk of PPH. Even there are no risk factor, but you have to think this patient can land up in PPH. So we start with oxytocin. We monitor the labor, progress the labor. And accordingly, every patient, if needed, why not to use methargine? Why not to use carbetocin? Everything is there. Even misoprostol, a lot of people use prophylactically. Nobody wants to land up the patient in PPH and then manage the patient. I feel even for intensivists, the management start with the obstetrician itself. If a lot of time you get the referrals for the PPH, not labor are conducted in ICUs. So if you talk with the, if you get the call, you communicate with them and at least ask them to pack vagina, so that the pressure will be there on the cervix. A lot of time uterus is hard, there is no injury, still patient is bleeding. It is the cervix. Cervix is traumatized and there are no obvious lesion, but the dilated cervix itself is profusely bleeding and that is causing problem. You get a good patient at your hospital and then the things are pretty easy, manageable. So this communication is really very important.
Other simple thing which I have experienced is a good light source in ICU. So giving lithotomy position in ICU and then not being able to visualize what's happening, how from where the blood is coming. It's a very practical, big issue because we don't have those strong light sources. So probably headlamps and all those things, something like that should be available in ICU for better visualization. And we keep PPH kits. So that is our.
What is there in the PPH kit, Anand?
PPH kit, we have a Bakri balloon, we have centerline large size cannulas, we have tranexamic acid as this, and these prohibited drugs are there, which are actually not allowed, but we keep them 1 ampu. So these drugs which are usually not allowed without prescription, but we keep them.
What I said about the Panikas cannula, the cannula is a very simple thing. One should have it everywhere, even in periphery, even in ICU, because it is much, much better than PPH kit. It wonders.
As it is said.
Any other questions? So I think, thank you very much, Bharat. Thank you so much.
Thank you.
As it is said, the management of obstetric hemorrhage is a race against time, requiring immediate recognition, rapid intervention, and often the coordinated efforts of a multidisciplinary team. Thank you, sir. I wanted to express my deepest gratitude for taking the time to present your talk despite being unwell. Thank you very much, sir.
Bharat sir, your gift will not be sent to you virtually. We will send it by post.
Now, I would like to invite Dr. Deepti Jeswani ma'am to present a token of appreciation to respected chairman.
After food for the gut, let's move on to some dessert for the brain. Albert Einstein said, creativity is intelligence having fun. So let's have some fun with Dr. Shailesh Chokse, who is a consultant intensivist at Criticare Hospital, where his clinical expertise shines brightly. In addition to his hands-on clinical work, Sir is also an active contributor to the academic community. Sir will lead us through an engaging and insightful brainstorm quiz designed to challenge and expand our knowledge. I give you Dr. Shailesh Chokse.
This would be a live quiz. So you will see a code here. You need to enter the code on your mobile. I will show a QR code for this. So you are seeing a QR code there and a game pin. So you can scan this QR code. If you are not able to do that, you can just type on your website www.kahoot.it. If anybody is having difficulty, please let me know. Once you enter into the game pin, they will ask for the nickname. You can enter your name. So as you enter your name, the name of the person will be seen on the screen. So the rules are whoever answer it faster would get more points. Second thing, I expect that uh, persons who are committee members should not participate into it. So there will be around 20 questions. Each right question has a 1000 points, and correct answer will depend upon the how fast you answer those questions. And after that, 3 prizes. We will announce the prize winner now only and distribute the prize also. Sound का लगा देते हैं sound. Anybody is having difficulty, please let me know. And please don't log out from when you are playing, because that will make you out of the game. Second thing, that's why you should not browse on the internet. (16) 18 participants. Anyone more? आएंगे वो बाद में आएंगे. So you keep it continuously logged in and keep your browser open while you are playing for the game. So we will wait for 2 more minutes if anybody want to log on. Start. So we will start now. 22. Anybody facing difficulty in login? Should I? आप गेम में जब चालू करूँगा ना तो आ जाएंगे. कौन कौन आया वो दिख रहा है. हाँ थांबा सर एकदा थांब क्वेश्चन येते. गेम पिन 304 304 336. First thing, you will only see question and answer on the screen, and on your mobile screen you will see color codes. So that color should be the correct answer. So you won't see anything to read on your mobile. That would be of 4 colors, different color. The correct answer, whatever written on that color, would be your. You should press that button only if it is correct. Okay. So total 24 participants. 25. Anybody? Anyone? हो गया login? Anyone facing difficulty? So we will start with the quiz. 26. Done. So we are starting. So first question. Sound नहीं है. All of the following are vitamin K dependent coagulation factor except. 26 seconds. Answer. I think everyone has answered. So total 10 people have given a correct answer. Factor 3 is the answer. 13 people have given a wrong answer. Next question. So on the scoreboard, the fastest in this is Dr. Ria. So she is a first. Next question. Lethal triad during massive transfusion protocol consists of all except. Faster you answer, you get more points. So total correct answers are 12. The hypotension is not part of the lethal triad. Let's see the scoreboard. So Dr. Ria came to second spot. And so we will move to next question. Oral anticoagulant of choice in a patient with deranged renal function is. Last 4 seconds. So correct answers. Apixaban is a correct answer. 15 people have given a right answer. So let's again check the scoreboard. Dr. Ria is again on the first, Rahul on the second, Kapil on the third. Amol sir on fourth. The following test is performed in a bleeding patient. What's the name of the test? I think I should skip the time now. Everybody must have answered. Very easy question. So 13 people have given it right. It is a rotem, not the tag. Tag is a single graph. So let's check the scoreboard. Dr. Amol came now on the first. And DKP is the highest climber. He came 7 places up. So DKP, who's DKP? Very short name. Dilip Shirsagar sir. So let's go for the next question. Patient on dabigatran had a GI bleed. Treatment options are. Fast. 18 answers. I think 6 more left. 8 more people to answer. So correct answer is all of the above. 10 people have given a right answer. Idolizumab, other than that, 4-factor PCC and hemodialysis can also be done. So the scoreboard, Dr. Ravi is on the top now. And I think Dr. Amol moved to spot 5. Sir, fastest finger. You need to exercise. Rivaroxaban should be discontinued in a patient with normal renal function for surgery within 5 days, 7 days, 3 days, 24 to 48 hours. 20 seconds. 15 answers we got. More 8 answers. 20. Anybody more? 26 are there, na? 4. So the correct answer is 24 to 48 hours. 13 people have given a correct answer. Let's see the scoreboard. So this time Dr. Ravi is again on the top and Ria moved to third spot now. In the patient with massive transfusion protocol with traumatic head injury, target hemoglobin, platelet and fibrinogen are. I think it's easy question for Dr. Ria. 7 gram 50,000 100 mg, 8 gram 50,000 150 mg of fibrinogen, 9 gram hemoglobin 75 to 1 lakh platelet and 150 of fibrinogen, 10 gram of hemoglobin 1 lakh platelet and 250 of fibrinogen. So the correct answer is 9 gram of hemoglobin, 75 to 1 lakh of platelet and 150 mg of fibrinogen. So this time again, Dr. Ravi is not top. He is maintaining his position. Next question. It's a video of eFast. What it suggests? Ten answers. 10 seconds more to left. 9 seconds. So it's a pericardial tamponade maximum. Have given a correct answer for this. 19 correct answers. And again, Dr. Ravi is on the top. Use of prothrombin time is a test of activity of intrinsic pathway, extrinsic pathway, both intrinsic and common pathway, both extrinsic and common pathway. The correct answer is both extrinsic and common pathway. So 4 correct answers only. Okay, Dr. Rahul has come to first spot. Dr. Ravi moved to second. Dr. Ria maintaining a third position. Dr. Monica ma'am has came up with the 6 places. So. Antithrombotic prophylaxis should be discontinued if platelet count is less than 1 lakh, 70,000, 50,000, 30,000. Okay, everybody has answered. So the correct answer is 30,000. So let's check the scoreboard. Okay, Dr. Rahul is maintaining first. Dr. Ria came on fifth. Dr. Amol on third. Okay, Dr. Prasad up five places. 3-factor prothrombin complex concentrate versus 4-factor prothrombin complex concentrate differ with the respect to concentration of which factor? Factor 2, factor 7, factor 9, factor 10. 18 answers, 19, last 4 seconds, fast, last 2 seconds. The correct answer is factor 7 concentration is variable. Total correct answers in this is only 7. So let's see the scoreboard. So Dr. Amol moving forward, Dr. Ria on the third, Dr. Rahul on first. So Dr. Paras made a 6 steps up. So crash 2 trial, 1 gram injection tranexamic acid should be given in case of trauma. Within 6 hours of trauma, infusion for 6 hours, 1 gram with 3 hours, then infusion for 1 hour, or 1 gram 3 times a day for 3 days. Nineteen answers. 22 answers. So correct answer is 1 gram within 3 hours, then infusion of 1 gram over 8 hours. 10 answers, 10 people are given a correct answer. So Dr. Amol on the first, Dr. Ravi on the second, Dr. Rahul on the third. Next question. One of the most common manifestation of heparin-induced thrombocytopenia is bleeding, arthritis, venous thrombosis, fever. 16 correct. 8 seconds left. 7, 6, 5. I think 3, 4 people are yet to answer. The answer is thrombosis. 16 people have given a correct answer. And again, Dr. Amol is maintaining the first position with the 4 correct answer continuously. Next question. All are the true statement in a damage control resuscitation surgery for experiencing trauma except target at physiological correction rather than anatomical, try for anatomical stabilization of traumatic site, hypotensive resuscitation, time for surgery should be limited to less than 90 minutes. Fourteen answers only. 7 seconds left. I think many of you have not answered. 21, 22. Yes. The correct answer is try for anatomical stabilization. We just try for the physiological stabilization. Only 5 people have given a correct answer. Let's check. Dr. Rahul came on the first, Amol on the second, Dr. Prasad on the third. Next question. Patient came with the massive pelvic trauma. Following procedure is performed. What's the name of the technique? I think Dr. Ravi has mentioned about this technique. 9 answers, 10 answers, 11. Twenty-one answers, 22. Okay, the correct answer is this is Riboa. 15 people have given a correct answer. So let's see the scoreboard. So Dr. Prasad moved to first, Dr. Amol on the second, Dr. Rahul on the third, Riya ma'am on fifth. Most common cause of upper GI bleed in India. Variceal bleed, reflux esophagitis, Mallory-Weiss, peptic ulcer. रवि सर ने आंसर कर दिया है पहले. So correct answer is peptic ulcer, not the variceal bleed. So the number of correct answers, Dr. Amol on the first, Prasad and Dr. Ravi on the third. I think we have left with the last 4 questions and competition is very close. 7,000 to 8,000, I think 6 people are there. Now let's see, 10 units of cryoprecipitate contain how much of fibrinogen? 2 answers only. 10, 11, 18. 23 answers. I think everybody has answered. The correct answer is 3 to 5 gram. The 8 people have given a correct answer. Let's check the scoreboard again. Dr. Amol on the first. Amol sir is eligible for gift or not? We don't know. 3 more questions to go. A 31-year female old patient who recently experienced PPH is now presenting with the following complaints. Diagnosis. So fatigue, inability to lactate, low blood pressure, and irregular absent menstruations. I think 3-4 people yet to answer. Last 5 seconds. So the correct answer is Sheehan syndrome. 14 people have given a correct answer. So let's check the scoreboard again. I think Dr. Amol is maintaining his position and Dr. Ravi came on third. Now, let's see. Last two question. Management of acute uremic bleed consists of all of the following options except conjugated progesterone, conjugated estrogen, desmopressin, cryoprecipitate. You need to see except. Last 2 seconds. So the correct answer is conjugated progesterone is not used for acute uremic bleed. I think only 2 people have given a correct answer. So again, Dr. Amol, sir लो gastro के लिए. Patient was having bleed. Take was done. We suggest you of which of the following data and graph how to treat it. So R time is 5 minutes, K time is 3 minutes, alpha angle 69, amplitude is 48, clot lysis time is 5%. How will you treat this graph? Amol sir must have already answered. Last 5 seconds. Okay, the correct answer is transfuse the platelet. The maximum amplitude was small. So only 4 correct answers. So the third prize goes to Dr. Ravi. Let's see, the second is Dr. Prasad. And the first is Dr. Amol, I expect. Yes. And fourth is Dr. Kunal and fifth is Dr. Ria. Let's call on all of them on stage. First is Dr. Ravi. First to come on third spot. On the second position, Dr. Prasad. On the first position, Dr. Amol. I think sir needs a help to walk. With finger, he climbs podium fast. Difficult with the legs. Oh. नहीं सर. नहीं सर, कोई सेटिंग नहीं.
अमोल सर, रात की पार्टी का जुगाड़ हो गया है.
Next party is from Dr. Amol only. And we just check. Correct answers are 30%. Only 13%, 30% are the correct answer people on an average. So hope you enjoyed the game and the quiz. And congratulations all to winner. Thank you.
Thank you, Dr. Shailesh Choksey, sir, for leading us through such a mind-boggling and thought-provoking quiz. Your expertise and engaging approach not only tested our knowledge, but also deepened our understanding of critical care concepts in a truly interactive way. Now, I would like to invite Dr. Deepak Jeswani, sir, to present a token of appreciation to Dr. Shailesh Choksey. Thank you, sir.
For our next topic, hemostasis hijacked, a pharmaceutical pitfall. Our esteemed chairpersons are Dr. Jayesh Timane, who is a consultant physician at Wockhardt Hospital, Nagpur, Dr. Rahul Arora, who is a consultant hematologist and bone marrow transplant physician at Max Hospital. Jayesh? Prasad. Dr. Prasad Uddhoji, he is a practicing intensivist in Nagpur. A hematologist is a medical maestro solving the mysteries of your blood with the precision of a detective and enthusiasm of a vampire. In the realm of hemostasis, even the smallest disruption can have profound consequences, reminding us of the fragile balance our bodies maintain. It's my pleasure to introduce Dr. Riya Balikar, an esteemed consultant physician and hematologist at Kingsway Hospital. Her exceptional academic achievements include being a president awardee and a gold medalist, underscoring her dedication and expertise in the field. She is the director of HemoHeart Foundation, where she leads effort to advance in the field of hematology. Today, ma'am will be sharing her insights on a critically important topic, that is hemostasis hijacked, the pharmaceutical pitfall. In this talk, she will delve into the delicate balance of hemostasis and the unintended consequences that can arise from pharmacological interventions. I give you Dr. Riya Balikar.
Thank you so much, dear Monica. And post-lunch session, we have very few people, but this topic is something that is practically very important for us. After the very interesting quiz, I hope everyone is wide awake now. So the topic is hemostasis hijacked pharmaceutical pitfalls. I would more be concentrating on the drug-associated coagulopathy, the novel anticoagulants that we are so rampantly using in our practice. It will be covered under the following subjects. I always like to start with a little bit of history. So as far as the history of anticoagulation goes, this is the first description in history. So what they found was this leech used to suck blood out, and what they thought was the bad blood. This was one of the disease hypotheses in ancient times, that bad blood caused most of the disease. So they used to actually apply leeches to patients to cure them of whatever diseases they had, any disease, be it gangrene. Gangrene is something in which Ayurveda still uses leeches. This is a depiction of a king who actually used leeches. He thought that the leeches would be able to absorb the fat from his body. And this was the first extract that was available. It was used as anticoagulation. They killed leeches. They extracted this molecule called hirudin from the leeches, and they gave it IV. But IV, we know it's a protein. It caused a lot of complications, and then they managed to somehow isolate the purified extract in 1950s. And hirudin and its derivatives are molecules that are being used in practice now. Next was anticoagulation is something which had a lot of serendipity in it. So this was J. MacLean. He was basically working on procoagulants, but he accidentally again happened to discover heparin while working with dog livers. So that was, heparin means a molecule that is derived from the liver. So that was how heparin was discovered. And warfarin again was discovered by a disease called hemorrhagic disorder of newborn. A farmer noticed that after eating a particular hay, his cattle all fell sick, they started bleeding. And these two scientists, Carl Link and Mark Stackman, they discovered warfarin, that is dicomarol, at the Wisconsin University, that is by the name, in the 1920s. So this was all about serendipity. We know the coagulation cascade. Dr. Samir Melankari sir has nicely taken this, and we know there are so many molecules here, and that gives us a lot of scope, not as just as far as treatment we saw about the PCCs and all the molecules, but as far as use of and development of anticoagulations is also concerned. So initially there was a time when it was all non-specific drugs, and these drugs caused a lot of side effects, a lot of problems, and now we have come to targeted therapy. So which are the anticoagulants that are now available to us? The parenteral, we know there is unfractionated heparin, there is no molecular weight heparin, and there is fondaparinux. These are the indirect ones that have a variety of mechanisms of action. The direct ones, the oral hirudin, like I said, this was derived from the leech, and derivatives of hirudin is bivalirudin, argatroban. The factor 10A inhibitor, the oral, it is not available to us. Indirect oral is warfarin, again, acts on a lot of factors. direct dabigatran, which acts on thrombin, and 10A, which acts on the factor 10A, rivaroxaban, abixaban. This is something which is available to us. Now, anticoagulants are excellent drugs. We use it left, right, treatment, prophylaxis, you name it, we are using it. What about the side effects? Lot of side effects, and that is basically what we'll be seeing here. Right from hypersensitivity reactions to bone loss, hepatic renal effects, purpura fulminans, and teratogenicity. And the most important point that we are worried about, and that is bleeding. This is a patient with purpura fulminans post-warfarin. And this is how a baby looks like if the mother has taken warfarin during pregnancy. So coming to our case presentation, the first case, a known case of rheumatic heart disease with MVR done in the past. She was on warfarin 5 mg OD, presented to the ER with nausea, vomiting, headache, tachypnea, and melena. This is a CT brain. We can see a large intracranial bleed. This was a lab workup. Hemoglobin of 6, prothrombin time of 40, INR was 4. Everything else was normal apart from the creat, which was slightly high. INR 4. In ER, she received 500 ml of FFPs and 1 red blood cell. Her tachypnea worsened. She needed BiPAP support. So plasma use, we know, is associated with a lot of problems and lot of challenges. Viral infections and allergic reactions, but most important that we are worried about, and that what happened in this patient was transfusion associated circulatory overload and TRALI. So this is something, because FFP, you know, you need to give a lot of it. To correct any bleeding, the amount of FFP that needs to be given is 15 milligram per kilogram. So if you look at a 70 kg person, that comes up to a lot. And especially in patients who are severely anemic, patients who have kidney injuries, cardiac failures, transfusing so much of FFP becomes very difficult. So what is the solution to this? So what did we do next in this patient? INR is still high. It's 3, so you hardly corrected anything. So next comes the role of these newer molecules that we have. Dr. Samir Melankari sir touched on it. Dr. Jeswani sir touched on it. So what this patient received was PCC, prothrombin complex concentrate, which is nothing but the actual clotting factors which you give to the patient. Just 1,500 international units of this factor, which is roughly around 6 vials, and the INR came down to 1.7. So reversal of anticoagulation. So warfarin is one drug which is associated with a very high risk of bleeding, and GI bleed and intracranial bleeds is something that we have to be really worried about. So when is emergency reversal needed? If the patient has bleeding, patient has come to you with an emergency surgery, you are planning for it. So if it is a minimal bleeding, you can just hold the doses, you can give vitamin K. But what if it is a massive bleeding? One is FFP and the other is this complex concentrate. We'll be going into details of this. So we heard what is 3 factor and what is 4 factor. The difference is factor 7. And there is one more factor which is called FIBA. This many of us have not heard of. FIBA is nothing but the activated factors. So when we look at 3 factor and 4 factor PCC, you are basically giving inactivated factors. But when FIBA is there, you are actually giving activated factor 7, and that makes it highly prothrombotic. So one vial of 4 factor PCC, which is available to us, it is 250 units. And 250 units describes the other factors, they may be varying in amount. But the actual factor which is responsible for that word 250 is factor 9. So 250 represents the amount of factor 9 in the vial. And what is remarkable is that it reverses the bleeding totally within 30 minutes, whereas FFPs can take as much as 6 hours to 12 hours to reverse the bleeding. PCC is very powerful. You give it, it's a short push, within 30 minutes your bleeding is totally stopped. Indications, now actually the approved indication for PCC is warfarin toxicity. So any vitamin K, warfarin or acetone toxicity, that is what the indication for this concentrated. There are other indications like whenever the patient has a deficiency of any of the factors, also it is used. So these are FDA approved. But now we are also using it off-label, like Dr. Jeswani sir mentioned in his article, in his presentation. If there is any bleeding which is not responding to anything, then the medicine that would work is PCC, and we are using it quite a lot, especially patients with intracerebral bleed, NOAC-associated bleeding. PCC is something that we are using, and we are getting excellent results. Now, what is the dose? So the dose roughly is 20 to 40 per kilogram. Body weight is the dose, 20 to 40 units per kilogram. These are the recommendations. So obviously it would be based on the INR, how much the INR is. Less than 2, normally we don't have to use it unless the patient has obvious bleeding. In that case, the dose is around 15 to 25. 2 to 4, we go for around 20 micrograms per kg, and 4 to 6, it is around 40 micrograms per kg. Roughly, that is how we do it. Each vial is 250 international units. So roughly, if you want to calculate, 1 vial for every 10 kg of body weight. It is just like cryoprecipitate. Cryoprecipitate, we use 1 cryoprecipitate for 10 kg body weight. Same here, 1 vial for every 10 kg of body weight, provided the INR is between 2 to 4. So what is the advantage? It's a beautiful drug, acts very fast. FFP, you need to tell the blood bank, you have to thaw it, arrange it for us. Here there is no wait time. You don't have to look at which blood group you are looking at. You don't have to risk trally, you don't have to risk taco and any transfusion reactions. And like I said, the reversal is very fast. It is within 30 minutes. These are studies and trials that have shown that this is very, very effective. You can see efficacy and intent to treat at 4 hours. This is plasma, that is FFP versus PCC. At 4 hours, the patients who had complete control of bleeding was 82%, whereas with FFP it was just 50%. If you looked at 30 minutes, that incidence was 62% with PCC, and with plasma it was hardly 9%. And that is very significant numbers. So again, these are trials that, lot of trials regarding efficacy of this PCC. Now, you will say, what about the cost? PCC now is available at very reasonable rates, and normally the second doses of PCC are not needed. 1 dose does it all. So there was a trial here, there was a study here, FFP versus PCC for emergency reversal of warfarin, and what is surprisingly found that the cost wise also this PCC was much more effective, as in the number of hospital stays reduced, the patient was reversed very rapidly, so the other complications, the stay, everything reduced. So conclusion was PCC was financially also much more effective than FFPs. So that was the first case. Second case, 56-year-old gentleman, he came with fractured tibia following a road traffic accident. He was operated for reduction of the fracture. He was started on low molecular weight prophylaxis as his routine practice. Day 7, this patient develops hemiparesis with slurring of speech. Was it a bleed? But the CT brain was normal. They then did the MRI, it showed a right MCA infarct. The patient was, initially he was on prophylactic dose heparin, he was put on therapeutic dose of LMWH along with antiplatelets. So obviously you have an infarct, you think it is because of the coagulation effect of this disease, the state, so LMWH and antiplatelets. The hematologist was called in because the platelet count was 60,000. So they wanted to basically decide on the dose of heparin. Should I give it? Should I not give it? Should I switch? So what was the diagnosis in this patient? Yes. So this patient had HIT, heparin-induced thrombocytopenia with thrombosis. So whenever any patient on heparin comes to us with low platelets and instead of bleed as what is expected, this patient has thrombosis. Obviously, venous thrombosis is much more common, but arterial thrombosis, especially strokes, are something that can be seen, especially in elderly patients. So we suspected HIT. We did the 40 score. Dr. Milankari sir has shown us what this is. HIT serology. Now, sir said this test is available to us, PF4 heparin IgG. So this is available as HIT serology. Most labs are now doing it, and the results are, they take time, they take 3 days to give the reports. But whenever we are clinically suspecting it, the treatment of this is to stop the heparin. So what is the pathophysiology? Heparin in any preparation, unfractionated heparin, low molecular weight heparin, even something like a diluted heparin flush, even one diluted heparin flush, as much as just you've taken 2,500 units, you've diluted it, even that is capable of causing HIT. So it is very, very important to remember this. And what exactly happens is there are antibodies formed to this complex, PF4 heparin complex. Platelets get activated and there is extensive thrombosis in the body. This is the 4T score, which tells us whether we should think of HIT or no. Dr. Milankari sir has discussed this in detail. So this patient was started on fondaparinux. All heparin was stopped. Other options are DOACs, the novel anticoagulants that we have, Bevalirudin and ergatroban if you are looking at injectable. Now in ECMO patients, Bevalirudin is something that is being used because you need constant round the clock. Infusions or constant use of this drug is something that is used mainly in ECMO patients. Otherwise, we are not using this much. Fonda and DOACs are good enough. So case 3, 89-year-old man admitted to the hospital because of confusion. He had hypertension, osteoarthritis and non-valvular atrial fibrillation. Warfarin had recently been switched to dabigatran because of poor control of INR. 150 mg BD was the dose and CT brain showed a IC bleed. So this was his report, everything else was normal. So what this patient had was a dabigatran induced IC bleed. And like one of the questions was, do we have an antidote? Yes, we have an antidote. It is called Praxbind. So if we are using the original molecule dabigatran, Pradixa, then this is available to us. Basically, 2 vials have to be used. The therapeutic dose is 2 vials of Praxbind. And in patients who are not using the innovative molecule, or you don't have access to it, or in the other cases like rivaroxaban and apixaban, if you are using, the antidote is not available in India and Dexanet is not available. So in these patients, the other options are FFPs, and one option is activated charcoal. So if the patient has taken the drug within 2 hours, the last dose has been within 2 hours, then activated charcoal ingestion can be given to the patient. It really helps. Hemodialysis can be tried in patients, and other options obviously are the PCCs and FEMA, and if nothing is available, FFP should be there. So this is again, like I said, rivaroxaban and apixaban, we don't have the antidote available. So this is treatment of this apixaban induced coagulopathy with PCC. 2000 units was the median dose of PCC that they have used. So you can see how effective it is. Around 70% of the patients have shown complete reversal with a dose of 2000, which is not a very high dose. So reversal agents, again, we have very good reversal agents available, but if they are not available, we can see PCC here is at par, or it's actually slightly scoring better than idaroxaban and Dexanate. So what is the AHA update for patients with IC bleed who were on novel anticoagulants? We can see warfarin. Like I said, more than 2 is when we use the PCC, but in patients who are INR less than 2 also, one problem with these drugs is risk of thrombosis. So when the INR is less than 2 and the patient has bleeding, we get a little worry in using it. But as per these guidelines, we can safely use PCC in patients who have INR more than 1.2 also. The dose would be very low, it would be 10 to 15 units per kg only. And obviously the vitamin K should be added to this. Dabigatran, we've seen less than 2 hours, charcoal. If the patient has bleeding, idaruximab. If the patient doesn't have bleeding, just observe the patient. PCC also is good enough. Heparin, again, we know protamine is the drug of choice. Protamine doesn't help much with low molecular weight heparin. It is a drug of choice for unfractionated heparin, but it can still be used for milder bleedings. So we know these are, like I mentioned, all these molecules, all these factors, they have given us ample new targets, and more molecules are being developed as anticoagulants also and as reversing agents also. So one of these molecules is FEBA. Last few slides. FIBA is factor 8 inhibitor bypassing agent. So as the name suggests, this drug was first used in hemophilia patients with inhibitors. So these are patients who do not respond to conventional factor 8 preparations. So these patients were treated with FIBA when they had a breakthrough bleed or even for prophylaxis. And the results were so beautiful. Patients who could not be controlled on anything had such beautiful hemostasis that they started using it for other indications also. And FIBA has been used left, right as a substitute to PCC, especially when PCC fails. FIBA and Novo7 are two molecules which are being used. Novo7, this is factor 7, activated factor 7. Like we saw, 3-factor and 4-factor PCC had factor 7, and FIBA had activated factor 7. So why not just give factor 7? And the rationale behind this was factor 7 bypasses the intrinsic pathway completely. It acts via the extrinsic pathway and the tissue factor mechanism, which you don't need all the other clotting factors. Directly acts on thrombin and forms fibrinogen. So this was activated factor 7, recombinantly produced. Beautiful drug. When every option fails, this is what we give. But the problem with this, it causes something called a thrombin burst. So these patients are at very, very, very high risk of thrombosis. So thrombogenicity, if you see, the lowest is for PCC, which is pretty safe. Next is for FIBA, and the highest thrombogenic is factor 7. But the beauty of factor 7, if you want, suppose your patient is bleeding like a tap, there is nothing you can do. We saw that the factor PCC concentrate takes around 30 minutes to act, but Novo7 acts within 2 to 5 minutes. So if you don't have time, emergency is this, and again it just has to be just dissolved. Just dissolve it, make a 5 ml preparation, and just give it short push. So within 30 seconds, you can administer the drug, and within 2 minutes, the bleeding stops completely. So it's a beautiful, beautiful drug, and 90% of the patients respond completely just by the first dose. There are times when you need to repeat it, but that is very unusual. So these drugs are very, very beautiful drugs, but the problem with these drugs is thrombosis. So though we've seen that these drugs should be used, I would say use these drugs with caution, especially in patients who are at very high risk of thrombosis. Be very, 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 very careful. So take home message: wise use of anticoagulants, awareness of the different adverse effects, monitoring of the patient for any bleeding, rapid initiation of reversal therapy, which is so nicely available to us, but at the same time, judicious use of PCC, FIBA, and Novo7. Thank you very much.
An excellent presentation, Ria. Any questions from the house? As Ria promptly said that when we are using these agents like PCC and Novo7, the risk of thrombosis is always there. So Ria, any experience of thrombosis with PCC, 3-factor or 4-factor PCC in an acute situation?
We use it a lot in our ICU. We get a lot of patients with DIC and polytrauma patients. So we use it a lot, and NOAC reversal also. But till now, I have not seen any patient with PCC. But Novo7, I have seen 2 patients. One who presented with a stroke, and one who had a venous thrombosis. FIBA, again, we use it in our hemophilia patient with inhibitors. So FIBA till date, I have used FIBA very less, but till date I have not seen any thrombosis. But Novo7 is something that thrombosis is pretty much common.
So that is one factor which we need to keep in our mind before we use this, though the risk of thrombosis in our situation is less. Another comment which I would like to make is whenever we diagnose the patient with HIT, we always see that there is a thrombocytopenia. But recently we got a patient where the patient developed a thrombosis post-heparin and the platelet count was still within normal limits. It was like 150. It has dropped from 3 lakhs to 1.58. But sometimes the platelet counts may be normal in a patients of HIT. So that is something which we should keep in our mind when we see a thrombotic patients who have received heparin. So
Yes,
because
absolutely.
this is only 15% of the patients when we retrospectively analyze that what happens to such a patient.
Yes, because if you look at the 4 T's, after the values which is less than 1.5 lakhs, the other thing is a 50% reduction in the platelet count. So even that matters. So like in this case, the platelet count was 3 lakhs. So if it comes down to 1.5 lakh, there is a 50% reduction. So like Dr. Rahul said, normal platelet count doesn't mean it is not hit. Absolutely agreed.
Any other question? Okay. Yeah, please.
Yeah, it was very nice and excellent informative session, Dr. Ria madam. So see, I've myself have got one question for one patient we had. He stayed with us for a span of 1.5 months around. So he was quite young guy actually. He has developed. He was having this EJV cannulation, and then subsequently he was in central line was inserted, and then he has developed thrombus inside both right IJV as well as left EJV, and it persisted but quite around until the time he was getting discharged. It was persistent, and meanwhile actually we had given him fragment from renal point of view, and then at the end while repeating this scanning also, it was still persistent, and then at the end actually based on a lot of issues actually we had to discharge the patient, and then we had discharged that patient on apixaban. So actually while searching I could not find exactly any recommendation to go ahead with the EJV or this chronic thrombus, or whether to treat that or let it that be, or what should we do about that in that case. So we have discharged the patient on apixaban as such, and we have called the patient after 6 weeks. So we are still waiting for that patient, but I just want to ask for myself exactly what should we have done apart from this.
So what was the main disease that the patient had?
Disease was he was having a severe septic shock with prolonged multiple exterior organisms has developed. So, but mainly during the stay, he developed this probably because of the cannulation. EGV it was done, and he had developed this thrombus, and it was quite persistent. There is no DVT as such. So, for this, so with these venous thrombosis, I could not find any kind of treatment. What should we go ahead with that? For to treat whether to treat that first of all, and if we have to treat that for how long duration with what? So at the end, actually, after fragmentation, the same thing we discharged on apixaban. So, but we are still that patient is yet to come to us.
Yes.
So
for EJV thrombosis, I think a 12-week course, a short course of anticoagulation should be fine. You should not ignore it. Even superficial venous thrombosis, we don't ignore it. We give them a short course. Maybe a 12-week course, and then we put them off anticoagulation.
So it's around 12-week course. Apixaban will do that.
It should be given. Apixaban or whatever you prefer. And I think in this patient there was recurrent thrombosis. Even IJV the patient had thrombosis.
Right. IJV as well as left EJV. It's in that patient.
So
actually.
in this patient also, more importantly, we need to rule out some thrombophilic condition.
Yeah.
Because recurrent thrombosis should not happen. Even with sepsis, why should it happen so much?
Okay, because
so some thrombophilic condition, I think, should be ruled out.
Because there was no, apart from this, there was only EJV cannulation was there, which lasted for around 7 days in him.
One more thing is maybe if this was some infection or something, some thrombophlebitis there that caused it, then maybe you can, you can just afford to ignore it. But if it was not associated with thrombophlebitis, it is de novo thrombus which has developed, and recurrent you are getting IJV thrombosis, then you should work out for some thrombophilic condition.
Probably on the next follow-up, actually, we'll go into that.
Thrombophilic
IDV
should be done.
Thank you so much.
Lifelong anticoagulation. There is a lot of controversy about it. So initially it was said that any unprovoked thrombus you should give for go for a long-term anticoagulation. Now there are question marks on the fact that whether you should test the patient for thrombophilia at all if the patient has come to you upfront without any provoked factors. So if the patient has any recurrent thrombosis, if the patient has a strong family history of thrombosis, plus your thrombophilic profile is showing that your protein C, protein S is really very low, and the patient had a major organ thrombosis, then these patients should be on lifelong anticoagulation. All unprovoked thrombosis should not receive lifelong anticoagulation.
Stop, he used to develop pains again.
Yes.
So it's now like 2 years that I have to continue. Whenever I stop it, he develops pain, and the fellow is not having enough money to investigate. So is it wise to continue anticoagulation
This
such kind of?
patient, I think you should, sir. Because atypical site thrombosis, especially if you're saying the moment you stop it, the patient is symptomatic again, then there is a good chance that you are dealing with some thrombophilic condition. So this patient should be continued. One more thing is for any splanchnic venous thrombosis, any abdominal vessel thrombosis, we have to rule out something like a myeloproliferative neoplasm. PNH should be ruled out. So these two conditions more present with abdominal vessel thrombosis than they present with peripheral or cerebral thrombosis. So at least those two tests maybe can be done for the patient.
Excellent session, Riya. Now we hand over the mic to the MOCs for further.
Thank you.
Thank you, ma'am, for delivering such a compelling and insightful presentation. Now, I would like to invite Chairperson to present a memento to Dr. Riya Balika, ma'am. Thank you, sir. I kindly request Dr. Dilip Shirsagar, sir, to felicitate chairpersons with token of appreciation. Stepping forward to our next topic, don't ignore the gut feeling, for which our distinguished chairpersons are Dr. Sudhir Chafle, sir. He is a ICU in charge at Getwell Hospital, Nagpur. Dr. Deepak Parashar, sir. He is a director at Parashar Clinic, Kadmeshwar. Dr. Ravi Daswani, sir. He is a gastroenterologist and hepatologist at Gastron Hospital, Nagpur. In the landscape of medical emergencies, GI bleeds stand out for their potential severity, reminding us of the importance of vigilance and expertise in patient care. So, our next topic, don't ignore the gut feeling, GI bleed, is crucial for both healthcare professionals and patients alike. Dr. Ravindra Ghawat, sir, will share his insights on why it's vital to recognize and act on the early symptoms of GI bleeding, the latest advancements in treatment, and how we can improve patient outcomes. So,
good afternoon, everyone. I think in concluding session, I would like to Dr. Ravindra Ghawat to enlighten us one of the most important topic that don't ignore the GI gut feeling, the GI bleed, which is most common things which we deal day to day in practice in your ICU, and it's a very critical thing, and sometimes it's very difficult to get on from where it's bleeding. So obscure bleeding is also one of the most common things what we have to see in our practice. So I request Ravindra to just enlighten us about this day to day problems with GI bleed.
Thank you for those nice words at the fag end of the day. Thank you for all the audience who still have the patience and zeal to be here after a heavy lunch and on a Sunday evening. So, I thought because we are at the end of the session, rather than discussing a lecture, I thought it would be better that we talk about cases that could at least keep all of us engaged, including myself. So, rather than discussing theory, as I said, we will just, these are all cases that has sort of been managed in my hospital. So the first case, 76-year-old male was hypertensive, was on telmisartan, aspirin, admitted with complaints of blood in stool 2 episodes one day. bloody vomit was since 2 days, since 1 day. Chest pain since last 6 hours, and he was referred from some other hospital to our ICU, and he was conscious when he came, oriented, but little dull and drowsy, elderly man, 80 by 60 BP unsupported, that is without vasopressors. He was tachycardic, perhaps was mild tenderness, but otherwise soft. Rest of the systemic examination was normal. No similar complaints in the past. And ECG showed that there is ST depression in V3 to V6 with ST depression in 2-3 AVF, and TROPI was also positive. And 2D echo showed that the left ventricular ejection fraction is 20% with grade 2 LVDD. Hemoglobin was 7. There was quite a bit of acidosis with lactates which were high. Now the big question is what to do with this patient. In some time the patient had sudden hemodynamic compromise. So immediately venous and arterial sheath that we do was inserted. Coagulating parameters were normal. So this was the time when I entered the ICU, and one of my consultants and the residents were managing the patient. The patient was immediately started on noradrenaline vasopressin. He was on 25 ml of noradrenaline. We make a dilution of 1850. So rather than going into micro, I would say that's a very large dose. And the vasopressin was 2 ml, the ejection fraction was 20%, and everybody thought he's into cardiogenic shock because ejection fraction was 20% and STT depression. And the big dilemma was what to do first, whether to manage the bleeding. They were wary of giving fluids. Nobody was interested in, nobody asked for blood because everybody thought that's a cardiogenic shock. The cardiologist was called, IBP was kept ready for insertion. I entered and I just looked at the parameters and say, okay, this is a patient, what should be the priority? Whether you manage the bleeding first or you manage the cardiogenic shock first. Any takes.
Bleeding.
Yeah, so the cardiologist would say manage the bleeding, the endoscopy said manage the cardiogenic shock, make the patient stable, and then I will do the scopy. The cardiologist said first to manage the bleeding and then I will do the angiography. Anyways, when I saw him, I just pushed him, I just ignored the ejection fraction and pushed him around 1.5 liters of fluid, and then immediately asked for 2 bloods, which means within half an hour we could get those bloods cross matched. Fortunately, the blood group was also O positive, I suppose. And within a span of maybe 1 hour to 2 hours, I called up the endoscopist and I said, nothing doing. You have to come and do the scopy immediately. I am not going to wait for the hemodynamics to get stabilized. The hemodynamics will get stabilized only when you come and address the source of the bleeding. So I insisted, intubated the patient, ABC has to be followed. And the endoscopist came, there were some ulcers in the esophagus and stomach, and then they were addressed. So within a span of half an hour to 1 hour, his noradrenaline requirement was at 2 ml per hour and the vasopressin was off, and he had a stable hemodynamics. We extubated the patient next day. 2 units of blood transfusion was given. Simultaneously, UGI scopy was performed, and the UGI scopy revealed deep ulcers at the GE junction, and there were few oozing ulcers. They looked like 2 ulcers. And the important thing was in the UGI scopy, what you should do. There are 2 options that you have. Either you inject or you do APC. For this patient, we chose to do APC. Why do you think so? So here a patient who had recent MI, so we did not want to give adrenaline to this patient. If you give adrenaline, then it might just exacerbate the MI. So APC was the chosen treatment. Patient did well. The next day, these were the endoscopy findings. We'll not go into details. Now the next question was, because he had an MI, the cardiologist was after us to start about anticoagulation and aspirin. Okay, so in next 24 hours, though the gastroenterologist was not very confident, we said we will start aspirin. Within next 24 hours, we started aspirin at 75 milligrams. 75 milligram, 150 milligram, or any more dose, they equally flare in preventing or treating the MI. So they are equitable. Even 40 milligram aspirin is good enough. We thought whether we could start clopidogrel or double antiplatelet, but that was too risky with our recent bleeding. The patient had a stroke. So patient did well for around 3-4 days. He was quite stable. He was mobilized, and we thought he will not just. And during this time, he also developed AKI. The creatinine had gone up to 4. So obviously, the cardiologist was not very happy to do an angiography and angioplasty. So this is how we were waiting for the shock to reverse and the creatinine to come down, and we thought we would do an angiograph and subsequently do an intervention. 4 days, and we were about to sort of next day plan an angiogram, and the same night he had an arrest, unfortunately. That was probably ventricular fibrillation, and that was secondary to MI. But these are very catch-22 situation. It's very difficult to address, especially when you have a patient who is immediately bleeding. Though we were insisting to the cardiologist that probably now that the patient has stabilized, we have started ecosystem, don't wait, immediately address the. And initially didn't, he was waiting for the creatinine, but here probably you also cannot wait for the creatinine, you need to address the MI as well. So very catch-22 situation. You cannot ignore a GI bleed. Now again, the take-home message is that when you have a patient with GI bleed and simultaneously myocardial infarction, it is better to address the GI bleed immediately and then address the myocardial infarction, unless and until the patient is in as a left main disease, as in severe shock. The problem is if you intervene in a patient who has got an MI, they are like, you are going to use heparin, you are going to use, they are likely to bleed as well. You might use antiplatelets, you might require double antiplatelet course. If you don't address the cause of the GI bleed, then the patient would continue to bleed, and anyways they would not survive. Probably to some extent you can manage the cardiac part little conservatively till the time you address the GI bleed. So that is the take-home message. The second take-home message is that you did not wait for aspirin and antiplatelet to start after a GI bleed or even after a GI surgery. Now, in fact, the trend is to continue aspirin throughout the surgery, like for patients who are operated for CABG bypass. They are on antiplatelets, so you don't stop always. You don't get a chance to stop antiplatelets in them 48 hours before or so. So you can, at least aspirin is known to be very safe, or supposed to be very safe throughout surgery. On the day of surgery, also people give aspirin, and the next day a regular dose after surgery, after 12 hours or 24 hours, the regular dose of aspirin can be given. So that is the take-home message. And even this type of patient, you can start aspirin early. There was a question which had come in few previous talks, whether after neurosurgery you can start anticoagulation and antiplatelets. So neurosurgery is a little catch-22 situation again, tricky situation. But yes, within 3 to 4 days you have repeated a scan and there is no active bleeding, and if the surgeon is reasonably sure about his skills of hemostasis, you can still start an antiplatelet or anticoagulant in neurosurgical cases. And I am sure in next few years it is going to be even shorter period that recommendations are going to come. So this is what I had thought 15 years back, that we should start ecospin immediately, should start anticoagulation immediately. Pehle to even post-op patients, surgeons would not allow us to start anticoagulants immediately. And now, even before the surgery, especially in orthopedic patients and trauma, they give anticoagulants on the day before surgery and immediately 6 hours after. So these are coming in the recommendation. The reason being, patients don't die of bleeding, but they definitely die of pulmonary embolism if it is in a large thrombus. Okay, this is the second case. 42-year-old female, hypothyroid. I will not go into all these details, but basically she had pancreatitis and edematous pancreatitis and peripancreatic fluid collection, and then she was managed for the pancreatitis, and then MRCP and all those things were done, and basically she had an epigastric pain and vomiting which started on day 31 of the pancreatitis. These were the CT findings, and what you can find out is the walled-off necrosis there, pancreatic walled-off necrosis, and almost necrosis next to the stomach, and the stomach lumen has actually gone less because of the walled-off necrosis. It was pushing the stomach, and a decision to do a laparoscopic cystogastrostomy was taken, and it was done. Patient did well after the laparoscopic cystogastrostomy, and then patient was discharged day 45. On day 55, after he presented with, after discharge, she presented with, total day 55 of the illness, she presented with 3 episodes of hematomesis. And that's when the upper GI scopy was done, and they found that there was a bleeding at the cystogastrostomy site. Okay. So hemostasis, local hemostatic agents were adjured, injections were done, and the bleeding could be controlled. The gastroscopy said that now there is no bleeding. The patient was obviously intubated. That is one more take-home point, that if you have a patient with shock or massive bleeding, always intubate them, protect the airway, and do the scopy peacefully. Rather than struggling to do an endoscopy. Most of the time, people are wary about intubation and ventilation. क्यों करना है, मैं कर दूंगा, I will do manage. Don't do that. Give good sedation. Make the endoscopies comfortable to do the scopy. That will give you better results as far as therapeutics of endoscopy are concerned. So what happens? Next 24 hours में intubate करते हैं ना. So intubate the patient for airway protection and when the patient is in shock and especially when there is massive bleeding. So this was the finding. There was bleeding from the cystogastrostomy site. It looks easy till that time, isn't it? क्या है? Bleeding दिखा तो this क्या हो गया? Okay. So check scopy was done after 2 days. There was no active bleeding, but the hemoglobin I was not very satisfied with 10 hemoglobin. It was just maintaining 7, 8 and not picking up. NJ tube was inserted for enteral feeding. No blood in the RT. No hematomasis. Patient was extubated smoothly. The check scopy was also normal, so everybody was happy except me. Because the patient was tachycardic and the hemoglobin was staying there, it was just not picking up. So somehow I was not very happy, and this is what happened on subsequent day after the extubation. The next day, even in fact, I asked my resident to ask the surgeon whether he or she is sure about extubating the patient. I want to extubate, but then do you want to do another scopy next day? So they categorically said no very confidently, and the subsequent day the patient had again hematemesis. Okay, so you have done a scopy. You have addressed the bleeding by doing a scopy and some therapeutic intervention by drugs. Now it has bled again. So what next? Okay. So obviously we did a CT scan of the abdomen and to find out whether we can find an active oozer or bleeder from the surgical side, the anastomotic side. And so there was no active oozing, but we knew that the bleeding was there. By that time, the hemoglobin also started dropping to 6 and the patient became hypotensive and tachycardic. So the decision of DSA was taken. As usual, surgeons were always reluctant to operate. So DSA was done, and on the DSA, they could not find a specific vessel which was bleeding. So embolization of the dorsal pancreatic artery, suspecting that this would be the feeding artery to the cyst and to the anastomotic side, and the right gastroepithelial artery was done. I think the interventionist radiologists are lost to intervention. Otherwise, this was a good case for them. This was done, and the intervention radiologist thought that the things have been addressed, but it was not to be. The patient had bleeding again. So now he said, okay, we did an epigastroscopy to find out. Nothing found out. Because the bleeding was like it used to come, then it used to stop, it used to come, it used to stop. By the time you do endoscopy, there was no bleeding, right? So there was probably an ulcer. So what next? So we again did a re-embolization. The intervention was too enthusiastic about addressing his skills and this problem. So he said, I will try one more, please give me a chance. And in fact, I was after the surgery, please take him to the surgery. So this time he tried a splenic artery embolization. It did not work. Patient continued to bleed in next 24 hours, and then the finally good thing was done. Good sense prevailed. The patient was taken up for surgery, and underrunning of the vessel was done after speaking to the relatives, and the patient was discharged. In fact, yesterday or day before only the patient was shifted to the ward with stable hemodynamics and on all good parameters. So take home message is, most of the surgical bleedings are addressed by surgery and not by intervention. So remember this, if you have a patient who has come to you post-operative after a surgery, most likely these patients require a re-exploration and re-surgery than anything else. Rest of the things, whether you do a scopy, whether you do all these things, embolization, they are not likely to help in this condition. And if you would be really lucky to address this problem by non-invasive methods or less invasive methods like this. Once in a while maybe, but most surgical bleedings have to be addressed by surgery and nothing else. So this is a third case, though this is not a gastrointestinal tract, but then some interesting thing. This was a 63-year-old male who was admitted for a CABG, 4 grafts received, and though it is not in this context of bleeding, that the patient, we extubated him in next 2 hours after the CABG. So same day he was extubated. In the night, he suddenly developed weakness of one limb and upper limb and lower limb, so hemiplegia. So which was noticed because he was extubated. Otherwise, he would have been sedated and would not have been noticed. But this was out of the context. But just because we are discussing the case, and we did an MRI, it found that there was a occlusion on the MCA territory. I think M2 segment of the MCA, and this was very surprising. The patient has an atherosclerotic disease, and his Dopplers were normal actually. But when we did an angio, we found that there is diffuse atherosclerotic disease, like they have a coronary atherosclerosis. In fact, both the MCs were narrow, and this one side MCs were more narrow. So sometimes, you miss those findings because patients did not have any complaint. Even the carotid Doppler was normal. So he was doing fine, routine post-operative course took 1 or 2 days more, and because he had a stroke, then he could not be weaned off the ventilator without a tracheostomy. So we did a tracheostomy. Day 10, tracheostomy is done after giving enough chance for him to be sure that he needs a tracheostomy and he doesn't get extubated. And okay, on day 15, then he was just doing rehabilitation in the ICU, was about to be shifted. On that day, he dropped his blood pressure. The blood pressure came down to 90 or something. There was no tachycardia. He was on ivabradine and beta blockers, so there was no tachycardia. And then obviously everybody thinks when you have a patient on hypotensive in the ICU, the first thing that you think about is infection, isn't it? So every time you have an hypotensive patient in the ICU after 10-15 days, you think this is an infection. So the consultant started antibiotics. The cardiothoracic surgeon said give a reference to ID. This happened on Saturday evening or Sunday. So I went on round on Monday, and I found something that some parameters are not fitting in the infection box, the septic box. So I said this doesn't look like sepsis. So there's something else. So hemoglobin was normal. So in fact, there was a drop of hemoglobin of 0.5, which was not very significant, 0.4 or 0.3. But I still said, okay, this is something which doesn't fit into sepsis. So let's do something else, and we will send this to local blood. Two local blood came 3 positive, 3 plus positive. And the next day, patient dropped his hemoglobin by 1 gram, and the very next day by 2 gram. And there was no hematomesis. The patient already had an rise tube because he was on RT feeds, and there was no bleeding from the RT as well, right? And there was no fresh bleeding from the PR, the rectum. Per annum bleeding was also not there. We did a PR examination. The abdomen was soft, the chest was clear, otherwise maintaining saturation. There was no increase in the lactate. So I stopped the antibiotics, and we just started looking for the source of bleeding. And subsequently, as the HB continued to drop, and still there was no bleeding in the RT, we did an endoscopy. And the endoscopy, as expected, came negative. There was no blooding or bleeding found in the endoscopy. And on that the same day, when on rounds, we could find some mass being palpated on the left side of the abdomen, which was not evident in the initial examination. So we did a sonography. We had actually done a sonography which did not pick anything. Then we did a sonography with a senior radiologist. We said that there is some mass there, some collection there on the left side. We did a CT scan, stool occlusion positive, and the CT scan showed this. Can you make out a large collection in the retroperitoneum there? So this was a large retroperitoneal hematoma which was there on the scan, and which can get easily missed because retroperitoneum you cannot examine them well. You don't get a swelling palpable like in the peritoneum. You can easily palpate. Retroperitoneum is there. Even the sonography doesn't pick it up. And for this patient who was sort of post CBH, there was no reason why you should develop a retroperitoneal hematoma. If you have undergone an intra-abdominal surgery or something like that there, or even the kidney surgeries, renal surgeries, then probably you would expect pancreatitis. But for not this patient, where you would expect a retroperitoneal hematoma. Okay, so then obvious choice was an interventional radiology because retroperitoneums are not easy to operate, and it's very difficult to find the source as well in retroperitoneum. So we called the interventional radiologist, and under UAG and protocol, left number arteries were cannulated, and what he could find was, there was extravasation at the L1 and L2 arteries, and these were embolized, and also the L3 and L4 arteries were also embolized. And there was active association from these. So this was the spontaneous hematoma, which is very rare, happening in the lumbar region. The vessels gave off. Again, we attributed it to the atherosclerotic disease that he had, diffuse atherosclerotic disease. So probably these vessels also, as the interventional radiologist was telling, were absolutely atherosclerotic, and that's how the patient died from there. So this was a spontaneous hematoma which responded to embolization. So again, take home message here is that patients who have a retroperitoneal bleed, the usual dictum is to embolize them rather than going for surgery. Surgery, you only invert the hematoma, you may not be able to address the problem correctly. So in retroperitoneal hematomas, the usual choice would be to do the and then again follow up the patient. Like the theme says that don't ignore the gut, don't ignore the abdomen, I would say. So you should not save or you should not stop unless and until you reach to a diagnosis that where the bleeding is from and what is the source of the bleeding. Right? You need to continually, vigilantly find out the source of bleeding so that you can address it. The patient is discharged now with a tracheostomy, of course, and with a stroke, but he's doing better and with a normal hemoglobin and so on. So the last case, 38-year-old male, known case of CLD. This is a simple case. Decompensated, admitted with abdominal pain, jaundice, hematemesis, and AKI, required CRRT. We started him on CRRT. He also had a CPR because he was severe hypotensive outside hospital. When he came, ROC was achieved, then was transposed to J. Because now his INR was 2.8, hemoglobin was 6.8. He was on very high vasopressor doses, noradrenaline vasopressin. Will you transfuse this patient? Yes, there is no doubt about it. Will you transfuse FFPs? Yes, this patient requires FFP, right? 2.8 INR and actively bleeding and coagulopathic patient, right? So we did an upper endoscopy and blood products were given, and what was found was so we fortunately have take, and the coagulopathy was corrected as per the take, and blood products are given. You can see large varices there in the upper GI scopy, which is expected in patients with cirrhosis, right? And then these were the findings. There are two varices. EVL was done and 2 bands were applied. Thermal also showed altered blood, and the scopy showed that there was a large deep ulcer in the antrum at 2 centimeter, which was not bleeding but probably bled later. And duodenum also showed 2 ulcers. So this patient had variceal bleeding as well as the patient also had 2 ulcers. And many a times in varices also you get bleeding and ischemic ulcers in the varices. So you have two pathologies, you have varices as well as ulcers, and it becomes very difficult to manage them. Ultimately, the patient did not do well because of his condition. So this is just an overview of the variceal and non-variceal bleeding, how you approach them, and there are different approaches. And the major interventions are, of course, you resuscitate the patient, look at the airway, breathing, circulation, Q blood for blood, and so on, vasopressors. In patients with variceal bleeding, what is another important thing is, different is you use vasopressin in spite of noradrenaline as a first choice of vasopressor, because it is supposed to cause splanchnic vasoconstriction mode. Number one. Number two, you can also use terlipressin to control the bleeding. And in variceal bleeding, even after doing the scopy, you follow it with a terlipressin, either in split doses or infusion for 24 to 48 hours. That is one. Endoscopies, you should intubate whenever it's necessary, and APC and those things are for the endoscopy. Sometimes embolization and surgery if the bleeding is intractable or not responding to the routine therapeutic measures. And throughout, you need to monitor hemoglobin and the hemodynamics as well. Sometimes in variceal bleeding, if they are refractory, you also have an option of doing a TIPS. The ultimate option is to do a transplant, but sometimes if you decrease the portal pressure by doing a TIPS, then the bleeding gets controlled. The risk is, of course, of hepatic encephalopathy, and usually TIPS is a plastic procedure, and it is used as an adjuvant or bridge to transplant. But I will not utter again. Criticare. Thank you.
Excellent talk, sir. Very nicely, you have presented the variety of cases of GI bleeding. I am being a gastroenterologist, I had few points and few questions to ask. The case number one, sir, as you rightly said, as a gastroenterologist, we want the patient to be stable. But as in this case, if the patient is having active bleeding, the guidelines say that ABC has to be managed and we should intervene. And again in the second case, when there is active bleeding, the chance of finding the bleeder is the highest. And when we control the bleed and it stops, that gives us the most important indicator that now that we can proceed with the other intervention.
Yeah, so I will answer your first question. The dilemma in the first question was that the patient had two pathologies at single time. So if you have a single pathology, if the ECG was normal, EF was normal, then it was very easy to take a decision. Okay, this is the trouble, and you need to address it on priority basis. But here you were confused whether this is a hypovolemic and hemorrhagic shock versus a cardiogenic shock, because the patient also had a posterior wall MI. So there, when you are in this type of trouble, you always, tu pehle.
I completely agree.
But yes, the gastroenterologist immediately came and did address the problem. The second case, you're right, when the chances of finding out a bleeding on an embolization is less, the angiogram is most when the patient is actively bleeding. So to give the advantage to the interventional radiologist, we shifted the patient within half an hour of the episode of the bleeding, because this is what we were discussing, that if you want to find a bleeder on the angiogram, you have to do it immediately, when the patient is actively bleeding. So when the episode was there, within half an hour to utna lagega to shift the patient to the cath lab and all. So within half an hour the patient was on cath lab table. Fortunately the intervention radiologist was also available, and we did the scopy, he did the angiogram.
Sir,
So the reason was probably the bleeding was coming and it was just stopping with a clot, and it was small and there was large necrotic area, so there was no particular single vessel which was bleeding. So this was a walled-off necrosis, post-pancreatic necrosis, pancreatitis necrosis. So the area was quite ischemic and necrosed, and there were a lot of diffuse bleeders maybe, and there was no single bleeder which was there, and that's why I think he could not address it there.
Exactly, sir. So most of the cases of cystogastrostomy, that complete area is a diffuse ooze with some amount of platelet dysfunctions are in because of that infected. Sir, again the first case, I couldn't actually see the images of the endoscopy report, but if it is like a diffuse bleeding, then we have with APC we have other options like hemospray powder, which is really helpful. Because APC again causes some amount of ischemic necrosis of the mucosa and again can lead to bleeding, because already this patient would have required a thrombolytics or heparin. So I may suggest that it.
Because the patient was in shock, hemospray may not be a very good option than APC, because APC is going to give a more definitive control of the bleeding as compared to the hemospray. Maybe that is the reason why it was chosen as a first line therapy.
And probably if it was 2 or 3 areas of bleed, hemoclip application would have been a good idea as compared to adrenaline injection again.
Hemoclip, if you see an active bleeder, then it makes sense to apply hemoclip. But here there was no active bleeding, a spurter. So the patients who have a spurter or an active arterial bleed, probably there you would apply hemoclip. But here they were diffuse ulcers and there was no actively bleeding also from one side. Erythromycin, not really, not really. No, see, the erythromycin is a prokinetic. So how will it improve the visibility if it acts as a prokinetic agent, and it would help in emptying the stomach. So that is the only advantage. If anybody has any other scientific reason for use of erythromycin, I don't see. That is the only thing that.
Yeah. So it can be used when if someone is like not fasting for long or has recently, but there are preparations in the market these days which are available commercial also, which are semithicone preparations. Most of the times we find lot of bubbles inside and it is difficult to visualize. So they increase the transit, and again this can be done. Some people also use levosulpiride or like metoclopramide also for prokinetics.
We give metoprolol injection, but I'm not sure whether they really help.
It doesn't much help. Sir, in the third case, the patient had retroperitoneal hematoma. Stool occult blood being positive, could there be anything else which have got that?
So absolutely correct, and that was the first thought, because such patient who was on double antiplatelet cover plus anticoagulation, the first thought was this was an upper GI bleed, and that's why the stool occult blood also came positive. But then the upper GI scopy was normal, throughout. It's not absolutely clean. But yes, there is a possibility that there might be small ulcers there, or even ulcers in the
Small
other parts
bubble.
of the intestine, probably in the small intestine. But there was no other way. We did a CT scan with angiogram and it did not pick up any ulcer. But yes, there is a possibility that there might be ulcer. Plus, patient was bedridden for some time, so stercorals also are possible. We didn't do a colonoscopy because there was no hematochezia, And then once we found this as a large hematoma there, then it was obvious that this must be the source of bleeding. Patient responded well once he was embolized.
Just one last.
Please go ahead.
Actually, we have got one patient with inflammatory bowel disease who recently underwent angioplasty. He put two stents around 10-12 bags, and then he presented with the GI bleed. Colonoscopy shows multiple small ulcers. So how to go ahead with the antiplatelets in such patients? Now the problem was that the intervention was not possible because it was oozing from the multiple sites. Even the interventional radiologist saying they are not able to do any interventions right now. So how to go with the antiplatelets? Because the thing is that now underwent plasty with the two stents, and it's a really dilemma. Means how to go ahead with, because now cardiologists don't want to stop any antiplatelets, and he was still bleeding. The hemoglobin is also dropping in between.
So if this patient has multiple colonic ulcers, and how deep they were up to the...
It was superficial. I mean, that's why it's not possible to do any interventions also. And
Were
from
they
multiple.
in the lower part, or they were up
It's
to
a 3 or 4 places, sir. It started from the there are few ulcers in ileum, there are few ulcers in the colon.
No, if somebody has that much extensive ulcer, then you really need to find out what is the reason for those ulcers.
There
Whether
are-
there is ischemic ulcers, or there is something else, diverticulosis, or something else, or clostridium. So you need to find out what is the reason for the ulcers, number one. Number two, here, so the patient is bleeding, maintenance of stent, because patient already had an in-stent thrombosis. So you will have to give some antiplatelets. Instead of giving 2 antiplatelets, maybe 1 antiplatelet will have to be continued. You cannot stop it, otherwise the patient will develop in-stent thrombosis. And simultaneously, you need to look at what has caused the bleeding in the colon. If it is restricted to colon and the patient continues to bleed, the option would be to do a hemicolectomy or a complete colectomy, and then do an ileostomy for passage of motion. Because we had one patient who had an extensive colonic ulcers, and Clostridium difficile came positive, and he was bleeding from this ulcer. Too many ulcers, throughout, and again the same situation. With some 2 antiplatelets, 3 times undergone angioplasty. So we decided to do the colectomy and did an ileostomy, and then continued with the 2 antiplatelet cover.
So again, the problem is that only it's very difficult to go for what procedure we want to go, because we have got the multiple lesions at multiple levels involving the most of the things. We have got small colon and large boils or involvement, small boil and large. So it's
No,
very sometimes very.
what he says is makes sense, and that is correct. So what he says is that in case you are not able to give 2 antiplatelets, it would be reasonably safe to give 1 antiplatelet and 1 anticoagulant. So that's what you want to say, isn't it?
As far as we want to avoid any cardiac issues, So to avoid cardiac issues and at the same time to keep the bleeding during the procedure minimal, what we can do is stop the antiplatelets, shift the patient to anticoagulation, and keep the anticoagulation on till the time of procedure, because antiplatelet effect will take at least 3 days. Now that is also questionable. Like earlier it was 7 days, now it is 3 days. Now they say you can take the patient on even on antiplatelet. So we can consider that, because you will experience, even the cardiac people will have an experience that patients who are on antiplatelet and they are taken for emergency surgery, they do not have a bleeding issues too much. And the another situation is, if that procedure is elective, we can shift the patient to anticoagulation, stop the anticoagulation 6 to 12 hours before the procedure, and take the patient for procedure to avoid any cardiac event. From that perspective, I wanted to speak.
Yeah, that's good.
Thank you, sir, for this most enlightening and interesting talk. The case-based presentation really kept us engaged in this. Thank you very much, sir.
Thank you. Thank you for a patient hearing. Thank you for inviting me and engaging me in this nice discussion and the conference as well. Thank you, team of Criticare, Deepak, Shailesh, and all of you, all your team. Thank you, chairpersons.
I would like to invite Dr. Deepak Jaswani to please present a token of appreciation to the chairpersons. Dear delegates, it is my great pleasure to invite our organizing secretary, Dr. Deepti Jaswani ma'am, for our vote of thanks to all the people who have made this convention a possibility. She has been a pillar on which not only this conference hinges, but the whole edifice of Criticare is standing. I would rather say she is the sun of our solar system around which we all revolve as planets, including Dr. Deepak Jaswani. We are honored to have her with us today, and I invite Dr. Deepti Jaswani to express our collective gratitude.
Good evening, good afternoon, all of you. To start with the conference, we need a vision. And that vision has always been created by none other than my husband, Dr. Deepak Jeswani. On behalf of all the attendees, speakers, and volunteers, I would like to extend our sincere gratitude and appreciation for your outstanding leadership and dedication in organizing this successful conference. Your tireless effort, attention to detail, and unwavering commitment has resulted in a truly exceptional event marked by engaging presentations, productive discussions, and meaningful connections. Your ability to bring together diverse perspectives, expertise, and stakeholders has created a unique and enriching experience, and we all are grateful for your vision and hard work. As we come close to this conference, I would like to take a moment to express my heartfelt gratitude to each and every one of you for your participation, engagement, and contribution. To our speakers, thank you for sharing your expertise, insights, and passion with us. Your presentation has inspired, educated, and challenged us, and we are grateful for your time and efforts. To our attendees, thank you for your active participation, thoughtful questions, and enthusiastic discussions. Your engagement has made this conference a truly enriching experience. To our organizers, volunteers, event and hotel management, thank you for your tireless efforts, dedication, and hard work. Your commitment has ensured the success for this conference, and we appreciate your contribution. I thank the two wonderful Sweet 16 MOCs for sailing this ship smoothly, and I'd like to invite Dr. Deepak to give a token of appreciation to both of them. Invite Dr. Monica. Dr. Karishma. as we depart, let us carry this with our knowledge, connection, and inspiration gained during this conference. May we continue to build on the ideas and relationships formed here, and may we look forward to future collaborations and gatherings. Thank you all.
As we come to the end of this incredible conference and depart, let us remember the power of collaboration, the beauty of diversity, and the strength of our collective spirit.
Before we bid farewell, let's pay tribute to our country, हमारा भारत देश. किसी ने सच कहा है, मैंने ढूंढा बहुत वो जहां ना मिला, मेरे वतन जैसी ना जमी ना कोई आसमां मिला. Ladies and gentlemen, please stand up for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे भारत माता की
Everyone, please proceed for high tea. अब चाय पी के ही जाइएगा.